A very good morning to all the senior faculty, teachers, our seniors and dear delegates. I am Dr. Sarjana Singh
And I am Dr. Padmaja.
and we will be comparing the pre-lunch scientific session today. The first lecture for today's session will be delivered by Dr. Vijaypal Khanagwal, and we would like to invite on stage the chairpersons for this session, Dr. Naveen A., Assistant Professor, JIPMER, Puducherry, Dr. Anil Garg, Professor, BPS Government Medical College for Women, Sonipat, Haryana, Dr. Hitesh Chawla, Professor, GMC, New Mehwat. I request the chairpersons to occupy their seats, please. I'm delighted to introduce Dr. Vijaypal Khanagwal. Sir is the professor and head of Department of Forensic Medicine at Kalpana Chawla Medical College, Karnal, Haryana. With an impressive 34 years of teaching experience and 85 publications to his name, Sir is the medical legal advisor to the Government of Haryana. Sir is the president of GLI AFMS and vice president North Zone IAFM. Sir's accolades include numerous awards for academic activities at both national and international levels. Sir will be speaking on the topic integration of various subjects to forensic medicine in the PG curriculum present scenario. Sir, please.
Respected chairpersons, respected seniors, dear colleagues and friends. I talked to Dr. Dasari about 1 month ago. So he asked me to have a guest lecture on integrated teaching at PG level. And initially I was very reluctant to have lecture on this topic because when I discussed the topic with my other colleagues, their first and last impression is that old wine, new bottle later. Means we are already having integrated teaching in forensic medicine and vis-a-vis the other specialties of medical curriculum. And when I started preparing this topic, then I could see that the MD curriculum, which has been devised under guidelines by the National Medical Commission, Medical Council of India, way back in 2015, the vision document, then competency-based medical education in 2009. So, almost 7-8 days to search the related documents, and I could see the MD curriculum for various specialties, starting from anatomy to medicine, surgery, pediatrics, dermatology, etc. And it was, in my view, it was a very large topic, but I will try to give the comprehensive approach to the integrated teaching of others. Relatively, the discussion will be almost 20 minutes, but may take 5 to 7 more. That's why I requested Dr. Aman to have discussion in the first lecture, because the people will be coming and they will be interacting with us and we will be able to discuss the topic properly. So the topic which was allotted to me by the organizers was integration of various subjects to forensic medicine in PG curriculum present scenario. I prepared the topic under various learning objectives, which are definition of integration, types of integration, integration in PG teaching, and subject-specific learning objectives and quality of a MD in forensic medicine, and importance of integration in postgraduate teaching, present scenario in forensic medicine and other broad specialties, application of integration in postgraduate teaching, the challenges and solution. So it was, as I said earlier, that it was in 2015 when the vision document was prepared by the erstwhile Medical Council of India, and almost the same was adopted by the National Medical Commission, and the National Medical Commission has incorporated integration of medical curriculum for teaching at graduate and postgraduate level, means both the degree courses, with the specific objective of providing knowledge in a holistic way. And the definition of integration, which I could find from net, it is derived from a Latin term, integrate, which means to make whole. In other words, it is coordination of different activities to ensure harmonious functioning. So far as the medical education is considered, integration is bridging connections between academic knowledge and practical, and it is a learning experience that allows the learner to perceive relationship from blocks of knowledge and develop a unified view of its basis and its applications. And though the types of integration could be many, but broadly at UG level it was introduced that there could be horizontal integration and vertical integration. Horizontal integration means the integration of disciplines within a phase. Say if the subject is being taught in the first phase, so integration of the disciplines of the first phase, it will be a horizontal integration. Whereas vertical integration, I am talking about the integration of the subjects at the UG level, which was devised by the National Medical Commission. And vertical integration means integration between different disciplines taught in different phases. As is clear from pointer hai, pointer. As is clear from the pictures, means within the same phase, basic sciences, paraclinical and clinical, within the same phase. And if between different phases, means basic with clinical or paraclinical with pointer, pointer. And it can be understood by this document, which was devised by the National Medical Commission in 2019, and it is vertical integration. The topics are: describe the importance of documentation in medical practice in regard to medico-legal examinations, medical certificates, medico-legal reports, and various other topics. And the vertical integration has been suggested for radio diagnosis, general surgery, general medicine, and pediatrics. So the guidelines which were devised by the National Medical Commission, it mandates that there should be a goal of MD forensic medicine teaching, and I'll enumerate under the 5 points that the MD forensic medicine should be aware of medico-legal aspects in various settings. It is as such copied from the document, and should be aware of contemporary advances and developments, then has acquired competencies pertaining to the subject required to be practiced in at all levels of health system, and is oriented to the principles of a research methodology, and acquired skill in educating and imparting training to medical, paramedical and allied professionals. And it was further made mandatory, and in fact it is a mandate by the National Medical Commission, that after acquiring the PG degree, the forensic medicine specialist should become an expert in the subject, that is expert in forensic medicine, identify and define medico-legal problems, undertake and discharge medico-legal duties and responsibilities in the required settings, then keep abreast with all recent developments and emerging trends in forensic medicine, medical ethics and the law, and should deal with general principles and practical problems related to forensic, clinical, emergency, environmental, medical, legal, and occupational aspects of toxicology. And these are 5, and total number is 10, but incidentally serial number 6 is missing from the original document. Thereby the total number is 9 now. So the doctor should deal, means forensic medicine should deal medical legal aspects of psychiatry, mental health, and drug addiction, and impart education in forensic medicine and toxicology to UG and PG students with the help of modern teaching aids. Then assess the students' knowledge and skills in the subject of forensic medicine and should be able to orient it to research methodology and conduct of the research. So all these are the guidelines which have been devised by the National Medical Commission. Now coming to the topic, integration of various subjects to forensic medicine in PG curriculum. In fact, the integration of forensic medicine and other medical specialties for PG teaching offers a multidisciplinary approach for preparing medical professionals to address legal and ethical issues in their practice. The present scenario is that the importance will be for these 3 points broadly: ethical and medico-legal considerations or issues in clinical practice for medico-legal responsibilities, then interdisciplinary collaboration, promoting teamwork, and holistic patient care, enhancing comprehensive understanding of history and conditions of the patient. The present scenario is that the document about which I was talking, that now guidelines are for competency based postgraduate program. All of us must be aware about this, that now the rotational duties in the first year of PG course, second year and third year is shown in the picture, which is from the erstwhile Medical Council of India, and the same has been adopted, I think, by all the medical institutes in our country, and it is followed by the DRP, that is District Residency Program, and the objectives are to expose and involve the PG student to healthcare services, to acquaint them with the planning, implementation, monitoring and assessment of outcomes of national health programs, and to orient them to promotive, preventive, curative and rehabilitative services being provided by the National Health Mission. Now, the basic sciences and allied subjects, the contents which I could gather from the document of Medical Council of India, that there should be understanding of anatomy parts and organs of the body, then important from medico-legal point of view for conducting autopsies and determining the causes of death in various conditions, then surface and regional anatomy of head, neck, chest and abdomen, then gross anatomy and blood supply of heart, brain, lungs, spleen, liver and kidneys, then gross anatomy of male and female genitalia, comparative anatomy of male and female skeleton, histological examination of various tissues and development of fetus. So broadly all these topics could be integrated with the anatomy department. So far as physiology and biochemistry, I'm talking about the basic integration of basic subjects with forensic medicine. The mechanism of phenomena important in body from medico-legal viewpoint, then mechanism of fluid and electrolyte balance, thermoregulation, then endocrine functions, physiology of sexual behavior, physiological functioning of CVS, digestive system, respiratory system, central nervous system, hemopoietic system, reproductive system, including pregnancy. So far as pathology is considered, though in some of the states the subject is commonly now called forensic pathology. However, the pathology is important so far as integrated teaching with forensic medicine is considered. Pathophysiology of vital processes and various other mechanisms relevant to our specialty. Then pathology of inflammation and repair, immunity, hypersensitivity, etc. Then pathology of myocardial infarction, congenital heart disease, tuberculosis of lungs, cirrhosis of liver, diseases of kidney, tumors, endocrine disorders, venereal disease, intracranial hemorrhages. So I have chosen only the important one and the which I could find that these are the important aspects relating to our specialty. Then pathology of sudden death. So far as integration with microbiology is concerned, application is like common infections and infestations of medico-legal significance, then identifying infectious agents essential in cases of unexplained death, bioterrorism or outbreaks, particularly adverse events following immunization. There comes the role of autopsy in cases where death occurs, and integration of microbiology is relevant at that place, and integration should be training on the role of microorganisms in death, identification of pathogens in postmortem samples, forensic implications of infectious diseases, and dentistry or odontology for age estimation, identification of the individual, dental injuries, bite marks, then mass disaster victim identification, assessment of child abuse and neglect. Radiology, forensic radiology for non-invasive internal examinations and identifying fractures, that is bony injuries, foreign objects like bullets and pellets or other internal injuries, and use of imaging in virtual autopsies. So far as integration of psychiatry and psychology is concerned, the application will be medico-legal aspects of psychiatry and mental health, medico-legal aspects of drug addiction, role of psychiatry in criminal investigation, punishment and trial, responsibility both civil and criminal responsibility, assessing competency, the Mental Health Care Act 2017, determine the causes of death related to psychiatric conditions and psychological autopsies. Gynae and OBS, all the topics which are taught at UG level, starting from virginity, pregnancy, delivery, abortion, infanticide, impotence, sterility, artificial insemination, legitimacy and paternity, assisted reproductive techniques, PCP Act, MTP Act, sexual assault examination including POXO cases, maternal and fetal deaths. Internal medicine, patient's privacy and confidentiality, medical record keeping, consent of the patient, procedure specific, acute completion of death certificate and understanding causes of death. Death certificate, usually most of us must be aware that the cause of death usually noted by the residents in medicine department or surgery department, they write it cardiopulmonary arrest, right? And majority of the times I suggest the HODs of surgery, medicine and other specialties where death occurs, that cardiorespiratory arrest is not the cause of death. It should be the terminal, this is the terminal event. Then chronic disease and forensic applications, impact of chronic diseases on forensic assessments. Pediatrics broadly, child abuse and neglect and sudden infant death syndrome, accident and emergency, identification of medico-legal cases, mandatory reporting of medico-legal cases, assessment and documentation of injuries in live cases, collection and preservation of evidence, and maintenance of chain of custody. And toxicology, the specialty which is taught by forensic medicine and toxicology, as was discussed yesterday. Forensic medicine including toxicology, application is for understanding the effects of toxins, drugs, poisons, critical for forensic investigation, principles of techniques used in toxicological laboratory. Integration means provide training in clinical and forensic toxicology, including methods of detection, interpretation of toxicology reports, and case studies on poisoning. Genetics, the genetic analysis important in forensic identification, paternity testing and understanding hereditary diseases. And integration, introduce training in forensic genetics, DNA analysis techniques and application of genetic data in forensic investigations. So these are the guidelines which are given for our specialty in the NMC document, and I could also search for the guidelines for the other broad specialties, and I could find for 19 or 20 broad specialties including anatomy. These are guidelines for PG curriculum for anatomy department, for biochemistry department, and it is beyond the scope of 20 minutes lecture to discuss all these in details. But broadly, I am trying to show you that as the guidelines are there for MD forensic medicine, similarly there are guidelines for other specialties also from anatomy department, biochemistry, physiology, pathology, pharmacology, ophthalmology, medicine, even psychiatry, orthopedics, obs and gynae, pediatrics, dermatology. And in majority of the competencies or majority of the guidelines are professionalism, ethics for all these specialties. Surgery, pulmonary medicine means medical ethics and legal issues related to medical practice. MD pulmonary medicine, it is given medical ethics and legal issues related to medical practice. So now application of integration in postgraduate teaching. In my view, creating a roadmap for integration of forensic medicine with other medical specialties in postgraduate teaching involves a systematic approach, which can be divided into several key points or key stages, ensuring that the integration is both comprehensive and practical. And the following are the suggested steps. First is identify core competencies, then create modules, then training for the trainers, then integrated clinical rotations that involve exposure to forensic cases within other specialties, then student education, case-based examinations, practical assessments and reflective essays, then program evaluation through student feedback, faculty inputs and outcome analysis. Now the challenges and solution. When I made the discussion on integration, it might have come to the mind of all that what could be the challenges or is it feasible. The challenges are time constraints, integrating forensic medicine within an already packed curriculum, then resource availability, ensuring access to forensic expertise facilities, and resistance to change. As I said in the beginning, that it is old wine in new bottle. So to conclude, the structured approach will provide postgraduate students with a comprehensive understanding of how forensic medicine intersects with various other medical specialties, enhancing their overall competence and preparedness for real-world medical practices, and faculty can use new methods of teaching and learning to make it more interesting. These are the references almost from the official document of NMC or MCI. And I am highly thankful to my assistant professor Dr. Sandeep Kumar Giri, who helped me a lot in preparing this topic for presentation in this conference. Thank you very much.
Any questions? I thank Dr. Vijay for such a nice presentation.
Thank you.
Sir, any hours are fixed for other subject to take classes of our MD forensic medicine?
No, sir. It is nowhere mentioned. Means I am having all the documents. MD anatomy to MD pulmonary medicine, dermatology. But
So
the
it is
rotation
all
which has
optional at present.
the rotation which has been advised for our specialty in first year, second year, third year. It is only for one more specialty, probably in gynae, and it is about posting in some other department for a certain period.
Okay. No, at present we are arranging randomly classes of
in
sometimes
fact-
psychiatry or anatomy.
Sir, in
But there is
fact-
any compulsion that how much classes
in
we
fact-
have arranged for our PG student?
Which we are following in our department. We call the postgraduate students of medicine department and gynecology department relevant to their the relevant topics to them.
No, sir. To send the student there, that is problematic. We can call their lecturer or their professor to cover these topics. That can be allowed in this guideline?
The problem which I faced was that I discussed with the HOD gynae and OPS and she was reluctant कि sir आप ही ले लो. I'll send my students to your department, and you have got a very good demonstration room which is air conditioned, and in hospital they will not be able to be spared during the office hours or means OPD timings, and please take the classes after 4 p.m. and we are following the same.
So the same issue is with the current curriculum, sir. Competencies we have been given that we have to make a rotational posting in secretary also, sir.
Right.
They go to the OPD, but what was the purpose of the posting students, PG students to the secretary was different, but they are doing the OPD services along with the psychiatrist in the OPD, sir.
In fact, which I could find that only the history taking and evaluation part they can learn, RPG can learn, not more than that.
Same is the problem with the DRP training.
Yes. In fact, it is a very arguable question that DRP is not recommended by all, and by this way almost 9 months are lost from forensic medicine department. 3 months for DRP and almost 6 months for the rotational duty. And I should not say at this stage, my PG was on vacation, summer vacation for 15 days, joined on 25th
They are
and went for DRP from 27th.
and they are vacation for 3 months.
For 27th.
What is the role of DRP? Student who is in service candidate, already done job in 6 years as a medical officer. Again we are sending for the DRP population.
So it is the National Medical Commission who has proposed the
We
things.
should raise our voice. We have written letter from our college.
Right.
Person who is already medical officer, who has served in the rural area.
Right.
Still you are sending him and he is not going there as everybody
So in
knows.
fact, in my view, there is no benefit for the student. The student should have some benefit, only then the student should be asked to do certain things. But I don't think that it is very useful for the students. And particularly the MD anatomy student, it goes to for DRP. In fact, in our state, the Director of Medical Education is insisting on the posting of the faculty from basic department, clinical department to clinical department.
If there are no more questions, we can conclude the session. Thank you for a wonderful presentation, sir.
ठीक है वो ऑफ नहीं होता है जल्दी ओके ओके अब किसका
Thank you, sir. We now request the chairpersons to felicitate Dr. Vijaypal Khanagwal, sir. We now request Dr. S.K. Verma, President ICFMT, to felicitate our honorable chairpersons. Dr. Anil Garg, Professor, BPS, Government Medical College for Women, Sonipat, Haryana.
यही है ना कट गया यार एक मिनट हम आंसर ठीक है
Dr. Hitesh Chawla, Professor, GMC, Noor Mehwat. Dr. Naveen A, Assistant Professor, Jipmer, Puducherry.
फैकल्टी में अमनदीप सर का है अमनदीप सिंह गिरा ठीक है ठीक है
Thank you, everyone.
Our next scientific session would be delivered by Dr. Amandeep Singh, and the chairpersons for the same would be Dr. Kunal Khanna, Associate Professor, Kalpana Chawla Medical College, Karnal, Haryana; Dr. Leela Verma, Associate Professor, Dental Medical College, Chandigarh; and Dr. D. Pradhan Middle, Medical Officer, District Hospital, Bathinda. We kindly request the chairpersons to occupy their seat.
कुणाल सर हैं
A few words about Dr. Amandeep Singh. Sir currently serves as the professor at GMCS Chandigarh. With a rich teaching experience of 15 years, Sir has to his credit 60 publications in various national and international journals. Sir served as the ex-editor-in-chief of the Journal of Indo-Pacific Academy of Forensic Odontology and as ex-joint editor of Journal of Punjab Academy of Forensic Medicine. Additionally, Sir is an ex-editorial member of Journal of Indian Academy of Forensic Medicine. Sir has co-edited the textbook of ENT by Dr. B.S. Tully and has authored chapters in 2 other textbooks. Sir is also the resource faculty of Central Bureau of Health Investigation, Central Detective Training Institute and Mahatma Gandhi State Institute of Public Administration. Sir is also the State Awardee of 2020. Sir will be delivering the speak on the topic Introduction to ICD-11. Please, sir.
Thank you, Dr. Padmija. Respected chairpersons, my seniors, my colleagues, my friends. So, I am a replacement for one of our guest faculty who had to cancel last minute. So, I will just talk something about the new thing, that is ICD-11, which has been adopted by Indian government, which is going to replace ICD-10, which was previously being followed. Now, this ICD and its classification and coding of various diseases, this is mainly used by all the clinicians while they are filling up MCCDs. But we will discuss how this has to be incorporated in our subject also. So this ICD, we know that this is a international classification followed as per the WHO audience. There are different types of classification, mainly being the international classification of the disease, that is ICD, which we are discussing. Along with that, there is classification for disability, there is classification of health intervention. So ICD is basically for recording, reporting and conditions and coding for all the conditions which influence the health. So it allows a systemic recording, analysis or interpretation of various diseases occurring in the society. So in the end we get a data for epidemiological prevention or managing health care, and accordingly the government can allocate various resources and also monitor the funds they have already given for some program to prevent such diseases. Now ICD-10 version was being followed all over the world, but it was replaced by ICD-11 in 2022. Now the difference between the ICD-10 and the ICD-11 is that this has shifted from paper book to internet based, that is online version. So making it easy for tech-savvy future doctors, they will be easily accessing all these codes. They don't have to look into various books, the 3 volumes of ICD-10. They will just click upon the net or the website and they can get the code. So India also adopted this same. It was adopted on 18th March 2024. And of course, the training is still being done for the ICD-10 because we still have number of physicians, doctors which don't have the knowledge about ICD coding. So as per the Central Bureau of Health Intelligence, they are training the doctors for ICD-10 only because the difference is only regarding the version, that it is a book and it is online. Rest of the rules and regulation, filling of MCCD as per the ICD rule, that remains the same. So basically it is digitalization of the 3 volumes which were previously there. It is now in a online form. So rules, as I've told you, that the number of codes they have changed, no doubt, but we need not remember as we have to do in case of ICD-10. You just have to click upon the net and you will get the code. So there is no need of remembering any code or looking into the books. So this is how the previously ICD-10 version looked and now the ICD-11 version. There are certain new chapters which have been introduced which was not there in ICD-10. So these were regarding the disorder of immune system which was not there previously, the sleep-wake disorder, condition related to sexual health and certain supplementary chapters. Now how to assess this ICD-11? So I will discuss briefly. This is the URL which can be typed from any computer and you can get the free access. This is free from WHO. You can just access this site on your computer, on your mobile. So no specific username or password is required for this. So you, by filling this URL, you get this, go to this site, and in this site there are 2 versions for searching the codes. One is the browser version and another one is the coding tool. So in this, the browser version, that is blue in color on online, that can be used for browsing for any disease or condition for which you are looking for the code. So this browser has a quick search version, advanced search, and depending upon the tabular browsing also. So this is the place where you will find this browser, ICD-11. Then along with that there is ICD coding tool. ICD coding tool is almost similar. Here also you just can, when you click on this thing, you will get this page on the website, and then when you start filling this, any condition for which you are looking for the code, it will automatically give you the code. So you can see here the code 3A01.0. So this is the ICD-11 code for this disease. So any condition for which, suppose if we are giving a cause of death, hemorrhagic shock. So hemorrhagic shock due to rupture of liver. So if you start typing this, you will get a code for that. So why we as a forensic expert should need to know about this ICD-11? So we know that now MCCD is part of our curriculum. We have to teach students how to write correct MCCD. So for that we need to know what are the rules for writing MCCD, how to choose the underlying condition when we are writing MCCD. So for that we have to look for ICD. These rules are given by the ICD. So for that we need to know the latest ICD rules, how to correctly choose the underlying cause for writing medical certificate for cause of death. Now how we can integrate this ICD-11 in our ongoing work? So there is another cursor or place, ICD-11 API. Now this is again free of cost, where you can link this website to any of your ongoing form or place or any document which you are using in your hospital. So that this site will be linked, the browser or the coding tool will be linked with that ongoing or existing form. So without any cost. So you need not develop any software or anything. So that is also available free of cost by WHO. So if you link this to your ongoing MCCD forms which are being filled in your hospital, So what will happen? There is no separate need of looking for codes. You just link it with your already existing MCT, online MCCD form which your hospital is generating, and when you type, the doctor will type the name of the disease, immediately the code will come in front of this. So no separate software or anything is required. Similarly, this is the form which we are using for generating the postmortem report. In this, almost the last page, we have to write the cause of death. So similarly, if that column is linked with this API, so when we will be typing this cause of death, immediately this code will appear in front of it. And as per the Registrar Journal of India, there is about 20% cases are without any codes, cause of death are without any codes, reason being because they are subjected to post-mortem examination and that data is being lost. So that is not available for any analysis by the government. So if we can help in coding these causes of death, this is going to help in generation of data and that can be used for research as well as analysis. So ICD-11 being online version, it is easy to operate, especially among the tech-savvy youngsters. And MCCD being a part of our curriculum will be better managed by using this ICD-11 version. Integration with various forms, and that also free of cost, can help a better and a faster generation of coding for both mortality as well as morbidity. So both for clinicians as well as for us. And yes, infrastructure do come a hindrance in application, but at the end this version necessarily decrease the workload as well as manpower requirement. These are my references. Thank you.
सर ये इंटीग्रेट हो गया आपके चंडीगढ़ में?
No, abhi MedLeaper, we have to ask the MedLeaper person to integrate it.
हमारा जो मेडलीपर है, हमारे मेडलीपर से बहुत ज़्यादा अच्छा है यार। हमारा वो करवाया है ना, वो हमने एडिट करवाया है।
So you can get this addition also, so that we can code for all these.
पर उसमें क्या कर रखा है इन्होंने कि तीनों स्टेटों का अलग अलग कर रखा है। आप इंटीग्रेटेड नहीं, चंडीगढ़ का सर्वर अलग है, हरियाणा का अलग है। वो क्या कर रहे हैं कि हरियाणा वाला मेन कंट्रोल जो है हरियाणा के पास है, वो हरियाणा में तो
NIC में नहीं है, NIC में है ना सारा का सारा।
The NIC of Haryana has the server for Haryana people. NIC Chandigarh has our data and
बनाया तो इसीलिए गया था ना कि भी इकट्ठा है, कोई ट्रांसपोर्ट हो गया, कोई हरियाणा चला गया तो उसका डाटा उधर चला जाएगा,
कोड नहीं शेयर करता।
और दूसरी सर ये एक क्वेश्चन और कि ये जो आपने कॉज ऑफ डेथ देखा है, हम मैक्सिमम केसों में इसको पेंडिंग कर देते हैं आफ्टर।
for that you cannot. Of course you have to write a disease, only then it will generate the code. But subsequent, if you have, there is also a place for subsequent opinion also in MedLeaper. Of course, most of us are not using that. We are giving on paper. But if we are using that subsequent opinion, we can link it with the subsequent opinion, and then that will generate the final code.
Actually, very good presentation, but I want to ask one thing. Like ICD-11 is the latest classification and India is adopted, but we are following still the old MCCD form, which is not yet adopted. Latest MCCD form came, I think, 5-6 or before COVID, which is adopted by all Western country. So any reason for that?
The reason is that still, as per WHO, they want only the underlying cause of death. They are not expecting that you give code for antecedent or immediate cause of death. There is provision. You can give code for each condition.
No, our MCCD form is old version.
That is why they haven't changed it, because they want that at least underlying cause of death code, they can have it from the previous form if we are still using that. They don't want to actually hinder or increase any workload on anyone. They say that we need the data, and then data only for the underlying cause of death. So that will at least help them in, yeah, some purpose is served, not complete, but at least.
All over India we are having a trainer of trainers. Dr. Amandeep Singh is a trainer of trainer. Okay? He has done the course from Delhi, and he has now become a trainer of trainers. So they are now from trainer of trainers, they are getting the training done to all over India.
Once that is done and you have a uniform this one, then we will use the next one. Oh, because only underlying cause of death is required in that. Sir, the training of ICD-10 started in 2000. India adopted this in 2000 and we still are training, and I think we have just covered 10 or 15% after 24 years. So you can see the delay in the timeline when we adopted ICD-11 around 2 years after its release. So there is delay in, maybe different reasons are there. Hanji sir, Dr. Siddharth.
Just one. You told only the underlying cause of death. Is it the underlying cause of death or the because I thought underlying?
Yeah.
That is what they want. I mean,
Only.
okay.
Code for underlying cause of death. And that is why we need to know how to choose the underlying cause of death. That is given in ICD-10.
Yeah, that I understood. So immediate and antecedent वो सब नहीं चाहिए.
नहीं, आपने लिखना है, कोड नहीं चाहिए उसके लिए उनको.
Okay.
They need code for only
अच्छा,
the
code for
underlying
only
cause.
the underlying cause of
Yes.
death. Okay, right. Thank you, sir. Thank you.
Thank you. Thank you.
We now request the chairpersons to felicitate Dr. Amandeep sir. We now request Dr. Ashok Mundra, Professor and Head GMC Kota, to felicitate our honorable chairpersons. Dr. Leena Verma. Dr. Kunal Khanna. Dr. Deep Ratan Mittal. Deep, sorry. Thank you, everyone.
The next lecture will be delivered by Dr. Rajiv Joshi, and I would like to introduce the chairpersons for this session: Dr. Davinder Atal, Professor and Head, Government Medical College, Faridabad; Dr. Kuldeep Kumar, Associate Professor, PGIMS, Rohtak; and Dr. Mohit Chauhan, Assistant Professor, LHMC, New Delhi. We request the chairpersons to occupy their seats. I'm delighted to introduce Dr. Rajiv Joshi. Sir is the Professor and Head of Department of Forensic Medicine at Guru Gobind Singh Medical College, Faridkot. Sir is also the Controller of Examinations, Baba Farid University of Health Sciences, Punjab, and the current President of the PAFMAT. Sir was also the ex-principal and ex-superintendent of Medical College, Faridkot. Sir has a rich experience of 21 years in teaching and has authored 45 publications in national and international journals. Sir will be speaking about the new guidelines of the NMC.
आ गया खोल के देखो नहीं भी चला देते हैं क्या हो गया
वो चेक कर
लास्ट में बोलना बस लास्ट में बस हो गया Good morning everyone, respected chairperson, my senior colleagues and my dear colleagues. I was assigned a topic of new guidelines of NMC to improve medical education by my honorable Dr. Dasari Harish. I am happy Dr. Vijay Khanepal sir has already covered regarding the post-graduation part regarding integration, and this is a very broad topic regarding NMC, and I am touching some part of that. And second problem is that the NMC is changing guidelines every year. So this is again very difficult part. In yesterday also, they have changed the guidelines regarding new session about 24. I try to incorporate this also in this slide. So I will start with the part from the competency based part. So National Medical Commission got presidential assent on 8 August 2019, an act to provide for a medical education system that improve access to quality and affordable medical education, ensure availability of adequate and high quality medical professional in all part of country, that promote equitable and universal health care, that encourage community health perspective and make service of medical professional accessible to all the citizens. So they change from traditional curriculum to CBME curriculum, competency based medical education. The new graduate medical education regulation attempt to stand on the shoulder of contribution and the efforts of resource person, teacher and student, past and present. It intends to take the learner to provide health care to the evolving need of the nation and the world. The thrust in the new regulation is to continuation and evolution of thought in medical education, making it more learner-centric, patient-centric, gender-sensitive, outcome-oriented, environmental appropriate. Result is an outcome-driven curriculum which conform to the global standard or trends. So what are the objective of IMC, Indian Graduate Medical Training Program? So IMG possessing requisite knowledge, skill, attitude, value and responsiveness so that he or he may function appropriately and effectively as a physician of first contact of the community while being globally relevant. So what are the goals for the learner? In order to fulfill this goal, the Indian medical graduates must be able to function in the following role: a clinician who understands and provides preventive, promotive, curative, palliative and holistic care with compassion, communicator with the patient, family, colleagues and community, leader and member of the healthcare team and system with capability to collect, analyze, synthesize and communicate health data appropriately. Then lifelong learner committed to continuous improvement of skill and knowledge, professional who is committed to excellence, is ethical, responsive and accountable to the patient, community and profession, critical thinker who demonstrate problem solving skill in professional practice and researcher who generate and interpret evidence. So what is the competency-based training program of the Indian medical graduate? It would include designing and implementing medical education curriculum that focus on desire and observable ability in real life situation. In order to effectively fulfill the role, the Indian medical graduate should have obtained following set of competency: a clinician who understands and provides preventive, promotive, curative, palliative and holistic care with compassion, demonstrate knowledge of the normal human structure, function and development from a molecular, cellular, biological, clinical, behavior and social perspective, demonstrate knowledge of normal human structure, function and development from a molecular, cellular, biological, clinical, behavior and social perspective, demonstrate the knowledge of medico-legal, societal, ethical, humanitarian principles that influence healthcare, demonstrate the knowledge of national and regional healthcare policy, include the National Health Mission that incorporate National Rural Health Mission and National Urban Health Mission, framework, economics and system that influence health promotion, healthcare delivery, disease prevention, effectiveness, responsiveness, quality and patient safety. Then leader and member of healthcare team and system, the person should work effectively and appropriately with the colleague in an interprofessional healthcare team, respecting the diversity of the role, responsibility and competency of the other professional, recognize and function effectively, responsibly and appropriately as a healthcare team leader in a primary and secondary healthcare setting, educate and motivate other members of team and work in a collaborative and collegial fashion that help maximize the healthcare delivery potential of the team. Then he should be communicator with the patient, family and colleague and community, demonstrate ability to communicate adequately, sensitively, effectively and respectfully with the patient in a language that patient understand, demonstrate ability to establish professional relationship with the patient and family that are positive and understanding, demonstrate ability to communicate with patient in a manner respectful to the patient preference, value, prior experience, belief, confidentiality and privacy. Lifelong learner demonstrate ability to perform objective self-assessment of knowledge and skill, demonstrate ability to apply new gained knowledge or skill to the care of patient, demonstrate ability to introspect and utilize experience to enhance personal and professional growth and learning. The professional who is committed to excellence is ethical, responsive and accountable to the patient, community and profession, practice selflessness, integrity, responsibility, accountability and respect and maintain professional boundary between patient, colleague and society, demonstrate ability to recognize and manage ethical and professional conflict. So what is competency-based medical education? As all know, just is a revision part. It's a competency-based medical education, outcome-based education, usually involve all specialty together and better implemented in problem-based education system. Since in India we have many subject teaching, it's proposed to have a competency-driven approach in existing system-based format with integration. Integration we have discussed earlier. So what is the difference between traditional system and competency-based system? So in traditional system, there's a driving force for curriculum is content, knowledge and acquisition. In competency is outcome, knowledge and application. Then driving force in traditional is a teacher, competency based it's a learner. Path of learning is teacher, hierarchical, there's a teacher student in competency based. Responsibility for the content in structure and process based is teacher. In competency it's a student and teachers combination. Goal of education encounter knowledge acquisition, there's a knowledge application in competency based. Then typical assessment tool is a single subjective measure. You all know in competency based there's a multiple objective measure, evaluation, portfolio. There are so many method of assessment in competency based. Assessment tool is proxy. There's authentic, mimic real task of procession. Evaluation is norm reference. There's a Cartesian reference. Timing of assessment, emphasis on summative The competency basis emphasis on formative assessment. Then program completion, fixed time, it's a variable time. The person has to be competent for that competency. How will you achieve competencies? Again, we have read in medical education programs. So this is start from the knowledge, know, knows how, shows how, and does. So phase-wise training and time distribution for professional development. Competency-based undergraduate curriculum ATCOM course as published by NMC and made available on Council website shall be curriculum for the batches admitted in MBBS from academic year 2019-20 onward. In order to ensure training is in alignment with the goals and competency required for medical graduates, there should be foundation course, to orient medical learner to the MBBS program and provide them the requisite knowledge, communication, technical and language skill. So these are the new teaching or learning element. Then first is start with the foundation course, then early clinical exposure, electives are added, professional development including attitude, ethics and communication modules, ATCOM, learner, doctor, method of clinical training, clinical clerkship and assessment. So latest curriculum for the MBBS program, the training period and time distribution. First professional year must commence through the foundation course by 1st August of each year from the academic year 2024-25. Foundation course aim to orient medical student to undergraduate MBBS course and provide them with the knowledge, communication, technical and language skill. There shall be no admission of the student in respect of academic session beyond 30 August from the academic year 2025. This will be elaborated later on in last slides. The duration of the MBBS course shall be same 4.5 years divided into 4 professional years from the date of commencement of course to date of completion of the examination, followed by 1 year of compulsory rotating internship. There will be at least 39 teaching week in each academic year with each day of work requiring no less than 8 hours including one for lunch. Didactic lectures are allowed to make up no more than 1/3 of timetable. Other 2/3 must include interactive session, practical, clinical or group discussion. Theory part is shortened. For greater student comprehension, teaching and learning must be vertically and horizontally linked as discussed by Honorable Vijay Kanakwal sir, and link and integrated across specialization. Early clinical exposure, problem-oriented learning, case study, community-oriented learning, self-directed, experimental learning, elective should be included in learner-centered curriculum. University exam will be conducted at the end of every professional year. There will be supplementary exam in case the student failed to clear the university examination, and supplementary examination results shall be processed within 3 to 6 weeks. Again, it is shortened to 2 to 4 weeks from the declaration date of the main examination. There will be no supplementary batch. Hence, if any candidate fail the supplementary examination, will have to join the next or subsequent academic year batch. Mean if the person fail in supplementary examination, it will go to the junior batch. The partial attendance in an examination shall be counted as an attempt. So this is previous up to the 23rd. The first professional year contained anatomy, physiology, biochemistry. Second, pathology, microbiology, pharmacology. Third, in up to 23rd, forensic medicine, toxicology, community medicine. I and ENT comes in the part 2. This is a medicine allied subjects, general medicine, psychiatry, dermatology, surgery and allied subjects, rehabilitation, ophthalmology, ENT, orthopedics, etc., pediatrics. So this is the foundation course, the teaching hour. The orientation is a 30 hours, skill module 34, field visit to community health center 8 hours, introduction to professional development 40 hours, sports, yoga and extracurricular activities 16 hours, enhancement of language 32. So total 160 teaching hours for the foundation course. Then phase-wise distribution of teaching hours. So for the first, second, third professional, it's a time allotted 12 months, time available 39 weeks, 39 hours per weeks, university exam result 9 weeks, vacation 2 weeks, public holiday 2 weeks. This is all from the NMC part. Teaching hour for the final MBBS part 2, 18 months, time available 62 weeks, then vacation 3 weeks, public holiday 3 weeks. So it's a 2, 4, 1, 8 hour available on teaching learning methods. Mark distribution again up to 23rd. For university examination, there shall be 2 theory paper of the 100 marks each and practical examination 100 marks each for all MBBS subject of first, second and third part 1 except FMT. Forensic medicine toxicology subject comprise 1 theory paper of 100 marks and 1 practical examination 50 marks, which now revise up to again in 24 100 marks. Exam of the final MBBS exam shall be as per next regulation. Elective on topic in areas such as research methodology, use of artificial intelligence, computer in health and medical education, health management, health economics, Indian system of medicine, medical photography, art and music in medicine, literary activity may be provided by the college. Based on the both elective, learner is required to submit a learning logbook. 75% attendance in the elective and submission of logbook maintained during elective is required for eligibility to appear in the final MBBS examination / next. Eligibility to appear for the professional examination. For a student to be eligible to sit for the examination, there shall be minimum 75% attendance in theory, 80% in practical. Student will not be permitted to take the third professional part 2 examination if you do not have at least 75% attendance in the elective. Internal assessment include participation in the learning process, including assignment, preparation for the seminar, clinical case presentation, preparation of the clinical case for discussion, clinical case study, problem solving exercise, participation in project for healthcare in community, competency and skill marked in daily record and logbooks are considered for the internal assessment evaluation. There must be minimum of 3 internal assessment for each topic in first and second professional year, minimum of 2 assessment for each subject in third and final professional year. Each clinical posting in a given professional year must have posting clinical assessment done. To be eligible to appear at the final university examination for a given subject, student must receive at least 50% of total mark combined in theory and practical and clinical, not less than 40% in theory and practical separately for the internal assessment. Just for appearing in the university examination, they will not be added in the examination ward. The result of the internal evaluation will be counted toward a distinct head of passing the final test. University examination result, you all know that this is include long answer question, short answer question, objective type question. Viva oral examination evaluate the candidate approach to patient management, emergency preparedness, attitude, ethics, professional value, ability of candidate to read standard investigation data, X-ray, ECG. If the subject has 2 theory paper, learner must receive at least 40% aggregate of the possible marks on the combined total of 2 paper to pass the subject. Candidate must receive 50% aggregate marks and 60-40 ratio minimum or 40-60 ratio in a university conducted examination taken separately for theory and practical, which will include Viva and practical, in order to declare as pass in that subject. There shall be no grace mark to be considered for passing an examination. It has been abolished. A candidate cannot enroll in second professional if they fail the first professional examination. Candidate who fail the second professional examination may enroll in third professional part 1 training, but he or she may not sit for examination until second professional examination has been passed. Candidate who does not pass the third professional test will be permitted to enroll in third professional part 2 training, but he will not be permitted to sit for the examination until second professional examination has been passed. So I just talk about the FMT part and outcome. This is the division for the lecture, SGL, SDL and total for the second MBBS part. Then part 3 again for the FMT part, lecture 40 hours, SGL 70, SDL 20, 130. Then this is mark distribution for the final, theory 100, paper 1 and practical 50 up to 23rd. Mandatory to get 40% marks separately in theory and practical and total 50% for theory plus practical. So how will you keep the attendance record of the student? This is also required. So you can keep the attendance record in this way as the duration of 3 months, 6 months, 9 months, 12 months, attendance theory percentage. You have to display this theory percentage. You have to take the signature of the student and you also mark this your signature, and above information for the benefit of the student and parents. In case of any discrepancy, department record will be treated as a final. Then detail of attending extra classes. This is again discussed yesterday. If the person has acquired 60% attendance, then you can take a remedial measure in form of attending extra classes for that student so that he or she can appear for the final examinations. So you can take extra classes for the poor attendance if the person has acquired 60% attendance. For 75% you can take extra classes. So internal assessment shall be based on day-to-day assessment, relate to different way. I already discussed preparation of seminar, clinical case, preparation of clinical case for discussion, carrying out a practical skill in small research project or written test. Regular pedagogical examination shall be conducted throughout the course. Again, we have discussed already. When subjects are taught in more than one phase, the internal assessment must be done in each phase and must contribute proportionately to the final assessment. General medicine must be assessed in second professional, third professional part 1, third professional part 2 independently. Day-to-day record and logbook should be given importance in internal assessment. Internal assessment should be based on competency and skill. Final internal assessment in broad clinical specialty shall comprise of marks from the constituent specialty. It is also discussed yesterday. In surgery, you have to count the orthopedics also, anesthesia also. And the proportion of the marks of each constituent specialty shall be determined by the time of instruction allotted to each. Learner must acquire at least 50% marks of the total marks, not less than 40% marks in theory and practical separately for internal assessment. Result of internal assessment should be displayed on the notice board within 1 to 2 weeks of the test. University shall guide the college regarding formulating policy for remedial measure for students who are either not able to score qualifying mark or have missed or some assessment due to any reason. So this is the internal assessment theory part per forma. How can you calculate the internal assessment? How can you mark the internal assessment? You can take class tests, you can take seminar, museum study, library study, home assignment. So you can calculate the internal assessment on that basis, and this has to be kept in the record. Again, this is for the practical part, skill-based competency, ATCOM, lab activity, journal record book. This is undergraduate part only. University examinations are to be designed with a view to ascertain whether the candidate is required to necessary knowledge, minimum level of skill, ethical and professional value, with a clear concept of fundamental, which are necessary for him to function effectively and physician of first contact. Assessment shall be carried out on an objective basis to extent possible. University examination shall be held. First professional examination should be held at the end of first professional training. This we have discussed earlier. The appointment of the examiner, person appointed as examiner in particular subject must have at least 4 years. Again, curtailed to 3 years in 24. For total teaching experience as assistant professor after obtaining postgraduate degree in subject in a college affiliated to the recognized medical college. For practical examination, there shall be at least 4 examiners for every learner. Even if the supplementary student, if there is a single supplementary student, the 4 examiner has to be called. Out of whom not less than 50% will be external examiner. 4 examiners, senior most internal examiner shall act as a chairman and coordinator of the whole examination program, so that the uniformity in the matter of assessment of candidate is maintained. You all know the C form is there. University having more than one college shall have separate set of examiners for each college, with internal examiner from the concerned college, external examiner may be from the outside the college. University state, there shall be chairman of the board of paper setter, who shall be internal examiner, shall moderate the question. All eligible examiner with qualification and experience shall be appointed internal examiner by rotation in their subject. All theory paper assessment should be done as a central assessment program of the concerned university. This is the new guideline 25 to 26. This is academic calendars for phase 1 examinations, phase 2 examination, phase 3. This is yesterday event part. So new initiative. Every college shall arrange for a meeting with the parents, wards of the all students on record of the same available to the undergraduate of the NMC. Mentor-mentee program carried out judicially with the ratio of 1 mentor to 3 mentees. Mentor may be selected from our discipline from the level of professor, HOD to assistant professor. Mentor shall be allotted his mentee during the foundation course. The mentee shall stay connected with the mentor through his career till he complete CRME. Each year when 3 new mentees are added from phase 1 to mentor, senior batch support the junior student and create a healthy sibling environment. This is a family adoption program. Internal assessment, both subjective and objective assessment. Internal assessment not to be added to the summative assessment. Internal assessment in absolute mark displayed under separate column detail marks. Internal assessment for each subject shall be out of 100 for theory and out of 100 for practical, except in general medicine, general surgery, ops gynae, where it is 200 marks. For subject that teach in more than one phase, cumulative internal assessment to be used as eligibility criteria. Final cumulative marks are to be used for eligibility. So this is how they are divided in the phase wise internal assessment. For forensic medicine, just we are teaching in 2 phases. So it divided as a 25 marks in phase 2, 75 marks in phase 3 part 1. Final cumulative is 100 for theory and practical. Similarly for the community medicine, 25 marks in phase 1, 25 marks in phase 2, 50 marks in phase 3 part 1. final is 100. Ophthalmology and ENT divided as a 25 marks in phase 2, 75 marks in phase 3rd, part 1, final is 100 for theory and practical. General medicine 200 marks as discussed earlier, phase 2 50 marks, phase 3 part 1 50 marks, phase 3 part 2 100 marks. Then phase 3 part 2 100 marks divided as medicine as 75 marks, medicine as 75 marks, psychiatry as 13 marks, dermatology as 20 marks. So added allied parts is also given importance. Final cumulative IA for medicine out of 200 marks for theory and practical each. Similarly in general surgery, phase 2 25 marks, phase 3rd part 1 25 marks, phase 3rd part 2 150 marks. Again 150 marks divided as general surgery 75 marks, orthopedics 50 marks, anesthesia 13 marks, radiodiagnosis 12 marks. So final cumulative is 200 marks. Attendance requirement 75% for theory, 80% for each component. Remedial measure we discussed. After regular examination batch, if the attendance is more than 60% for of the student, then you can take the remedial measure so that the student does not suffer and he or she can appear for the final examination if the person has more than 60% attendance. So this is university examination phase 1, anatomy, physio, biochemistry, theory 2 paper 100 marks each, practical 100 marks. Patho micro in phase 2, theory 2 paper 100 marks each, practical 100 marks. FMT, no, again ENT I included in that part, again theory 100 marks, practical FMT again 100 marks from 50 to 100 marks. Community 2 paper 100 marks, practical 100 marks. Medicine 100 marks, 2 paper, practical 100 marks. Theory 1 paper, pediatrics 100 marks, practical 100 marks. 40% marks separately in theory and practical, but total it's a 50%, theory plus practical. Medicine light paper 2, psychiatry 25%, derma 25% in paper. Surgery and light paper, orthopedics 40%, anesthesia 10%, radiodiagnosis 10%, 1/4 examiner is from the orthopedics. So this is all about the new guidelines of the NMC. Thank you very much. हाँ जी सर.
आपने एक चीज कहा था कि यदि स्टूडेंट
हाँ जी ओन है.
If the student has acquired 60% attendance,
more than 60%
attendance, then to help him complete up to 75, we take extra classes.
Yes.
Is this mandatory or is this discretionary?
It's mandatory by said by the NMC during the study meeting.
So question is, if the student has defaulted, why should the faculty suffer?
This is the guidelines of NMC. I cannot say anything regarding this. They want the students should not suffer if they require more than 60%.
The faculty may go to hell.
Sir, nothing about faculty. This is all student-driven curriculum. क्या होगा? After regular examination of batch. नहीं after regular examination के बाद ही हम उसको लेंगे ना क्लासेस, तो एक्स्ट्रा क्लासेस तभी लेंगे ना, कंप्लीट हो गई है उसकी. अब उसके बच्चों के 60% से ऊपर है तो आप उसकी एक्स्ट्रा क्लासेस ले सकते हैं ताकि वो 75% आए.
सर किस तो बाद आफ्टर रेगुलर एग्जाम सर?
नहीं, दिस इज क्लैरिफिकेशन, इसमें थोड़ी सी दिक्कत है, क्लैरिफिकेशन दिक्कत है.
रेमेडियल मेजर्स आफ्टर रेगुलर एग्जाम्स.
नहीं सर, इसमें क्लैरिफिकेशन की दिक्कत है, ये थोड़ा शायद गलत हो गया, लेकिन इसका यही मतलब यही है कि आपको उसको 75% करना है ताकि उसका सप्लीमेंट्री में ना जाए वो बच्चा.
You are right.
I am saying slides may be written as wrong, but it is very clear. Understandable. We have discussed about that. You have to change the remedy.
Then we do one thing, that we don't take attendance और सबको 75% दे के छोड़ देते हैं. जिसने क्लास में आना है, जिसने क्लास में नहीं आना है,
आप रिकॉर्ड तो मेंटेन करना पड़ेगा.
वो हम महीने सर रिकॉर्ड
जिस बच्चे ने 50% लिया है उसको नहीं वो कह रहे.
सर रिकॉर्ड तो हम मेंटेन कर देंगे, बच्चे आए ना आए रिकॉर्ड मेंटेन हो जाएगा.
सर
और क्या, रिकॉर्ड ही तो मेंटेन करनी है यार.
सर जो कल वाला है ना, कल वाले में पूरा 2 पेज का वो है डिटेल.
यही है कल वाला, यही है
पूरी डिटेल है.
यही है कल वाला. यही है कल वाला. आपको रिकॉर्ड साइन भी करवाना है, वो आपको बोलेगा, स्टूडेंट बोलेगा, उसके पेरेंट्स से भी बात करनी है, अपनी अटेंडेंस मेंटेन करनी है उसकी। दैट इज व्हाई छोड़ देते हैं सर, ये तो बातें अलग है। इस बातों को तो मैं आंसर नहीं दे पाऊंगा, इन बातों का नहीं आंसर दे पाऊंगा। वो बेसिकली स्टूडेंट के लिए काम कर रहे हैं, अभी टीचर के लिए काम नहीं कर रहे हैं।
सर उसमें लिखा है सर, नॉट इन एक्स्ट्रा क्लासेस, रेमेडियल मेजर्स बट नॉट इन एक्स्ट्रा क्लासेस, कल वाले में लिखा है सर।
चलो देखते हैं, लेट्स सी।
So the topic is actually, the presented topic is very vast and actually require a great discussion. So I think it is not the right time to discuss so much in detail. Thanks for the wonderful presentation. Thanks.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir. We now request the chairpersons to felicitate Dr. Rajiv Joshi. We now request Dr. Ajay Kumar, Additional Professor, AIMS Bathinda, to felicitate our honorable chairpersons. Dr. Davinder Atal, Professor and Head, GMC, Faridabad. Dr. Kuldeep Kumar, Associate Professor, PGIMS, Rohtak. Dr. Mohit Chauhan, Assistant Professor, LHMC, New Delhi. Thank you, everyone. We now request everyone to proceed for the tea break, and after that we will continue our remaining session. South Africa, Brazil, Australia, US and Philippines. Sir's contribution has been recognized with awards from UGC, WHO, International Academy of Pathology and Indo-Pacific Association of Law, Medicine and Science, Australia. Sir will be delivering a lecture on the topic New Penal Codes and Overview in relation to medical practice. Thanks.
Good morning, everyone. Thank you, the chair, for this opportunity to speak on this topic. The latest of the amendments or the changes in the penal codes, more of academic interest in relation to the penal codes being as a taught punishment to justice, as in penal code to the Nyaya Sanhita. So the basic underlying theme from punishment to justice. The Bharatiya Nyaya Sanhita 2023, changing from the IPC 1860, focuses more on restorative justice. Nagrik Suraksha Sanhita, replacing the CRPC, which was initially formatted in 1882, then amended in 1898, then the latest was 1973 version. It introduces many procedural reforms. The Bharatiya Sakshya Adhiniyam, Indian Evidence Act 1872. It modernizes evidence rules, includes digital evidence. The background, just to understand what was the need for change, as has been promulgated, as was discussed in the parliament. The draft was originally formulated in 1834 by Macaulay, who had made such statements like that of 1857. These were revised broadly by Barnes Peacock, who was supposedly the first Chief Justice of the West Bengal courts, who supported the annexation of states, stood by the Governor General throughout the Indian Mutiny, and introduced summary punishment for contempt of courts. So that was the basic background, who formulated it, who revised it, to understand what was the genesis of these courts. So years after the mutiny, 1860, then a few years later, IEA and CRPC were formulated, and CPC came later. Almost the similar implementation was there in all of the British colonies. Like so you would find the similar code, even verbatim, and even the sections are same in all of these countries. Removal of adultery, so to say, unnatural offences, attempt to suicide, and seditions. The 511 sections have been reduced to 358 sections. There are addition of 31 sections, deletion of 19 sections, increased imprisonments in 41 sections, hiked penalties in 82 sections, minimum prisons have been prescribed. Earlier, where there was no minimum prescription of punishment, a minimum prescription has been there in 25 sentences, and community service has been prescribed in 6 offences. Key issues, another, night has been replaced with after sunset and before sunrise, wife has been replaced with spouse. There are some discrepancies there. Removal of age-based parameters are there in some cases. Adoption of technology and digital media are there. Murder or attempt by life convict, which was struck down by the Supreme Court, has been reintroduced with some variations. Transgender term has been introduced. Imprisonment for life has been defined. Age for sexual consent for married women has been raised, which was earlier 15, now raised to 18. Fake news has been included. Overlapping of offences are there in some cases. As a undercurrent, the adultery was removed, but still it has been introduced by another terminology. Scope of community service is still not clear. Some definitions are too broad, some lack clarity. Age threshold varies in many cases. There is duplication of offences. Unnatural sexual offences are unclear, and mob lynching confusion still remains. BNSS, the CRPC or the procedural code, detention punishable by life imprisonment, and anyone charged with more than one offence. So these have been stated as exclusions for this, but still what will be applicable is still not very clear in that. Key reforms in the evidence code: documentary evidence, oral evidence defined, electronic records or evidence have been defined, secondary evidence has been defined, and joint trials have been defined. Coming to the specifics, I have slightly included the major ones, and according to certain groupings. Some definitions: animal, child, death, document, gender, which includes transgender, injury from 44 to here, definition of life, definition of man and women. Then certain punishments. Punishments include death, imprisonment for life, imprisonment, rigorous imprisonment, hard labor, simple imprisonment, forfeiture of property, fine, and community service. Community service, what is not defined? It is broadly defined that it will not be payment based, it will not include any remuneration, it will be for the benefit of community, but how and what time, and that is not yet there. Imprisonment for life is imprisonment for 20 years. For child, nothing in offense under 7 years, that's included. Nothing is offense child above 7 years, under 12 who has not attained maturity. Unsoundness of mind, those sections 88, 90, etc., those come here. Intoxication and omission for PI, 6 months, up to 6 months. Then the sexual offenses, rape, exception, wife has been age has been increased from 15 to 18. Punishment for rape, 10 years to life. Aggravated, I have used the word aggravated, these all are the old custodial ones. And less than 16 years, 20 years to natural life. Less than 12, 20 years to death. Vegetative state, 20 years to death. Separated wife, 2 to 7 years, minimum 2 years. Custodial intercourse, not amounting to rape, 5 to 10 years. Deceitful intercourse, that is a new one, so to say that it addresses the certain religion-based or deceitful things. Gang rape, less than 18 years gang rape, repeat rape, identity disclosure of a victim, outraging the modesty, sexual harassment, disrobing. Disrobing is gender neutral, and voyeurism, again gender neutral, stalking and insulting the modesty of a female. Then coming to the relating to death, dowry death shifts to a separate section. Cruelty, miscarriage, culpable homicide, murder, all those 300 series ones. Murder, punishment for murder, life. This was struck down earlier by the Supreme Court, now it has been added. It was struck down in the sense that it prescribes a punishment only of death. Supreme Court said judiciary must have a prerogative of what to decide, so they have given from life to death. Mob lynching, culpable homicide not amounting to murder, rash negligent act, death. This is again being contested by the IMA and all doctor community. Death by rash negligent act, less than 5, up to 5 years imprisonment, and for a registered medical practitioner, up to 2 years. Here also there is a twist into this in interpretation. The doctor or registered medical practitioner only is a allopathic practitioner, not the homeopaths, not the Ayurveda practitioners, not any other doctor. So only for medical practitioners, allopaths. 1062, by driving vehicle up to 10 years, that has been kept in abeyance after the recent strike by the transport community. So this has been kept in abeyance. Abetment to suicide, attempt to murder. The injury clauses, 320 onwards, 319 onwards, 319 hurt, bodily pain, that remains the same. Simple hurt, grievous hurt. The punishments have been slightly changed, the sections from जो 23 से 26 वाले थे वो सारे sequence change हुए. Otherwise most of them remain the same. The acid attack has been given a separate section. So all those injury related. Then the court related of the Suraksha Sanhita or the procedural. In the procedural, cognizable, non-cognizable, summons case, warrants case, who is the victim has been defined. 2Y, person who has suffered any loss or injury. There have been certain clarification that the word victim should not be used in case of sexual offences. A survivor word has been used, but that has not been addressed in this. 6 classes of criminal courts have been defined: courts of session, judicial magistrate, first class, second class, and executive magistrate of different things. High court may pass any sentence authorized by law. Sessions or additional sessions may pass any sentence authorized by law, but death sentence subject to confirmation by High Court. Chief Judicial Magistrate, any sentence up to 7 years. Magistrate first class, sentence up to 3 years and fine up to 50,000 and community service. second class up to 1 year, up to 10,000, and community service. Summons in writing, in duplicate, signed, sealed, and can be electronic also. That's an addition that they can be electronic. And summons can be served with address, with email, by phone, either personally or electronic, and the receipt may be taken on the back. So in the procedure for medical things, the 53 section is 51. For an arrested person, arrested female, what examination would be there, what examination parts are there. For an arrested rape accused, even force can be used, all the same things. Person arrested has to be first examined by a medical officer, medical examination of victim of rape, then the inquest, 194 and 196. Earlier there was a specific term that judicial magistrate was introduced in the amendment 2005, but as discussed in earlier, the magistrate would include only the judicial magistrate, or it includes executive magistrate to be lawful, or disclosure of identity thing. Then again, police information of an offense, then deposition of 326(1), deposition of medical witness taken and attested by a magistrate may be given in evidence at any inquiry, trial or proceeding without the need of the medical officer appearing again for that. Document pertaining, that's the same government scientific expert, not yet applicable to the medical officers. 329(3), a specific new addition. The HOD can depute any responsible officer working with him to attend the court. Again, government scientific experts is the same. Then the last one, document or report prepared by medical officer, transferred, retired. A person who has transferred, who has retired or has died, cannot be found, or there is a delay in those such cases, or in routine, no medical officer shall be called to appear in the court unless the report is disputed, and the deposition may be allowed through audio, video, electronic means. They have not specified how, so whatever means they find suitable. Nowadays, mostly on WhatsApp, video conferencing also it is occurring, so that's okay with that. For the Sakshya Adhiniyam, the dying declaration shifts to 26A. Opinions based on point of person specially skilled, or the expert, who is an expert, that's defined. Certified copies, how they are to be attested, that's the same. Examination of witness, what it includes, what is a leading question, where it can be asked, how it can be asked. Refreshing of the memory by the witness. The last three, prosecution of offense of rape, evidence of character of victim, previous sexual experience not relevant, court said presumed she did not consent, and again question of such cannot be asked, that's again the same. So key changes, medical negligence, there is some vague change into that. Patient rights have been certainly addressed somewhat to an extent, but still not clear. Professional liability has been a focus, but again, in how, that's still to be seen. Negligence per se has been a topic of great discussion. 106 corresponds to 304A, causing death by negligence imposes punishment up to 5 years normally, but for a case of doctor, 2-year punishment is there, with fine or not. And the explanation says only a registered medical practitioner under the NMC Act. So it is only applicable to an allopath, not to the Indian systems of medicine, homeopaths or the dentists. Medical documentation should be meticulous in the sense that it is much more appreciable now. extended police custody has been provided in many cases. Procedural changes are there for faster implementation. Increased accountability and ethical responsibilities have been much more stringently placed. That were the key points. Just to stay informed and be prepared for more and more implementation of the act over the period of time. Police have begun to bring the newer cases into such issues, and hopefully we'll also gather more from as we proceed. Thank you, everyone. Sarji. So,
Cases to be registered under 377. What is the option available for the? What do you think that where should the police look
sir,
for?
कौन से वाला केस? केड़े वाला केस?
377 में
377
without consent.
Without consent would go into assault.
And bestiality.
Assault. वो तो एनिमल वाले पे भी आ जाएगा. मिसडिमीनर मिस.
Cruelty to animals only with maiming or
हाँ.
killing animal.
मेमिंग है उसमें. हाँ.
इसमें maiming नहीं है, killing नहीं है. That's an issue.
हाँ.
Sir, in new BNS 377 is deleted.
हाँ. उसको और कहाँ लेके जा सकते हैं?
So basic purpose of 377 was to protect the male child against the sexual assaults, and that is covered under the POCSO.
Below 18, more than 18 का.
वो 18 का.
More than 80 का तो सर उन्होंने लीगलाइज कर दिया था. सुप्रीम कोर्ट.
सर धक्के से थोड़ी लीगलाइज्ड है.
नहीं, उसकी डेफिनेशन ही ये थी सर, वॉलंटरी कार्नल इंटरकोर्स. धक्के से नहीं, that was a consented only. पर consented was also not legalized till the Supreme Court judgment. नॉन कंसेंटिंग 377 में कवर ही नहीं होती थी. उसमें तो
क्यों नहीं होती थी?
उसकी डेफिनेशन ये थी, वॉलंटरी कार्नल इंटरकोर्स अगेंस्ट द नेचर.
There was no voluntary. Only it is there.
सर आप आईपीसी खोल के देख लीजिए, उसमें वॉलंटरी वर्ड पहले है. स्टार्ट सेक्शन वाज स्टार्टेड फ्रॉम दैट वॉलंटरी कार्नल इंटरकोर्स अगेंस्ट द नेचर.
चलो
ये तो गूगल बाबा खोलना पड़ रहा है. वो नई चीज है ना, तो नई चीज तो खोलना पड़ेगा ही.
हाँ. Thank you, everyone.
Sir, thank you for such an informative one. And ये इसीलिए आपको दिया गया था, क्योंकि इसका जो ये था ना, न्याय आपके अलावा कोई नहीं कर सकता था, इसलिए सिर्फ आपको दिया गया सर ये. एंड वेरी वेल प्रेजेंटेड. थैंक यू सो मच सर.
ठीक सर. Thank you.
Thank you, sir. Now, I will request the chairpersons to felicitate Dr. Akashdeep Agarwal. Now I will request Dr. Pragnesh Pramar, Professor AIMS BB Nagar, to felicitate our honorable chairpersons. Dr. SP Mandal, Professor PGI Chandigarh. Dr. Yatiraj Singhi, Professor AIMS Bilaspur. And Dr. Jasprit Singh, Associate Professor, PGI Chandigarh. Thank you, everyone.
Our next lecture will be delivered by Thank you, everyone. Moving on to our next lecture, Our next lecture will be delivered by Dr. Puneet Setia, and the chairpersons for the same would be Dr. Hemant Bharadwaj, Classified Forensic Specialist, Indian Armed Forces, Dr. Preetinder Singh, Assistant Professor, SSGJ IMS Almora, Dr. Namrata Sigil, Assistant Professor, Dental Medical College, Chandigarh. We request the chairpersons to kindly occupy their seats. A few words about Dr. Puneet Setia. Sir is the professor in the Department of Forensic Medicine at AIIMS Jodhpur. Sir has 19 years of teaching experience and has published 50 works in both national and international journals. He has also contributed to chapters to several books. Notably, Sir was also the first Indian to conduct a workshop at the IIFS Sydney on proteomics and genomics in estimating the time since death. Sir also serves as the assistant editor for the International Journal of Medical, Toxicological and Legal Medicine, as well as the Journal of Forensic Medicine and Toxicology. Sir will be delivering a lecture on the topic Genomics and Proteomics in Estimation of Postmortem Interval, an AIIMS Jodhpur initiative. Please, sir.
A very good morning to all of you. When I saw the title of this conference and I had a word with Dr. Harish, so there were two things that could be done. One was about modernization and the second was about integration. And there was a doubt, what should I be speaking on? So we had a discussion and we came to the conclusion, I will not tell you who told me, but it was decided that I will be talking about the modernization part. However, just to give you some idea about this integration thing, we have talked a lot about integration in medical curriculum. When we talk about research, I would just like to inform you that I am already having multiple research projects that are going on with different departments, including departments of biochemistry, gynae-obs, psychiatry, neurosurgery, etc. So anybody who is interested are always welcome to join us. Now coming on to this topic, the journey for this started almost 10 years back from a simple sentence that stuck to me, and it said कि अगर हिंदुस्तान में एम्स में रिसर्च नहीं होगी तो कहाँ होगी, ठीक है, considering the amount of facilities that we people have, if we are not doing all those things, then who else is going to do it? So that was the starting point from where this journey started. So this is our institute for those who have not been there. Right, I'll start with small definitions. Just a revision for all of you. Proteomics, study of proteomes, proteome, of course I'm not going to talk much about these. This is important for my talk. See, the classical methods of PMI we have all been using about somatic death, but what I am talking today is purely based on the cellular death. So what has been done is somatic, but what we are doing today is cellular death. This again is important because all our work that I am going to present today is based on these three things: necrosis, apoptosis and autophagy. Predominantly the work that I am deliberating today is on autophagy. Right? So we all know the classical domains, classical ways. I am not going to discuss all those things, but the problem with those, again, we are already aware of all those things: less sensitivity, increased time, sample size, etc., etc. Again, not something that needs prolonged discussion. Now coming on to proteomics and genomics. Why this topic? It is topic because it is the in thing. All this research that we have been doing, it's not just for the sake of doing. The basic idea and the final goal is to produce something, maybe some card test or some dipstick kind of a test, which we can then distribute to everybody so that these can be used to determine time since death in the field for people who are, say, in PHCs, CHCs, etc., who are doing postmortems in India and they are not well trained. So something for them we can develop. So the whole concept is to develop something like that. right? So why proteomics? Because they are more objective and relatively less affected by exogenous factors as compared to our current methods, right? Secondly, the expression of genes as well as proteins, it proceeds in a time bound manner. That we have already seen, research is there, so that is the reason why this is being done. Now coming on to proteomics part first. Protein degradation can be studied in two ways. One is upregulation or downregulation of proteins. Second is destruction of proteins leading to increased formation of protein degradation products, right? In our study, we have only focused on the first part. The second part we have not focused in our studies, right? So what we do, what is important is after the cell dies, there are changes that are occurring in the cells, and because of those changes that are occurring, there is degradation of proteins, and it is the level of these proteins that are occurring after degradation which is what we are analyzing, right? An important thing that we must remember here is that every protein degrades in a different manner. Every protein in a different cell will be degrading in a different manner, in a different tissue will be doing in a different manner. So we have an endless opportunities of discussing or taking out or studying different proteins in different tissues. The same protein in liver would be going on or degrading in a different manner from, say, a spleen or from blood. So the amount of information that we can get is enormous, and if we can collate all that information, we can have something really good that can be utilized in the fields. So historically, these are the common animals that have been studied. These are the various tissues that have been studied at different points, and these are the various that have been utilized in at different points, right? And these are the proteins that have commonly been used. Now we in our study have used HMG-B1. As you the first thing, I would like to just give a brief overview about the autophagy pathway, which is the basis of the whole study design that we have been done. As you can see, HMG-B1 is the central pathway or the central protein that is involved in the whole pathway, and it is the initiator of this whole autophagy pathway, and that is why we have used this is extension of the same. Now coming on to what we have done, as I told you, HMG-B1 is the protein that we have studied in different tissues. What is the method that we have used? We have used ELISA. The reason being, it is a semi-quantitative method, and it is again based on your antigen antibody interactions, which is our ultimate aim of producing or preparing some CAR tests, etc. So this is the technique that gives me that is best, that can be utilized in that. So ELISA was the technique that we utilized. Now the tissue that we used was human muscle. I would like to add that this is the one that we have already completed. Other tissues like liver, spleen, blood, kidney, etc. on those the work is already going on. So it is not the end of it. We are using different tissues at the moment also. Now and after defined time intervals, some parts were taken from them and analyzed. Details I will be just telling subsequently. Right. So what we did was 100 grams of pectoralis muscle was taken at the time of autopsy, and it was divided into two parts. One was kept at 18 degrees and the other at 40 degrees in an oven. These two temperature was chosen because these are the ambient temperatures, average ambient temperatures of summers and winters in Jodhpur. So we were trying to see if there is any difference in the progression of this decomposition in summers and winters. So these were the two temperatures that were chosen. Right. As I told you earlier, every 3 hours 100 milligram of the tissue was taken from these initial step and processed, and this cycle is repeated every 4 hours. So for every tissue that we remove, we divide it into two parts, and from each part a part of the tissue is removed every 4 hours, and that is then analyzed. Right. So what we do with that, this we can just skip. This is the whole process. If anybody wants, I can just tell you subsequently after the lecture. The important thing is that it was done and finally analyzed tissues that were kept at 40 degrees centigrade. As you can see, there is serial reduction in the concentration of HMG-B1 as time passes by, and the same goes for cold. A bit different, but general trend is almost the same in both the situations. So what it tells us that temperature is not affecting the
general movement of the tissue or the degradation of the tissue. Right, so we constructed the regression analysis, did the regression analysis, and the regression equations were created. Okay, so that is about the proteomics part. Now coming on to the genomics part, before I start, I would like to tell you that this part or this study was a part of MD thesis of one of my students. So a lot of people keep telling me that we don't have facilities, how do, we need big equipments and all those things. So I would like to tell you all that even with small things, small materials, we can do a lot of things, as one of my students did this as part of his MD thesis, and all the steps that I am going to tell you have been done by him himself. Right? The genes that have stopped their expression at the time of death are of no use for us in our studies. So these are the ones that we use, and that is the basis that gave us the question, can they be used to determine the PMI? Central dogma, you are all aware, so I am not going to talk about this. Right? There have been multiple uses as far as the genetics is concerned. However, much has to be done in our specialty. So this is just a very, very small beginning and effort that if we can do something about this. Right? So these are the various things that are already being done as far as genes are concerned in forensics. So estimation of biological strains is being done, differentiate body fluids from which part of the body that has been taken out, that is being done. They can be used as markers of wound age. They can be used for detection of pregnancy, especially if the female is not available, and there can be apoptotic gene expressions. So these are the various ways for which genetics has been in use, in addition to our routine DNA fingerprinting and all those things which we are generally used to. Right? Now, whenever we are doing this, we use RNAs. We do not use DNAs. Unlike our DNA fingerprinting, we are using DNAs. Here we are using RNAs. And these are the various types of RNAs that are available. So which RNA needs to be used depends on the technique that we are using and the tissue that we are using and the availability. So these are the various RNAs that are available, and important thing is the half-life for all of those, because it is the half-life that determines how useful it will be and for what duration we can use the same. Some of the challenges that are there in using RNA is that there is degradation for regulation. There is universally present RNases are present, and secondly, the intact RNA can be extracted after death. An important thing that you can see are the last two slides, which is talking about the stability. Although the stability of each and every RNA is different and it is not as stable as a DNA, right? However, the time frame that we are using for our studies regarding PMIs, RNA can be very useful, because as you can see, the stability that is present in these tissues is much more than what is required for us. So RNA can be easily utilized. Right? So this is a study that has already shown that these are the tissues in which RNA can be utilized, and the stability not suitable, suitable or not suitable for using RNA as the tissues for detection of PMI. And based on this study itself, we had chosen the various tissues that we have been studying. Right? Before I start with what we did, some of the major challenges that are being faced the world over. The most important is the studies that are being done in animals. There are very, very few human studies that are available. Most of the studies are done in animal, and that too in controlled environments, which are very difficult to be extrapolated for the field work. Right? Secondly, the methodology is not being standardized. Every person is using their different method. There is no body or an association or an organization which has been saying, yes, this is the method that has to be utilized. So there is no standardization that has been done as of now. Same goes for sampling conditions also. Sample size in all these studies, especially molecular studies, is always very small. That is a handicap that is always seen in cases where molecular studies are done. And finally, as I said in the first point, the studies are done in controlled environment, where animals are taken, they are killed or done whatever is required of them, and then they are kept in controlled conditions. So while in a field, when we are doing autopsies, we don't get these controlled conditions, controlled environments, and because of that, extrapolating these studies to real life situations is a very big challenge as far as molecular techniques are concerned. So the various techniques that are utilized are real-time PCR, microarray and sequencing. Out of these, we have used real-time PCR in our study as of now. Sequencer we have in couple of our departments in our institute, so that is what we are going to subsequently. Microarray till now we have not utilized, although some departments are in the process of purchasing microarrays, so once we get those facilities, then we will be using those also. Right, now coming on to what we did. So this gene expression study was done on cardiac tissue. As I told you, it was part of the PG thesis of one of my student, and here we collected tissues just like we did in our molecular proteomic studies. The same way tissues were collected, kept at temperatures, and then they were analyzed, and the expression of various genes were seen. We used RT-PCR as I told you, and cybergreen was the chemistry that was utilized in these. Right, so what was done? As I said, the study is based on RNA. So the RNA was extracted, RNA was converted into cDNA, and after that the real-time PCR was analyzed to see the level of DNA. Before real-time PCR was done, the quality of DNA is always checked. So in terms of quantity and quality, so that was checked and then it was done. Finally, housekeeping genes were also studied. GAPDH is the housekeeping gene that is used. Housekeeping gene is a gene that is stable. So it is taken as a control, an inbuilt control in any molecular study that is done. A housekeeping gene is taken as an inbuilt control. So we used GAPDH, and we have already seen literature how it degrades with the passage of time, and we saw that the study period that we were using, this was a very stable gene, because it degrades or start degrading after 72 hours, and our study was within 24 hours. So this was a very good housekeeping gene that we utilized. And finally, the Livax method was used to determine the fold chain expression. Now, cardiac genes, the two genes that were studied was cardiac troponin I and proBNP, and in addition to that, we studied the autophagy genes also, HMG-B1, BCL2 and the BAX. So these were the genes that were studied in this particular study, right? And as you can see, the CT values of the various genes was like this. However, what is more important is the fold chain expression, and as you can see, the fold chain expression, it is increasing, so which means that there is upregulation of the genes that is occurring. So as time is passing by, the genes are expressed, the gene is more and more gene is being expressed. For proBNP, it is the other way around, the expression is going down. Right. So again, the regression equation was prepared, and the studies were and the results were published in various journals. So these were some of the journals in which the results have been published from these various studies that we have done. So this is what we have done up until now, and what are our plans for the future. So for futures, for proteomics, as I said, the way we have done HMG-B1, another protein, autophagy protein, you must have seen in the chart on the autophagy pathway. Declin-1 is another protein that is used there. So that is another protein that we have studied. Again, the work has already been done, only the data is being analyzed as of now. In genomics, what we plan is to study these couple of couple of genes, that is LDH and cardiac troponin T. Once again, work has already been done, and the data is being analyzed for these two also. Microbiome is another thing that we plan to study. We have prepared the things. We have the sequencer in a couple of departments, as I told you. We have Sanger in biochemistry, and we have NGS in microbiology. So we are working with them, and microbiome studies are also the things that are in the pipeline, and the work is going to start on them very soon. And finally, I've just been purchased GCMS as part of an ICMR project. So this is again is going to be used to use the study of volatile organic compounds to determine the postmortem interval. So these are the some things that are planned in future as far as our study for these things are prepared concerned, and this is the lab that we have developed and the equipment that is there. Thank you.
A very nice and informative talk, and we were not aware that postmortem interval can be done from these methods. This is new things to me. Thank you very much for your talk.
सर एक छोटा सा सवाल ये था कि लाइक टीलोमियर शॉर्टनिंग जो है वो एज एस्टिमेशन में यूज़ करते हैं वैसे तो हम लोग, सो दिस इज डेफिनेटली पोस्टमार्टम इंटरवल वी आर एस्टिमेटिंग TDI, तो हाउ डू यू कंपेयर दिस, आई मीन उसको प्रोसेस करना और इसको प्रोसेस करने में क्या फ़र्क है लॉजिस्टिकली या कॉस्ट वाइज?
टीलोमियर शॉर्टनिंग इज अ टोटली डिफरेंट।
यस, वही मैं बोल रहा हूँ, वो तो हम एज एस्टिमेशन के लिए करते हैं, पर वो उस अगर यू नो यू बीइंग दी डूइंग ऑल दिस हैंड्स ऑन, तो क्या उसमें और उसमें क्या फ़र्क है वैसे, क्यों दोनों का गोल अलग अलग है बिल्कुल, तो कुछ उस पर टिप्पणी कर पाएंगे सर?
Actually, it's difficult to compare because these are two totally different things. Telomere shortening is what you are doing is based on your karyotyping.
Yes.
Right. This is karyotyping is just the arrangement of your chromosomes. This is we are doing from a single chromosome. We are talking to the very basic genetics level.
Right.
Okay. So that these are two things that we cannot cannot even be compared. So it's totally separate.
Thank you, sir.
So it was a very nice presentation. So I have always had a negative thoughts about postmortem interval estimation, because I was thinking most of the time I think that the results obtained by all the research projects being done on postmortem interval, it's not practically applicable. Most of them are just for research purpose. So how do we, in the sense in this case also, the levels of the mRNA expression and all, how accurate are they? How we have derived the result?
Yeah, I forgot to tell you that once we had these results that were there, especially for the protein levels. Okay, what we did was we did some blinded studies. We took time since these proteins from at the time of autopsies and put those values, process them and put those values in the regression equation that we have got, that we have prepared. So the results that we got from those were very much within the this range of protein levels that are there, or time since death levels that are there. So the results
is it any better than what we do it grossly, in the sense with naked eye examination we come to a conclusion that this is so much time has passed on? How advantageous is that in compared to
the biggest difference is with the naked eye examination is the variability. For example, let's say we talk about rigor mortis or hypostasis. If the patient is or the person died in summers or the person died in winter, the levels would be totally different. That is not the seen here. As we saw, both at different temperatures, at 18 degrees, 40 degrees, the levels were comparable. Okay, so that variability factor is something that is very important, especially when we are talking about medico-legal issues. So there, this is something that has better reproducibility. The same can go for your reproducibility. For example, if I am doing it in my lab, if you have any issues with what I am doing, you can take the sample from me and test it in your lab. Right? So that is an important thing that is there, because ultimately, ठीक है, मेडिको लीगल में काम चल रहा है हमारा, सदियों से चला आ रहा है, आगे भी चलता ही रहेगा, बट द फाइंड इज द थिंग इज दैट वी शुड ट्राई टू इम्प्रूव अपॉन आवरसेल्व्स. सो दिस इज जस्ट
थैंक यू.
समर में डेथ हो गया या विंटर में डेथ हो गया, बट द फैक्ट इज within 1 or 2 hours the body goes into the cold storage, and the temperature of the cold storage is always the same whether it is in Jodhpur or in Delhi, right? So and जो हमने ये देखा है कि आप once the body goes into the cold storage, you cannot estimate the time on basis of postmortem changes, right? So then what we do is we extrapolate from the time the person has come into the cold storage. Or we know in hospital death cases there is no issue because you just subtract and then you get the post-mortem interval. So, I mean, what I think Dr. Murali is asking, what we will do is how subjective or
Sir, when we allow the body to decompose in a natural manner, whether it is summers or winters, then the results are reproducible in both the things. However, when it comes to say 4 degrees centigrade, right, when we are keeping the body in the refrigerator, right now we don't know what the effect will be on that. For that we need to do more work. In fact, I have had a word with Dr. Bansal also. So we are planning to do something similar to that, where the body is being kept at temperature at our cold rooms and freezers, and then what is the effect. So that is something that is being planned in the next phase.
इसमें सर even the preliminary results have not been shown in this slide. Result तो है नहीं इसमें presentation में. Results तो दिखाए नहीं.
It was an overview, sir, probably.
See, I just gave you the graph, the what you call the progression and the way it is going. If you want exact results, then I'll ask sir to let me organize a workshop as I did in Australia.
मैं ये नहीं कह रहा. मैं ये नहीं कह रहा सर. Have they been published anywhere कहीं पे छपे सर अभी?
Yeah. इसके
अच्छा इक्वेशन के बारे में कोरिलेशन इक्वेशन कह रहे थे ना आप?
सॉरी
रिग्रेशन
इसी में है.
हाँ
आप इसको देखोगे you will get it.
ठीक है सर.
Dr. Puneet, how much time will it take for a sample to be tested and conclusion drawing about postmortem interval? How much time does it take completely?
Sir, right now since we are doing serial estimation, so we have been doing it for
for one sample. Suppose,
for one sample.
let us say you said that you tested this on real cases.
Yes.
And then found that it matched with the actual time since death.
Yes, sir.
So now that testing, how much time does it take?
Sir, the whole protocol of this ELISA technique, it is approximately 45 to 1 hours.
No, the sample from preparation to end.
Yes.
Okay.
Like harvesting, because harvesting taking to the lab, that also took around 10 minutes. Including that, from harvesting to final result, the protocol is usually approximately 45 minutes to 1 hour. So that is the time we took in processing one sample, and that is why we could do serial estimation in our study because if the time period is long, पता चला पहला वाले काम खत्म नहीं हुआ अगला sample आ गया. So that is not feasible.
No, I am looking at the practical applicability. Say in case you want to implement this in real cases. And if it is going to take a long time, then it's not practicable. So if it is taking only 1 hour, that's a good thing actually.
Sir, in fact, right now because we are doing the whole ELISA method, so that is 1 hour. The plan is to prepare maybe something like a card test. Okay. So that should be there in within say 2-3 minutes, 5 minutes, just like you have for your toxicology things. Yes. So something like that we are planning. So if we can get that, hopefully if we can get that, then we will have card test. So that will just give the results in 2 to 5 minutes.
What was the longest time you had for estimation of this one? Like 2 hours, you took the sample 2 hours, 4 hours, 6 hours?
So we did the sample or we harvested the sample within 6 hours of autopsy, within 6 hours of death. So only in those cases where the autopsy was conducted within the first 6 hours, and then if you take the longest time as 6 hours, right? So every 3 hours we did it 4 times. So take it somewhere around 15 hours. That was the longest time from death to the processing. So that is the range that we have done in our studies. Yeah, definitely. Because the whole thing was that let us just start doing it. If we have something positive, then we can increase it further. So and since we have got some encouraging results, so that's why I said we have subsequent plans for all these things. Yes. Sir, accuracy as of now is dependent on the method that we are using. So right now the accuracy is somewhere around plus minus 2 to 3 hours. That is what we are getting as of now. And as we proceed further, as we get more data, because I'll just tell you, like when we started and initially when we were processing the data, this range was somewhere in the range of 5 to 6 hours. But as more data kept coming in, as we kept doing more cases and more samples, so this has reduced to approximately 2 to 3 hours. So hopefully as we keep on increasing this range of 2 standards.
Sir, for the informative lecture. Now I request the chairpersons to felicitate Dr. Puneet Setia. May I request Dr. Rajiv Joshi sir to felicitate our honorable chairpersons. Dr. Hemant Bharadwaj.
कर ली सर, मैंने डाउनलोड कर ली.
Dr. Preetinder Singh.
पहले तो तुमने दूसरी स्लाइड लगानी होगी.
सर आप एक मिनट बैठ जाइए सर, एक मिनट बस.
Now the next lecture will be delivered by Dr. Piyush Kapila, and I would like to invite on the stage the chairpersons for this scientific session, Dr. Kuldeep Kumar, Professor GMC Amritsar, Dr. Didar Singh Walia, Associate Professor GMC Patiala, and Dr. Arpan Kumar Pan, Assistant Professor MMIMSR Maulana Ambala. I request the chairpersons to occupy the seats, please.
इंट्रोडक्शन हुआ सर का?
नहीं हुआ, तभी मैं कह रही हूँ. I'm delighted to introduce Dr. Piyush Kapila. Sir is the by various courts of HP, including the Honorable HC, and has around 200 reported judgments to his credit. Sir has also an immense expertise in forensic photography. Sir will be speaking on the topic forensic photography and its admissibility in the courts.
Thank you.
Thank you, organizers, and good afternoon, everybody, for inviting me again on the same topic. Usually that is not usually done. You come with the same topic again. So I'll be talking about the admissibility of the photographs as documents and the latest Bharatiya this Sakshya Adhiniyam. You see, the body, it will perish after death, but the photographs don't. And what we see in the photographs, 1,000 words cannot explain that thing which one single photograph can explain you. Whenever the history comes from the police, if we have 5 people there, we always try to make our own picture of that thing. Okay? And when the picture, fantasize the situation of the body at the site, or fantasize the situation of the site itself, so that's altogether a different thing. So what we say is, with the photographs, they are very, very corroborative evidences which form the basis of the expert opinions. And there has been a paradigm shift in the forensic photography. I still remember we started with the normal camera, with the reels, and there was a lot of problem with the reels. Sometimes all the 36 photographs, there was only with one reel you can only do the 36 photographs, and it was a costly affair. not many people or not many department would had at that time had the capacity to buy those the equipments. Now with the invention of the mobile and with the features and apps that are being given in the mobiles, it's as good as a normal Dr. Sanjay Das is here. He is very good in photography. He would understand few of the things what I'll be going to tell. The Android phone, and many of the good Android phones have certainly very good capacity to take the good photographs also, even with the macros. So sometimes it's very challenging to give the second opinions, and what makes your second opinion in the second autopsy cases. So when a just and a right photograph is a very wonderful tool to present legible, plausible and irrefutable evidence, okay, which you can tell. By most of the cases, somebody would argue how it is possible. In many of the cases, what we have seen is one autopsy has been done, there was some brawl, second autopsy was, it was ordered by the court, okay, and it was, first one was also done by an expert, forensic expert, MD. But when it came to us, the head was not opened. However, the report said that head is opened, there was no intracranial hemorrhage and all, and actually the cause of death lied in the head itself. So when you are differing from one autopsy photo, the report, and you are coming to the second report, you should have a and your report, whatever report you are making, it is meant for a peculiar target. These guys, how so big is the judge? They are not actually experts in the human body. Okay, so it is a peculiar target you are targeting. So to them, if you are writing so many flowery or the technical words or these jugglery of the words, then they would not understand them. But however, when you show them a photograph, what exactly you are trying to portray into that one, that will be a very apt thing to say. And but here presentation of the evidence is a little bit of, you have to take not much of the things, but small things. It has to be simple but comprehensive, and maximum resolution but minimal distractions. You cannot, the bloody part is there, your instruments are there, and your so many other things are there. So your the person who is looking at that photograph, his mind will go at all those places. So you will have to choose the photographs, what photographs have to be. And with the digital media now, it's very important. Okay, or the photograph is there, that is there. So you couldn't change that one. Benefits, it's a data for the research, number one. Evidence in the court, I'll be telling you how we have started this one, giving the photographs into the courts. Evidence in the case of the second autopsy, I just narrated one of the examples. Minimize the potential biases from within the fraternity. Sometimes there can be peer differences also, subjective opinions. So there you can have, if you have a photograph, you can send it to any agency across the world and take their opinion. My opinion is mine. It can, मैं नालायक हो सकता हूँ, मेरा ओपिनियन जिस बेसिस पे मैंने बनाया वो आपके पास है, आप इस पे जो मर्जी ओपिनियन लेते रहो. Maybe you may find some better person who can give a better opinion on that one. And if it is acceptable and it serves the right purpose to give a better judgment, why not? I'm not concerned with this one. It can be taken with that one. So it's a vital source for the teaching purposes for all those people, like the young professionals whom we want to teach the real world examples. Okay, so that is a very good data. I might be having probably 2 or 3 TB data since 2005 or 6 probably. All the photographs, all the good cases, they are being taken. And now we tell the students who ever come to the post-graduation that take one mobile, that is your stethoscope. 10,000 rupees mobile, that should be only for this purpose. Take the photographs. Okay, and then after few days, like after 1 month or after a week, put those photographs, organize them with the postmortem cases, like with the postmortem numbers. okay, and then organize them into that one, and always write on the top of that, the folder, that what kind of case it was. Simple head injury, hanging, maybe the accident, what was the best thing in that photograph. In that bunch of photographs, you took the 50 photographs of one autopsy. Just tell me, like, there is one big, the best postmortem change, the best rigor mortis, about the decomposition changes. So you can always write them. So whenever you are searching for some photographs, you can just write the decomposition. Will accept this, that aperture, shutter, camera, ISO, how they are being, how they are used. The more is the light, less has to be the aperture. Less is the light, bigger has to be the aperture. That's the basic of the photography. And that's a main stem of the any kind of the photography. But there is shutter speed. You must have seen this photograph. I must share with this example. Lately, Donald Trump was shot, and in one of the frames, just near to his ear. How did that come? Because shutter speed does that one. Because that has been taken at 1,70,000 frames per second. That's why he could catch that one. So that's what shutter speed does. If shutter speed is less, Sachin Tendulkar's bat will be blurred. But if it is the shutter speed is too much, okay, it will be right there. It'll be hitting right at the point, the point of time when it is hitting the bat, it will be right there. So that's the shutter speed. So sometimes when you are moving, why forensic photography is, and why I have not said videography, because in the videography, whatever you have shot, it cannot be increased. In photography, whatever you have shot, it can be increased, whatever may be the pixels, whatever you want to see. So that's why photographs are better as compared to the moving thing. Yes, you can take a screenshot, but we have tried to take the screenshots. In that one also, how much frames per second is there. So that is taking approximately 32 or 64 frames per second. That's a problem. There, it's still, the screenshot or the snapshot, it is still blurred. So that's why photography is still, as of date, is better than another one. So I'm how the ISO will tell you, the various ISOs, 100, 200, 400 and 800, and you can see the clarity of that one. What's the depth of the front as well as the back, both go blurred. But the center is the perfect one. Like you can have this particular one thing in the portrait, this one, in your camera app, go to the portrait, your background will be blurred wherever you are focusing. So that's what the depth of the field means. And this is a photograph in which it's equally distributed. Okay, so that's the depth of the field. Then depends 1.8, 4.5 of the frames, So how in the last one, if you see in here, it is f22 where everything is visible from front to the back. Then is underexposed, overexposed, and correctly exposed. That is very important. I'm telling you the real example here. One photograph was underexposed and one is correctly exposed. So underexposed or overexposed, these photographs are bad photographs because they can't tell you much of the things. The basic equipment, if you need, like the professional ones, is a SLR camera. Anything with 12 megapixels and above can do. You can go higher, whatsoever, but still that is the only one. So I think some good batteries, the chargeable batteries, electronic flash remotes, they can be done. First thing we want to put onto like in the postmortem cases is the caption slip. You can put the college name, postmortem number, the date, and sometimes who are the autopsy surgeon. Body, sometimes they come in a sealed, okay? So you have to see whether take this photograph of the seal and whether it is matching with that one, how many numbers of the seals are there, okay? Then you take the wide angle photograph of whole of the body, and sometimes what we write is like mostly when you write the postmortem report, the first thing, what is the most striking feature of that body, that you tell. Okay, so cases, one boy just died just opposite our hospital in the evening. In the morning, when the body was brought, both have received, otherwise you will be, there will always be putting a blame on you that you have done this during the eye. They are still there. Okay. We take the photographs, wide angle, then whole of the body, okay, and then like in this particular clothes, you can mark them, you can take a scale, and that is, and even reporting is very good in this one. You take the photograph, you go back to your room, and then you can, because rest of the DNA which was there in the seminal, all the seminal fluid and vagina was flooded with millions of maggots, and so that we couldn't get, but the DNA was preserved from here. This particular case only, the Gudia one only, the major thing was that this child was ravished at somewhere in somebody's food was there. So we said that the same food was served in the school. Okay, we knew and what time she took the food. So we just said that, after taking this food approximately 2 hours, 2 to 3 hours, so because you can still identify the rice, it was not even semi-digested at this particular time. The weapon of offense can be measured from that particular one. Okay, this is the epic photograph of that the same child in which the accused was, on the dental photograph, because this scaled dental photograph of the bite mark was very, very important in this particular case. Sometimes some weapons, now if you want to explain this one, you will probably write 5 or 6 lines on to explaining this one. There is a small gap, and then there is a two injuries, maybe with the same weapon. Maybe you just put one photograph and you will understand, yes, this is by one edge has acted onto that one, whereas another one was not there. Any duplication of the ligature mark in particular one, actually it is going. I have given these photographs side by side. Confusion is there. You are incising and deformed. So you have given both the photographs. It was looking like this, formed. So you have given both the photographs. It was looking like this. Sometimes it is onto the. This is again an infamous case. One of the IIT Roorkee's girl was being taken to Shimla and was killed, and the weapon of offense was antiquity bottle, the alcohol bottle. You can see that bottle glass, it was actually showing there exactly onto the this was there onto the body controls. You can rule out certain the weapons of offenses. In this particular case, there was did. So obviously you have a better saying at this particular one. The same thing is in one of the case where you have to measure the signature fracture. And obviously there cannot be anything more than 3.5 centimeters. Less than that couldn't have done it. And the same thing was the police brought probably 8 or 9 millimeters area that this could have caused it. So obviously we said that this is 3.5. Signature fracture means signature fracture. Okay, the exactly same volume was. This case was not very much hyped up, but this was worse than Nirbhaya. It was Nirbhaya 2 actually, but because the child as well as the perpetrator was they both were from the migrant laborers, so this didn't hype up. You can see one of these wooden sticks. They were introduced through vagina. There was third-degree tear between vagina and the anus, and these twigs were found inside the abdomen. Okay, and approximately 1.5 meter of large intestine was lying outside into the fields, which was actually gunshot cases. You can take the gunshot, what kind of the bullet you have found, the wide angle, and the second one and the third one. You can always have a scale photograph. In the pathological autopsies, you can always say that what kind of the photographs are there. If you want to tell about the aneurysm or the thrombus in the circle of Willis or in the central, the wide angle photograph, which part is there, and then the smaller one and the third one, and obviously some contrasting thing you have to add to that one, because otherwise you will not be able to. Okay, in this one we could, the cut section of that aneurysmal part as well as the thrombus part was there. Okay, in the coronary sections, if you want to show how much the coronary is being blocked, Okay, so both these one can, the gross atherosclerosis of the aorta and of the thrombus was there in the renal artery. Weapon of offenses, how to make them, how to take the calipers, and if with the help of the calipers, if you want to show the exact width of at what end is there, and then you can take the help of the digital calipers also. These are available these days. Okay, so you can always take the width and length of those calipers with the help of these ones, and that photograph that one, and you don't have to measure it actually. Then you have to make a template. Okay, taking the temperature of the subhepatic area, and sometimes it can be helpful. Taking any measurement you have taken, for example, in the NHRC cases in the Model A, all the organs are to be weighed, so you don't have to remember those weights. Just weigh that area, and you can just reproduce it later on. What are the constraints? Lack of knowledge is one constraint. If you are doing the autopsy, maybe the assistant doesn't know what to focus, where to focus, and there are not basics. Unsteady hand, or especially the poor light, low light areas. Shadows, for example, in the outskirts, raw photographs, unwanted equipment or the bloody areas, wrong labeling that can push you into a very embarrassing corner. Side photographs, they are not from the top of it. What photographs are the better ones which are taken right on the right angle? How to present them, like we used to put them onto the CDs. Nowadays CDs are not there, so we are taking the USB drives. Okay, so you seal them after mentioning and labeling. For this photograph, everything is being labeled on this photograph. Sample seal is being sent to the court. So we send these photographs written on the CD, one copy to the court, another copy to the police for the investigation. And this is how we actually make this declaration that this document is admissible in the court, also in the new Bharatiya Nyaya Sanhita, section 63. Okay, look, in the second part of this one, I have written that 62 photographs were taken by the Nikon digital camera and are written on the CD unedited and handed over to the police unsealed, and another copy was made sealed and handed over for the court exhibit. So this particular remark, it actually exhibits in the court. This is a document which has been exhibited in the court because we have already written that what kind of the CD is being told there. Sometimes many samples are there. You can always take a photograph of all the samples, what has been sent, so that tomorrow the police and the FSL, they cannot argue with you. So that can save you the time also. Now the admissibility, it's very, very clear that it is admissible. And I was talking to Dr. Harish earlier. Nothing in this Athenium shall apply to deny the admissibility of an electronic or digital record. So this was not there earlier in the Indian Evidence Act. They actually amended Indian Evidence Act and later on told that yes, electronic documents can be admitted, and that was a section 63 in the earlier one. Here it is 61. And then 63, it says that nothing, notwithstanding anything contained in this Adhiniyam, and any kind of thing, like whether it is semiconductor, paper, stored, recorded, copied, optical media or magnetic media, or even the cloud that has been included into this one. Okay, and everything is being admissible. And earlier, in the earlier one, the primary evidence didn't have a photograph onto it one, or the digital one. This one, primary evidence and the explanation of 1, 4 and 5, they already said where the electronic or digital record is created or stored, everything is a primary evidence. Okay, and even the video recording or anything onto the which video recording is done. So if the conditions are met in this section are satisfied in relation to the information, so anything which is related to the computer can be admissible. And there are some, National Human Rights Commission has also given some recommendations of how to do the photography. What are the some recommendations worth mentioning here, which to take, where to take, and upper extremity, lower extremity, the feet, for the torture purposes, all those things. And now with the conclusion of this one, forensic photography is indispensable, obviously, captures crucial evidence, preserves truth for the future, communicate complex details in a way accessible to everyone, from laymen to the legal professionals, and by meticulously documenting every aspect, ensures that no piece of evidence is overlooked. How about Leon MacDonald? He was a person who actually made that Magna brush, if you remember, the fingerprint one, which does not aberrate the fingerprint parts. He said the physical evidence cannot be intimidated. It does not forget. It sits there and waits to be detected, preserved, evaluated, and explained. Thank you so much.
Honorable delegates, they can ask the queries if they have any from the speaker, please.
So it was a very wonderful presentation.
Thank you.
Just wanted to know what is your take on capturing photographs using mobile devices for legal purposes?
Yes. You can always.
So how practical, in the sense how feasible it is?
Very, very practical. Everybody has a mobile.
No, that is totally different from the legal point of view. Actually,
Nothing. You just have to say that I have taken these photographs from my mobile and hand to. It is if you see, the keyword was unedited. So when I'm writing it on the postmortem report, the keyword was unedited. It is written unedited onto CD or any USB drive. So you are saying that these photographs, they are being projected or they are being sent as it is.
so does the mobile need to be subjected for any examination?
No.
In case required.
In case required, okay.
So
that
may be a
maybe
that is a ground problem. That is a
talking
practical
of
problem.
1 in 1 lakh case.
Court thinks that you have edited. If the court has any iota of doubt that there is some way it has been edited, then it will ask for your mobile as the drive. Even that is not required. Photos have the raw data.
Yeah.
If you are submitting a soft copy of the photograph, it contains raw data which is not visible to you, but it can be expected and it can be told whether this has been edited or not.
So if the chain of custody is to be maintained, they may ask the capturing device also to be examined.
That is only in case of where it is required for as an evidentiary material.
So you never know which case it may be required.
So then for each photograph, you will have to keep a record of which device it has been clicked from.
So if that device gets corrupted or gets damaged,
it's okay. That is true for a camera also.
If it gets lost,
That is true for a camera also. Right.
So camera is an official thing that can.
But it also can get corrupted. That also can be lost. That can be broken. So it
it is better to avoid taking in personal mobiles, I think.
It's not necessary to take photographs from your mobile. You can purchase from the department.
Yes,
Sir, if you remember, I just told that I have told my PG students that this is your stethoscope.
Yeah.
You have to take one mobile which is only for this purpose. If even
depend upon the money you have.
Nowadays, I think DSLRs are very cheap, sir. Nowadays, I think.
Not that cheap. What an Android mobile with this.
iPhone costs around 1.5 lakhs.
एक सजेशन है सर, आई थिंक कि जितने भी फोटोग्राफ्स हैं शुड बी टेकन इन अ रॉ, सो दैट द सर विल नो बेटर कि उसका डिस्ट्रैक्शन जितना कम होगा अगर हम उसको जितना भी ज्यादा अगर हम सेव करते हैं जेपीजी और किसी और फॉर्मेट के अंदर तो रॉ फोटोग्राफ लो, दैट इज आप वैसे तो आजकल क्या मोबाइल भी आ गया जिससे आप रॉ फोटोग्राफ ले सकते हो, बट डीएसएलआर अगर आप यूज कर रहे हो तो ऑलवेज टेक फोटोग्राफ इन अ रॉ फॉर्मेट.
There is a problem in taking photography if you are using the artificial light. In the artificial light, actually, that what happens is if you see an LED light, put your phone onto the slow-mo, and you will see that LED flickering. So those lines, they are actually sometimes they are being picked up by the camera if it is an artificial light. Okay, so you will see lines. जैसे आप अगर कंप्यूटर के से अगर फोटोग्राफ ले रहे हो तो कई बार उसमें लाइंस आती हैं. दैट लाइंस इज एक्चुअली दैट anode is emitting photographs in flicker manner, but to our eye that is not possible that to see that gap in between. Okay, so in this one also, if there is a artificial light, usually there are some lines. So to remove them, you just don't use the artificial light for the photography.
Can we give opinion based on the photographs, second opinion?
Sir, if it has come to you, you can give. You can give. Yes, you will not, you will say that it is not, I have not examined as such. I have not examined.
This is my question.
Only based on the photographs, whatever you are looking there, it is there. It is limited, is there. Yeah, limited. But sometimes there is some, if there is some gross thing, you see, I was talking to some youngster outside, a forensic expert who cannot differentiate between hanging and strangulation, he ceases to be an expert to me. I don't know why there was so much of fuss in that Sushant Singh's case. What was the fuss about that? To me, if my postgraduate student, if he is not able to differentiate between hanging and strangulation, I'll fail him. Sir. Ji? Sir, usually even you would have seen most of the photographs except for one photograph where I was showing you the artifacts. I have actually tried to conceal most of the things. So actually it is not advisable to leak the photographs onto the social media. And if it is there, someone at some point of time may sue you. Doesn't matter, sir. पुलिस की तरफ से होता है तो आपका अपनी तरफ से आप वो पता लगा लेंगे आपके मोबाइल से गया है कि नहीं गया है. अगर बाकी किसी और के मोबाइल से गया है, we are not much concerned about that.
Oh, Dr. Piyush, thank you very much. Now you understand why I asked you to repeat the same thing.
Thank you, sir. Thank you, sir.
Because the BNNS had changed, and we again needed to know the difference between primary evidence and secondary evidence.
Yes.
And that is why we requested you कि sir दोबारा please एक बार दोबारा करो.
Thank you, sir.
Thank you so much, sir.
Thank you so much. Thank you, sir.
Thank you. Thank you, sir, for sharing very, very informative knowledge. And it is very useful for all of us. And my suggestion is that you should write an article in the new textbook for the younger generations.
Sir, sure.
Thank you.
I'll try, sir. I'll try, sir.
Sir, it was a very nice presentation. I want to ask few questions, sir, regarding the organs which we are taking photographs, as you have shown somewhere in white background, somewhere in the green background, somewhere in the blue background. So I wanted to ask that thing. So which background you are preferring, on which case basis you are taking that?
The green background is the best one.
Okay, sir.
Because if you see at many places when we are taking the photographs, specifically in the pathological ones, I don't know if I can remake that one. करेंगे see these ones, this particular one. See this particular one. We have specifically kept a green gown on the background.
Yes.
Well, and it's not, nobody is going to give you the green cloth. What we are using is the old gowns, what we have already discarded. So we make a clear part of that one and we use that one. So this is obviously the internationally accepted one is all the photographs. They should have minimum destruction and the green or they say light blue.
Light blue, yes.
So that's the actually thing which should be there.
And sir, my next question will be, if as an expert witness we are being called in court, so what question is expected if a photograph is showed in front of us? From that, what question is expected?
They can really ask that, the opinion regarding this particular photograph or opinion based on this photograph is given this particular, let's say, a statement A. Can it be a statement B? So that can be the only question. So if you have the good photograph and which has, and you have reasons to doubt that the statement A is not correct, or you have reasons to believe that the statement B may be correct. So you can give your opinion based on
Like sir,
that
in
one.
normal cases, we are asked whether, sir, you have written this PM report. So I think that will be the first question, is whether you have taken this photograph or not.
Yes, usually that is being asked, but if you are fervent enough now probably since last approximately 10 years or more, they have stopped asking me these questions. You have to, nip the, that thing in the bud itself. You don't take bullshit from the judiciary or from the lawyers. Now I have the audacity to speak them that this is not a relevant question, I am not going to answer this one. Or I have the audacity to speak even to the judge also why you are not interfering into this one. He is asking me, फिर तो कल को मैं ये भी बोलूँगा, हमने उनको भी बोला, जज को भी बोला कि फिर तो आपने ये जजमेंट ही नहीं दिया और गलत जजमेंट दी है. How do you feel about that? So why do you allow these questions? Though they will ask you, but you don't have to take it to the heart. But yes, if you have guts and if you have balls to do that, just
Thank you, sir. Thank you very much.
just do it.
Thank you, sir. Thank you.
Thank you so much.
Thank you, sir. Now I request the chairpersons to felicitate Dr. Piyush Kapila.
उसमें बहुत इम्प्रूवमेंट है, उसमें बहुत सारी चीज़ें हैं. मैं ज़्यादा लंबा नहीं आया, रेडी ज़्यादा टाइम नहीं किया. उसमें सर आपका बहुत अच्छा काम किया.
I request Dr. S.K. Dhattarwar, Professor and Head PGIMS Rohtak, to felicitate our honorable chairpersons. Dr. S.K. Dhattarwar, sir. I request Dr. Jhakar to felicitate our chairpersons. Dr. Kuldeep Kumar, Professor, GMCA, Amritsar. Dr. Didar Singh Walia, Associate Professor, GMCA, Patiala. Dr. Arpan Kumar Pan, Assistant Professor, MMIMSR, Mulana Ambala. Thank you, everyone.
सर कहाँ गए? सबके साथ गए सर, एक फोटो खिंचवाते हैं आजकल.
फाइन. हाँ जी सर, हुकुम करो. फाइनली हाँ सर, बस मेरा.
The speaker for our next lecture is Dr. Harvinder Singh. I would like to invite the chairpersons for this session. Dr. Sanjay Das, Professor and Head, HIMSS Dehradun. Dr. Arvind Kumar, Professor, UCMS Delhi. Dr. Siddhi Pasi, Assistant Professor, Dental Medical College, Chandigarh. I kindly request the chairpersons to occupy their seat. Dr. Harvinder Singh currently serves as the Assistant Professor in the Department of Forensic Medicine and Toxicology at Himalayan Institute of Medical Sciences, Chandigarh, Dehradun. With 9 years of teaching experience and 23 publications, Sir is also the Joint Editor of the Journal of Punjab Academy of Forensic Medicine and Toxicology. Sir has also delivered guest lectures in various organizations. Sir will be speaking on the topic fabrication of injuries. Please.
Good afternoon, everyone. Today I will be speaking on fabrication of injuries. First of all, disclaimer. The contents of this presentation are my personal opinion. These are not directed to anyone. I won't be discussing why these injuries are fabricated. I only present a common pattern seen in some cases. I only question what stops us to be more proactive in such cases. So what happens is, in the state of Punjab, पेशेंट आपको खुद आके बताएगा, डॉक्टर साहब मैं चोट बना के आया हूँ, आपकी सेवा पानी कर दूंगा, आप रिपोर्ट अच्छी बना देना. तो फर्स्ट ऑफ ऑल, फैब्रिकेटेड इंजरीज कैन बी सेल्फ इन्फ्लिक्टेड इंजरीज, जहां पर पेशेंट ने खुद चोट अपने आप को लगाई है टू गेन सिंपैथी और to gain sympathy. Then self-suffered injuries, in which he takes the help of some other person to inflict injury upon himself, for again mainly for legal gains. Then malingering. In malingering there is intentional production or exaggeration of symptoms or injuries for secondary gain. Then factitious disorders. Here the individuals who fabricate symptoms or injuries without obvious external incentive. The motivation may be psychological. And Munchausen syndrome by proxy, where usually a parent induces an injury over their child, again to gain attention or sympathy. Now coming to epidemiology, some studies indicate that 10 to 15% of medico-legal cases may involve some form of fabrication, and it is higher among populations that are involved in legal cases. In situations where there are financial gain or legal gain. Coming to the demographic factors, males are more likely to fabricate injuries than females. Legal gain and financial gain is the predominant factor when males fabricate injuries, and females usually fabricate injuries as a symptom of underlying psychiatric condition. The age group that is most commonly involved is 30 to 50 years. Younger adults, whether male or female, fabricate due to underlying psychiatric conditions. In older individuals, legal gain is the major precursor. Most of these cases belong to lower socio-economic status. Coming to the psychosocial and behavioral factors, individuals with certain psychiatric conditions such as borderline personality disorder, factitious disorder are at a higher risk. Substance abuse is also a significant risk factor, as individuals may fabricate injuries to obtain prescription medicines. Legal and financial pressures, particularly those involving criminal defense, can lead to the fabrication of injuries. Financial pressures, compensation for work-related injuries are also strong motivators. We also found some regional variations. Amritsar College, which represents the Majha region of Punjab, we found 3 studies that originated from this college. These are the major findings of these colleges, these studies. Kumar K et al., who studied these cases from 1997 to 2013, reported 14.77% incidence, and they said that the preferred sites were legs. Goria R. K. et al., they gave incidence as 2.41%, and Kumar K. et al. again, in their study from 2018 to 2020, they said that upper limbs were more predominantly injured. Also, the studies 1 and 2, first and second study, also reported some injuries which they labeled as endangering life. They did not clarify what were those injuries. Faridkot College, which represents the Malwa region of Punjab. Again, 3 studies are there. Buller et al. In 2007, Singh et al. In 2016, and Singh et al. In 2013. There are wide variations in age group and gender distribution also here. Then Singh A et al. And Singh R et al. Highlighted the increasing sophistication in fabrication techniques. They said, as forensic detection improves, those fabricating injuries are adapting and becoming more strategic in their methods. This is an indirect indicator of a trend towards more deliberate and carefully planned fabrications. Actually, trained individuals are making these injuries. They are involved in fabricating these injuries. In the state of Uttar Pradesh, there is only one study which deals with fabricated gunshot wounds. The author said these cases typically originate from a specific area, a village, a town, or part of cities. So they found clustering of cases there. This clustering suggests that the perpetrator is active in that area. The gunshot wounds, they said, are generally either grazing the body or aimed at the extremities, thereby avoiding contact with vital organs or critical parts of the body. We found only these injuries in whole of India. Similar injuries have been reported in Pakistan in areas of Punjab and Sindh. Rahim Yar Khan, this is a place in Punjab province of Pakistan. They reported increase in long bone, nasal bone fractures and firearm injuries. In Sindh region, there was increase in nasal bone fractures and change from small bone to more severe injuries. Now coming to spectrum of fabricated injuries, क्या ये injuries हो सकती हैं? How do these people they try to gain sympathy or legal gain? तो सबसे पहले psychosomatic complaints most commonly found in children, in females. इसमें they fabricate or exaggerate the symptoms of conditions like chronic pains, headaches and other somatic complaints without any corresponding medical evidence. In factitious disorder, they deliberately fabricate, exaggerate or induce symptoms of illness to gain, and the motive is psychological satisfaction. In Munchausen syndrome by proxy, an injury is induced on the child to gain sympathy or attention. Coming to our main part, bruises and contusions. We had a case in GMC Sector 32 when I was working as EMO. The patient presented with V-shaped injuries over back, upper back of chest and back of abdomen. Again V-shaped, patterned bruises. Actually, he had applied some irritant over a stick and then applied the injuries in he was able to apply the injuries only in V-shaped manner. Then incised wounds can be there. Textbooks में दे रखा है, they are superficial, they are easily accessible parts. Tentative cuts may be present. Crisscross cross pattern or chest pattern has also been described. Burns, these may be symmetrical, again on easily accessible parts, mainly caused by cigarettes. Then fractures and dislocations, they find limited mention in forensic textbooks. Even gunshot wounds, they find almost no mention in forensic textbooks. Now coming to cases, again I will not tell you why I think they are fabricated. I will show you some series of photographs and you may be the judge. Can all the cases have similar injuries? Scenario, I have divided them into scenarios. First, long bone fractures. This is photograph of a twin, and I have मैंने सिर्फ वो केसेस इंक्लूड किए हैं जिसमें सिर्फ एक इंजरी थी एंड द हिस्ट्री वाज ड्रामेटिक. 4-5 लोग पड़ गए, बहुत पीटा, मारा पीटा, कई वेपन्स यूज किए. तो केस 1, a 26-year-old male, the alleged weapon was kappa, a sharp heavy weapon. Number of assailants that he claimed was 4 to 5. Corresponding cut on clothes was present. Number of injuries 1. Incised wound on front of left leg, and on X-ray examination there was cortical fracture of tibia. Case 2. Similar injury. Again an incised wound over the front of left leg. He was a 66-year-old male. Alleged weapon was again kappa. Number of assailants were 2. Corresponding cut was again present, and X-ray examination revealed cortical fracture of tibia. Case 3. A 39-year-old male. Alleged weapon sword, talwar. Number of assailants many. Corresponding cut present. Number of injury 1. Again cortical fracture of tibia. Again another patient. Again he had an incised wound over front of right leg, and X-ray again exhibited cortical fracture of tibia. Now a female. Again one injury, और कपड़ों पे कोई stain भी नहीं है. There is such a drastic injury over leg, and there is corresponding cut present, but there are no stains over the cloth. 32-year-old female. Alleged weapon kappa and lathi. Number of assailants 2. Number of injuries 1. Incised wound present over front of right leg. X-ray revealed cortical fracture of tibia. Now a 40-year-old male. The weapon is kappa, a sharp heavy weapon. A sharp heavy weapon. It is so it is a sharp heavy weapon. So sir, number of assailants were 4, number of injuries was 1, incised wound over outer aspect of left hand, and fracture of first metacarpal was there. In case 7, a 30-year-old male. Alleged weapon sword, kappa, danda. Number of assailants 3 to 4. Number of injuries again 1. हाँ सर, कापा commonly वहाँ पर होता है. They actually also use it in assaults. सर काटने के लिए यूज होता है सर, चॉपिंग के लिए. दोनों के लिए काम आता है सर. तो incised wound present over inner aspect of left hand, and fracture of fifth metacarpal. Hand पे first metacarpal and fifth metacarpal are most commonly injured. Then case 8, again a similar injury, weapon sword, assailant 1, injuries 1, incised wound over inner aspect, fracture of fifth metacarpal. Again injury 1, 20-year-old male, alleged weapon gandasi, kappa, datar. Number of assailants 2 to 4, number of injuries 1, and overlapping cuts could be seen in this case. In case 10, again similar injury, similar number of assailants, similar weapon, a sharp heavy weapon, again fracture of fifth metacarpal. So in cases say I can show you 50 cases, even more, and all have the same injuries. अब उस पे corresponding cut भी मिल रहे हैं हमें जहाँ पर मिलने चाहिए. तो how do we prove कि these are self-inflicted or not? X-ray examination of the one of these cases. Case 11. Now the injury has moved. पहले वही सेम प्रेपरेटर होगा, पहले लात में मारेगा, दूसरा पेशेंट को पकड़ के हाथ पे फिफ्थ मेटाकार्पल करेगा, तीसरे पेशेंट को पकड़ के उसका फर्स्ट मेटाकार्पल करेगा. दे कीप चेंजिंग देयर पैटर्न. तो 36-year-old male, kappa 3 to 4, number of assailants, injuries 1, incised wound present circumferentially around the little finger, fracture of middle phalanx. Case 12, fracture of proximal phalanx of left hand. Now coming to firearm injuries. Firearm injuries are also being fabricated on a large scale in the state of Punjab. So this was a patient who presented with 3 injuries over his upper limb and 1 injury over his abdomen. This is the close-up shot of these injuries, in which pallets were found embedded in the wounds. The wounds had scorched margins and the margins were raised. And there was a pale area. A pale area can be seen here. So it was a case of 39-year-old male. Alleged weapon was firearm. Distance of fire was 3 to 4 feet. Number of injuries 4 punctured wounds, raised and charred margins, pale area around the central wound, X-ray examination, pallets in the depth of the wounds. Another case, similar injury, 4 punctured wounds over the shoulder. Again similar finding, charred margins, raised margins, pale area. 49-year-old male, actually he had fired upon someone and that person had died, and he had come with the history that I fired in self-defense. So number of injuries I have already told you, and pale area was present around the center. This is the X-ray of the same case. 5 pellets were there in the depths of the wounds. Case 3 and 4, they came together. This was a politically motivated case. Both alleged firearm injury by the same person in the same incident. Alleged firearm was 12 bore. Distance of fire was less than 1 feet. The alleged firearm was never recovered by the police. This was the first patient, case 3. 2 superficial, which I have encircled, 2 superficial burns were present, and 2 punctured wounds were present with charred margins, and palate could be seen protruding out of one of the injury, which I have marked with an arrow. And the burns and these punctured wounds were equidistant. Case 4, again I will say case 3 and case 4 came together in the same incident, and they said that the same person had fired upon them with the smooth bore firearm. इसमें हमें एक एंट्री वुंड मिला और एक एग्जिट वुंड मिला. एंट्री वुंड पे स्कॉचिंग भी थी और साथ में ब्लैकनिंग भी थी, and there was an exit wound here. The exit wound is present here below. In case 3, we sent the clothes for determining the presence of GSR. Report in case 3 read, the tears in the given shirt are not due to firearm. This report went missing from the court. It was never submitted in the court. Only when the police was reprimanded, only when I produced a copy of the report that the police produced it, again a new challan was filed, and the accused got bail after around 2 years. This was during COVID time. He could not get bail for 2 years. Then case 5, a 35-year-old male, alleged weapon firearm, distance of fire 4 to 5 feet, number of injuries 1 stab wound. On X-ray examination, a foreign metallic projectile was present in the depth of the wound. And सब में क्या होता है, पेन थ्रेशोल्ड बड़ा होता है. क्योंकि उनको पहले एनेस्थेटाइज किया जाता है, देन दीज इंजरीज आर प्रोड्यूस्ड. तो एनेस्थेटाइज कौन कर रहा है? अ ट्रेन्ड इंडिविजुअल. डॉक्टर पे भी आएंगे सर. तो डिस्कशन किताबों में लिखा हुआ है, इनकंसिस्टेंट हिस्ट्री, unusual patterns, lack of corroborative evidence, delayed presentation, multiple injuries, superficial injuries. These have been used to describe the characteristics of fabricated wounds. हमें नहीं मिलते. We don't find it. What we found was that a certain pattern was present, Upper limbs, in upper limbs, left-handed predominance was present. In lower limbs, right predominance was present. In upper limbs, fractures of phalanges and metacarpals were there, and in lower limbs, cortical fractures of tibia were there. Forensic examination, हमारे पास सिर्फ क्या रह जाता है फोरेंसिक एग्जामिनेशन, हम डिटेल्ड डॉक्यूमेंटेशन कर सकते हैं इंजरीज की. अगर गलती हो जाए, जैसे कपड़ों पर स्टेन्स नहीं थे, वी कैन मेंशन दोज, और कोई हमारे पास चारा नहीं रहता है, ऐसा बोला जाता है कि काइंडली डोंट ओपाइन ऑन दीज इंजरीज, ओपाइन ओनली व्हेन द पुलिस आस्क्स यू फॉर द ओपिनियन, ये बोला जाता है. मेडिकल हिस्ट्री ले सकते हैं, बैकग्राउंड चेक कर सकते हैं कि कोई पहले कोई लीगल गेन तो नहीं पहले कोई लीगल केस तो नहीं चल रहा, कोई लीगल गेन तो नहीं मिलेगा. बट वी आर नॉट द इन्वेस्टिगेटिव एजेंसीज अगेन, और एंड द पेशेंट मे नॉट डिस्क्लोज टू यू द पास्ट हिस्ट्री. Then we can correlate with the mechanism of injury. A sharp, heavy weapon produces drastic injuries. The injuries should be compared with the claimed mechanism of injury. Any discrepancies can indicate fabrication. In factitious disorder or Munchausen syndrome by proxy, a psychiatric evaluation may be necessary. Investigative collaboration is very necessary. Working closely with law enforcement is very necessary. पर प्रॉब्लम क्या है, पुलिस वाले भी मिले होते हैं. Coming to trends and patterns, the corrupt practices. Problem है involvement of trained individuals. In many cases, medical professionals are also involved. ये मैं नहीं बोल रहा. Again disclaimer, I have not said this. And there is clustering of cases. This is a news excerpt from a news. Dog convicted of fabricating injuries to frame rivals in 2010 from Firozpur. No firing in Firozpur clash 2013. Bullet injury fabricated reveals SIT report. 2013 doctor fabricates injuries and booked. 2015 the Vigilance Bureau booked 5 persons including a doctor for fabricating injuries. All the cases are from Firozpur. इन जो भी मैंने आपको फोटोग्राफ्स दिखाई उनमें 90% केसेस आर फ्रॉम फिरोजपुर. दे आर कमिंग फ्रॉम ममदौट एरिया, लखों के बहरामपुर. अगेन क्लस्टरिंग कैन बी सीन. एक को पुलिस पकड़ती है, दूसरा खड़ा हो जाता है. In Sangrur also this trend has started. 4 fabricate injuries and they were held. और लीगल इश्यूज क्या है इनमें, इसका हवाला दिया जाता है. राजेंद्र सिंह वर्सेस अदर्स वर्सेस स्टेट ऑफ हरियाणा. इसमें क्या हुआ, एक रोड एक्सीडेंट कहकर केस आया. डॉक्टर ने भी अपने ओपिनियन में ही रोट द कॉज ऑफ डेथ. In the cause of death, he said these injuries are due to road traffic accident. He did not need not mention that, but he mentioned it. I don't know why in the cause of death column. The court said the doctors are not supposed to give medico-judicial opinion inference whether the case is of one of murder or of accident or of friendly hand. इसके बाद पंजाब हेल्थ एंड फैमिली वेलफेयर से एक चिट्ठी निकलती है सब मेडिकल ऑफिसर्स को कि फ्रेंडली हैंड के बारे में, सेल्फ इन्फ्लिक्टेड इंजरीज के बारे में आपने मेंशन ही नहीं करना है. पर पंजाब मेडिको लीगल मैनुअल 2019 किसी ने पढ़ा ही नहीं. पंजाब मेडिकल लीगल मैनुअल में लिख रखा है और उसमें साइट किया गया हाई कोर्ट रूल्स एंड ऑर्डर्स को, जिसमें मेंशन किया गया है कि अगर आपको यकीनन है कि दीज इंजरीज आर सेल्फ इन्फ्लिक्टेड, यू मे गिव योर ओपिनियन, यू मे शो प्रोएक्टिव मेजर. अब फ्रेमिंग ऑफ ओपिनियन में क्या दिक्कत आ रही है, अगेन वी आर नॉट प्रोएक्टिव एज पर माई ओपिनियन एंड माई ओपिनियन अलोन. अगर हम प्रोएक्टिव नहीं रहते हैं इसका मतलब वी आर ब्रीडिंग करप्शन. Why do we limit ourselves to single cases? हमें क्लस्टर ऑफ केसेस मिल रहा है, हमने फोटोग्राफ सब हमारे पास फोटोग्राफ्स भी है, डॉक्यूमेंट्री प्रूफ भी है, हम इकट्ठा करके why can't we give that documentary proof to the authorities? What is stopping us from informing the authorities? After all, it is said sending police information is our duty and not an option. So last but not the least, fabrication is not limited to the living. It is now being seen in dead also to enhance the already present injury or misdirecting the investigation. Recently, in the year 2019 in Haryana, a multi-million insurance fraud was caught. Government doctor was held for writing fraud autopsy reports of dead cancer patients. These are my references. Thank you. Mike.
Yes, sir.
Dr. Arvind, it was very nice presentation. So many photographs of fabricated, suspected, alleged fabricated injuries.
Thank you.
So is there any method where we can point out technically, not through history or any other means, indirectly, by directly looking at the injuries, by noting some features, some technical points where you can directly point out that this is not
until unless the preparator makes a mistake, you cannot do it.
No, you said that the injuries are not correlating. The external injuries, I'm talking about the external injuries, right? So in case of
what happens is, as forensic experts, we are not taking into account the mechanism of injury. हम ये नहीं देखते कि drastic injury है कि नहीं है, वो correlate कर रही है उस mechanism of injury से. जैसे कापटे से मारा पर मिल रहा है एक छोटा सा incised wound. It cannot be made.
Leave the weapon. Don't worry about the weapon. I'm just talking about the mechanism of injury over there. The biomechanics, whether in case of an incised wound,
So
right? And you are showing an underlying fracture.
There are limited studies on biomechanics of fracture. There are very limited studies.
No, in these cases, in incised wound, and you are showing a fracture underneath that incised wound.
I cannot do that. मतलब मैं biomechanics of fracture.
No, not you are not doing. I'm telling you, describing an injury in that way, it may help you in the sense.
You have to move to another question, please.
Yeah.
Any other question?
सर रोहतक वाले होंगे तो ज़्यादा बताएंगे. तो क्लस्टर ऑफ केसेस ही थे. वो एक तो हेड इंजरी वाले. सर देयर वाज ठीक है फिक्स्ड 50 cases which had same pattern of injury on the right side of
उसके ऊपर तो अब SIT भी बैठा हुआ है and number of doctors have been convicted in this case. That happened in Haryana, and some of the cases had come to PGMS Rohtak for secondary opinions also. And this an SIT was there, and a number of doctors were convicted in that case.
Sir, 59 cases and सर 14 cases उसमें ऐसे थे जिसमें 100 के साथ काटी हुई bone and X-ray में 100 bone dust was there on one side of the wound.
अगर स्टेट के बाहर बताए ना किसी को कि ऐसा होता है, कोई नहीं मानता until unless you have visual proof.
Sir, and
10 केस रख दिए इकट्ठे.
and we are writing पटियाला का श्योर कर सकता हूँ कि injury with 2 pinprick marks on each end of the wound with fine bleeding and no pain. ठीक है. Injury, 2 pinprick marks on each end of the wound with no pain. Yes sir.
सर वो कुकिंग हो रही है सर.
आप एनेस्थीसिया की बात कर रहे हैं, 2 पिनप्रिक मार्क. ग्रॉसली आपको दिख रहे हैं कि ऐसे लिख रहे हैं?
सर दिख रहे हैं.
हाँ, तभी आप करोगे फोटोग्राफ से आप करके बता पाओगे. ये आप बना रहे हो, पैटर्न बना रहे हो, इस तरह का पैटर्न बना.
हाँ देखो एक्सपर्ट नेक्स्ट सर फैब्रिकेटेड थी तो सर.
चलो सर, थैंक यू सो मच.
सर हरिंदर सर, यू सेड कि 50 से ज्यादा केसेस हैं आपके पास इस तरह के, राइट?
हाँ जी.
आपने अभी कुछ सोचा कि इसको पब्लिश किया जाए?
सर आई हैव ऑलरेडी पब्लिश्ड.
You didn't mention. आपने अपनी स्टडी नहीं बताई, जितनी भी स्टडी बताई सब किसी और की.
है सर.
नहीं मेरे को नहीं दिखी इसमें, इसलिए मैंने पूछा.
नहीं, वो फेसबुक की वही स्टडी है हमारी.
थैंक यू सर.
थैंक यू.
Thank you, sir. I now request the chairpersons to felicitate Dr. Harvinder Singh. I now request Dr. Amandeep Singh to felicitate the chairpersons. Dr. Sanjay Das. Dr. Arvind Kumar. Dr. Siddhi Pasi. Thank you, everyone.
Our next speaker is Dr. Amandeep Kaur, and I would like to introduce the chairpersons for this last scientific session. Dr. Pankaj Chikara, Professor PGIMS Rohtak, Dr. Sahil Kurana, Assistant Professor GMC Haldwani, Dr. Rupinder Kaur, Assistant Professor Homeopathic Medical College, Chandigarh. I request the chairpersons to occupy the seats, please. I'm delighted to introduce Dr. Amandeep Kaur. Ma'am currently serves as professor in the Department of Forensic Medicine at MAMC, New Delhi. Ma'am holds postgraduate diplomas in forensic science and criminal justice and possesses 15 years of teaching experience. Ma'am has authored 7 original research publications in addition to numerous case reports. And ma'am will be delivering a lecture on the topic integration with allied branches in clinical forensic medicine.
Yes, ma'am.
Thank you.
I know it's the last presentation, technically last presentation of the conference as such. So basically I'll be talking about everything that you have read or heard yesterday and today. So I'll be just compiling that because that was the theme. So I think in little terms I'll be integrating everything that you have heard yesterday and today. So before going into the topic, I think you will see that it's nothing bigger about it because we at few places we are doing this so-called alignment integration with allied branches because either they need us or we need us, and we have already seen that as a human body, if it's there, we have to integrate so that a wholesome thing can be taken out of it and not just single branch can do something about it. So when I was researching for this topic, actually I found a very beautiful article, and in that article it was from by Sir Dr. David Paul. It's a 1977 it's a lecture actually which was put into this publication. It defined forensic medicine as a medicine specialty which applies the principles and practices of medicine to the elucidation of the judicial proceedings. So basically it's what we teach our undergraduates, application of medical and paramedical medical knowledge to aid in the administration of justice. But it's just a better way of putting it. And he also said that it's an anomaly if we just take that forensic medicine from an autopsy table. That is, it's just not forensic is all about dead, because I think when you talk to normal, you can say not non-medical people, they simply ask what do you do, and you just say we do postmortems. So when you talk that, okay, you even deal with the living, that's a new thing for them, because that has become our synonym, that we are the postmortem doctors. But all I want to say is it's not just the thing. And in this very article, he gave a very nice simile. saying that we know that if it's a stage of medical legal play, if homicide and suicide are the main characters, but those main characters are not when seen with other characters which are very small bit players, they are just very small, but when you put every them together, and these bit players are abuse cases, rape cases, when you put everything and together, then it is then what forms a major forensic medicines as such as a subject, not just those two players. So in that context, if we say, when we are in basic terms, if we are dealing with the dead, we are finding some information from the dead, it's forensic pathology. And when we are dealing with the living and doing something as a part of medical legal work, it is said to be a part of clinical forensic medicine. This has already been discussed by Dr. Vijaypal sir. Already he has discussed everything, but in the crux, I just want to say that if someone wants to be a clinical forensic medicine professional, he should be well versed with medical. Basically, when we say if someone is special, has a specialty of one subject, we can't say that, because we get cases of every else, like we are basically jack of all trades, but we can master most of them. So in that case, we have to be good with basic clinical subjects. We have to know basics, anatomy, physiology, because that's how we interpret what we see, and if we have a strong backing, we can at least know how the things are proceeding. So these what we have learned as to what a PG curriculum has or UG curriculum has for a clinical forensic medicine subject. But if we see this is just an Indian concept, but if we look abroad, they use the term forensic physician in Western world. And beyond what we are told that we are supposed to do, they have certain more things that they want, that detainees should also be examined by forensic physicians. They have this refugee problems, or if prisoners are there, they are coming for examination, they have to be done by forensic physicians. So, and finally, if there is, let's say if there is a biological warfare, a chemical, some terrorism has occurred, they want that forensic physician to be part of that. So those are the things that are included abroad. But all that said and done, what we are supposed to do in clinical forensic medicine, what actually is done. If we see in India, we know that clinical forensic medicine work is done by medical officers, or even non-PG, non-academic JRs, what we call, and if not, it's basically in the PHCs and CHCs, primary and secondary facilities. If we go further, maybe tertiary care hospitals, their medical legal work is done by JRs and SRs of non-forensic, you can say fraternities, but forensic people are not that involved much. But yeah, it's not a wholesome thing, but few states do have that, and even if they are involved, they're involved in very few activities, not as everything is done by so-called clinical forensic medicine unit. But if I just want to cover all the bases, if I say globally, when we see the forensic medicine professional work, there they have divided into two parts. They say ki if this system, this forensic medicine system, they say these services are of two types. They say one is integrated and the other is divided. If pathology part, that is a forensic pathology, and clinical forensic medicine part, if they are done by the professional, that is a forensic physician, they call it as a integrated. And when it is done by either, they are like not one person deals with them, different people deal with that, and they are said to be divided. So if I say most of the countries I have searched for, actually there is an article in the clinical forensic medicine Stark book. It has a first chapter of history. It has a study which was done based on the questionnaire by Jason Payne, and they have shown that countries like Scotland, UK, they have this few places they have this forensic physicians, but say in Canada, USA, these examinations are done by not by even the nurses, because they have this in sexual assaults, they have this sexual assault nurse examiner. So they have this SANE, SANE examiner who does these jobs. And even some countries, they have, like Sweden and all, they have this gynae part, this sexual assault part, if it's done for a survivor, it is done by a gynecologist. If these are child abuse cases, they are done with by a pediatrician along with this forensic physician. So it is very different. And even I found an article which was done only for South Asian countries. There it was something very odd. It was like in Pakistan. They say it's an MO can do he's designated as medical legal officer who does this clinical forensic medicine part. Now this MO, not like us just after MBBS, they are supposed to have 2 years of experience before they are labeled as medical legal officers. But in countries like Bhutan, Nepal, they have this MO who don't need that extra training for being a medical legal. Just after doing their MBBS, they can be MOs, just like us. In I think Bhutan, I found that there are only 2 forensic experts, but this study was of 22. They have only 2 forensic experts. Rest of the work is done by medical officers. Finally, it's not that I'm saying they are not doing good work. There was a survey-based study in which it was examined what is the difference or what are the lacunae that were there when an examination for a clinical forensic examination was done by a forensic professional, or if it is what was done by clinicians. So they found that when clinicians were doing it, they either missed the injuries, only 40% of people examined the whole body, clinicians. They didn't even examine the whole bodies. They didn't write the injuries as where it was, what was the size, what was the shape. They just wrote broader, this, present or here. Not much details. They didn't even use the diagram sheet that we have at the back. So it's not that, what I meant to say is, it's not that clinicians are doing it inadvertently. I just wanted to look for what may be the reasons that they are doing it. So I kind of put them into a few categories, if I may say. Attitude towards patients' history taking. The article that I was mentioning that Dr. David Pauls he has compared this clinician, how they are different to a patient and how we are different as a forensic person. So if a clinician is taking patient's history, he is supposed to be, it has to be detailed examination. He has to listen to the detailed history, what he is saying. Eventually, okay, not impartial, because till he has all the facts, he cannot diagnose anything. So he will stay impartial just like us, but eventually he has to be trustworthy. Because if the patients are, if it is the patient who is giving the symptoms and he is telling what he is suffering from, you cannot just judge and say, no, this you cannot be suffering from this or you don't have that symptom. He has to rely on that to form a differentials and the diagnosis. But not with us. We are told from the beginning, take everything in a suspicious way till you can prove it otherwise. So we come from the other angle. So here their attitude and our attitude is different, especially when we are working for medical legal work. Secondly, patient's requirement and priority. Let's say it's a polytrauma case. It has come to the emergency. What is the first thing or what is the first instinct that a surgeon or a JR or SR, JR or SR has? He has, I have to save this, he's bleeding from here. His idea is to take care of that patient, but he forgets that before he stitches that wound, it has to be documented in the very way so that it can be used as a medical legal evidence. So there, his intentions are not bad, but that is what he is taught to do. If you see this, you have to do this. You cannot just escape it. So ideologies are different there. Then documentation, like I said, it's okay, they don't care it's incised or lacerated. All they care is it's a clean wound or not. If it's not clean, clean it or leave it open so that it can be healed. After that you can clean it and then you stitch it. So what they write is CLW. What is a CLW? It can be clean wound, it can be cut lacerated wound, or it can be simple contaminated LW. I mean, it's not a clear term, that's what they use. So maybe it's their flow that they have, because just keep this thing in mind that they just have to write this and stitch, that's all. Finally, evidence. If we have an eye and we know what that case is all about, we know how that case is, finding those evidence is crucial for that very case, we look for those evidences. Here they don't have that. if there is a cut wound or if there is a stab, first thing is they tear off the shirt to look for the depth, see where it's bleeding, if they have this bleeder or not. For us, if that shirt is important, you cannot just tear it from that part. You have to preserve it. You have evidence on that. Even if it's an accident case, there may be glass shards. We need those pieces even if we have to see. Clinicians, they don't care because their thing is different, their view is different. Finally, I think if you ask them ki what all cases or what all legal issues there may be or what are laws are regarding all this, they just know one or two. I don't think they are well versed with the changes that have happened now. So I won't say that it's their fault, but they are special. Their specialty is not forensic medicine. They are just doing it as a part-time job. Finally, what are the repercussions? What if they miss something? What happens after that? It's everyone knows about this. If they miss, in poisoning cases, medicine, JRSR, they do keep gastric lavage. But are they keen enough and do they hand it over to the IO? Sometimes it just keeps lying on the side shelf and then it's thrown off. But if this patient survives for 4 to 5 days and then dies and then it comes to us, our chemical analysis report is negative. But if that gastric lavage would have been kept and sent, or the blood sample had been kept and sent, maybe we would have found something. Similarly, in like I said, in cases like broad dead cases, if they are basically taught how to look for post-mortem changes, because after it has been kept in the freezer, we won't be able to help them, because sometimes in hanging cases, it comes, if it is coming in rigor mortis, why can't they just mention it as in rigor mortis? They have been taught that in forensic medicine in their MBBS curriculum. So at least some part of time since death we can come up from that, especially if they are seeing that thing in the emergency in that very format. Finally, as we know, if this is all wrong, everything goes wrong on the second part. Our opinion, they go haywire, because if they are right, if they don't know, if they cannot differentiate between a lacerated and incised wound, weapon we cannot justify. If a police is bringing one weapon and the injuries of other, we cannot corroborate. Nature, because they are not sure, they are just stitch it and then they call us, forensic medicine call for referral, for forensic opinion. If they already stitched it, what's the point? We won't be able to tell that. We are getting such cases wherein we are called 6th or 7th day and they have already stitched and they just want to fill that tick less, it's a forensic thing. So, like I said, forensic medicine, clinical forensic medicine work is not done as it should have been. But let's just not make it a blanket statement. It is being done. Maybe a few things are done and rest are not done. So I've just compiled you can say a scenario what is being done in various states. But solely it is based on the calls that I have made to people I knew in those states, and it's just 1 or 2 opinions that I've got. So in Punjab, even I did my PG from Punjab, we used to do medical legal reports. We used to make those medical legal reports. We used to be a part of, as a board, we used to be part of a sexual assault survivor examinations. We used to go for age estimations. So those are things that were done, but not that much. Similarly, in Haryana, we used to get referral cases wherein old cases, they used to come as an MLR and we used to give opinion on them. They were review cases. So that was another medical legal work that was being done there. Other than these, and then even I asked in Telangana, they said in AIMS, they said we are not doing much, we just do because we are very short of faculty. So what we are doing is age estimations, and we do give opinions, or we do help the SRs or the JRs who are on duty to help them prepare that MLR. That's it. Madhya Pradesh also, they are not doing much, but they said they are part of 1 or 2 boards. They are even part of negligence board, age boards. Delhi, finally, we have been doing it, not much. Only medical legal work we are doing is postmortems, and if I look for the clinical, all we are doing is part of the age board. Then potency test. Sorry sir, I'm not using the term sexual assault salient examination, I'm using the term potency. But because the accused examination part is done by the GRs and the SS of the other branches who are posted in the emergency. And that last part which is left is the potency test, and that's what they call, and they send us to forensic medicine. Potency test ke liye bheja ja raha hai. That's it. So we are not doing even much. The best thing I found was the Rajasthan. They have been fully fledgedly, what I could found was doing age, doing sexual assault victim examination with obs and gynae, assault assailant examination. If it's a sodomy case, they are doing it with surgery. They are even part of the disability boards. They are doing fitness examinations. What we teach, UG, they are doing it in clinically, they are doing it in OPDs. So they have this full-fledged CFMU working. Now the topic was integration. We have heard about it since yesterday. So I don't think I have done, what I have done is, if I take as a forensic medicine subject, not just the clinical part, but if it clubbed together, we can basically integrate with any branch we want to. Because it's like like I said, jack of all trades, and we can master a few things. So if we integrate with them, they can better our knowledge, and they can learn something from us, and it can be reciprocated. So anatomy, physiology, abortion cases wherein during abortion, if the fetus falls and they have certain injuries, or if it's a criminal abortion case and eventually products of conception are left out. So there they know the anatomy part, we know the injury part. So in that way, if we collaborate, we are not missing anything. Then biochemistry, pathology, microbiology, we are using it, but forensic pathology part. For cases of dehydration, or if it's a diabetes case, or even pathology, we do send tissues for histopathology. Finally, pharmacology. Pharmacology, if a cocktail drugs are taken, and if that cocktail is taken, there can be drug interactions. We may not be knowing exactly we may know individual ones, but when they are clubbed together, whether it's a synergistic effect or the antagonistic effect, they are better people to help us out. There they can help us. Even RFSL at Delhi, they are just doing qualitative tests. They just tell this drug and this drug. If it's a drug which is a therapeutic drug, like a paracetamol, tramadol, they are taken normally. But if they are not giving us the quantitative values, it's of no use. If a person may have taken paracetamol just before he died, but if it's not in a range where it is supposed to be a cause of death, it's of no use. But in our college, they have started doing certain drugs where they're doing it a quantitative test. So we can send those tissues and they ask them, do a quantitative analysis and send us. That can help us out. Rest we all know. Surgery we have already covered. Medicine we have already covered. I think we have already covered most of it. I think there are the two things that I think it will be different will be dermatology and forensic medicine. I had to look up for the articles because I was not well versed with that. So even herpes zoster, sometimes it looks like abrasions. Varicella zoster, it looks like cigarette burns, the way they are shaped. So there it can be seen. Diaper rashes, normally we see, but sometimes they give such kind of redness that it can appear as a sexual assault, child abuse. So there is something that has to be looked. Even subungual melanosis, it's a cancer, it's a tissue, but when it is eroded, it looks like somebody has tortured and pulled out the nail. So those are certain conditions where even more, there were few papers, I couldn't read much of it, but there are conditions where dermatology and forensic medicine can corroborate. Medical genetics, sir has already covered proteomics, genomics. I think I'm not the person to talk much about it. Sciences, we are already doing it. Finally, talk of the art, that is the artificial intelligence. So artificial intelligence is nothing. It's all, we collect a data, we put it in a machine, we let that machine analyze, and when we put another data, it will process it much faster and tell ki, okay, this is this. Now if you want, this can be progressed to this, because now it has formed a pattern. So basically AI is a piece of man-made brain power which permits a machine or a software program to gain from authentic exercises or patterns to foresee new yield streams by utilizing explicit expectations. So they are already being used. If a child was kidnapped in young age and found later on, you can use this AI to just see the progression. What will be the age now and how she will appear now. Even aging of bruises have been done with this AI. Age estimation, even 3D, basically whatever you have, if you put every data into that machine and teach it, it will learn. And it will learn better than a human being because it will go faster and it will progress in that very format. Finally, all this thing, all I want to say is clinical forensic medicine is something which is not explored much, though it should have been a part of us, but it's somewhere left behind. So all I wanted to say was, if let's say ki forensic I know it's a very bold statement, the first one, we should develop it so that others may see that you are not small, you have done something about it, and it should be respected just like any other specialty. Then pathology, it should be, postmortem should be done by forensic, because we know just 1 or 2 years cases, 10 cases that they see in MBBS, and once they become, after clearing MBBS internship, we ask them, okay, write an exam, you become an MO. They cannot do autopsies, but we are expecting them to know how it is done. So there, it's better to have job opportunities open for forensic medicine people, so that even they can get jobs, and finally services may become better. Issues, yes, medical legal issues, it should be done by forensic medicine. In collaboration, yes, because it's an integration. So we can help, we can do our medical legal part, let clinicians do their part, and together that report can be brought forward. Sensitization. People in the emergency, other than the doctors, they should know what is important. If you don't tell them what is important, they will not be looking for it. If you are not there keeping a keen eye, they will lose that. But if you sensitize them that yes, it should be taken care of, they will be keeping an eye on it. Then SOPs should be made. Say standard operating procedures. Yesterday we talked about it. They said, we were told that central it cannot be done, but why not state level? At least it can be made uniform. And if we are doing something and we are teaching those peripheral hospitals, till we can employ forensic medicine people, we can simply ask them to follow it. We can say, yeah, this is what it is a standard, just follow it. And if it is standardized, at least it can be taken as a benchmark. Finally, in-house trainings, because if we learn something, say 10 years back, it cannot hold good today, because the science is progressing very much. So in-house training we need so that we can be better, and external training for the people who are still far behind and still want to learn forensic medicine. Finally, you can very well see that I have become a fan of this article. He said there are 4 principles of forensic medicine: detail, impartiality, suspicion, and observation. So he says that once these principles are mastered, experience and expertise will follow. So in conclusion, I'll say, as long as crime exists, clinical forensic medicine will be there. So if we are the ones, our role has to be extend beyond the dead. We are not just forensic medicine, pathology, we are not just postmortem doctors. It extends beyond that. And the last statement is, if we feel it is inappropriate to care for a patient with chest pain without adequate knowledge of cardiovascular pathology, physiology, management, and implications of our intentions, why should our patient, the survivor of a crime, expect anything less? The main part is this statement. This is from an article which was published by a emergency medicine resident, stating he has written what all they do wrong, and finally they say, if we are experts in something, this is something a crime survivor needs. This is what is expected of them. So if they should also be given this specialty treatment for forensic part, for the medical legal part, not just second hand things. Finally, in our modern society, the living are as entitled to properly trained and expert opinion as are the dead in the field of forensic medicine. These are the references. Thank you. Any questions? Sorry.
Quite food for thought. Any questions for the audience?
सर सबको भूख लग रही है.
Just say one thing.
जी सर.
Awareness is the first step towards learning, and once we are aware that yes, we are lacking somewhere, that's a good thing, that's a good step. And in that context, I would add that at AIIMS Raipur, we have, because we had the fortune of starting a department, we decided to do all medical legal work of the hospital to be handled by forensic medicine only. I have the data on my Google Sheet, which I can access on my phone from anywhere. I can sit here and see what cases have been handled by my staff there. And you will be surprised to know that we are handling somewhere around 7,000 MLC cases every year. And we are handling around 700 autopsies every year. And we have also started DML toxicology. So we are handling somewhere around 350 to 400 poison patients every year at AIIMS Raipur. And we have not yet started in a big way, but we are starting histopathology. We are doing microbiological testing for samples collected from autopsies, and we are going to start forensic radiology as well very soon.
Sir, I think next time, or I should better add Raipur to the list of Rajasthan, I guess. Sir, मैंने डॉक्टर से पूछा. I really think that sir's zeal and I think it should be contagious, and we should also learn something from it and grow. Seriously, this is the growth. See the exponential hai. That's nice. Hanji bache, please.
I am one of the integrated subject you have talked about. I am from dermatology. I am a consultant in Animal Hospital. So you just given the very good example of chicken pox, herpes zoster, and we can very well differentiate it from the clinical things. But the thing which we suffer a lot is from our STI clinics. Like when a patient come, like a few days back, we had a case of poxo. I didn't realize that while examining the patient, but when we asked the age, she was like 17 years old. But she came with her aunt only, and the PGs as we know that the poxo has to be informed, it has to be taken care of by the police, and we need to talk about it. But the girl as well as the aunt, they were all reluctant about that case. So what we do in that case, we have called the police also, the CMA also, and they told us if she doesn't want, let it go. And it happens again and again and again. So what do we do that? We are not like we just what.
It's a case you have to
no, we are just writing on a case sheet only that we are referring this case to the but sir, they don't they
mandatory.
Yes, yeah. Like our PG, I was sitting in other room. My PG told me that ma'am, we have told this to the police, and the police himself told us कि if she doesn't want, let the case go. But as far as we know that it's a crime we are doing, it's a crime. Yes, sir.
Inform in writing and let the onus be on someone else rather than you. Actually, ma'am. Inform in writing.
नहीं मैम एक्चुअली what I would like to tell is we are getting such cases regularly.
Writing a letter.
All on the case sheet only, on the OPD itself.
Right, I'll tell you what we do. At our place, it is very common. Most of the POXO cases, especially when the victim is a male child, we get as genital warts. Dermatology में जाता है, वहाँ पे genital warts होते हैं. So what they do is they give us a call. Right, and we go to the OPD, one of our residents goes, and we advise them what needs to be done, how the medical legal formalities have to be done. That is what we are doing. That is the practice we are following at our institute. Right, so we are.
If I am giving a call and they refuse, the police refuse, what
No,
next we
see,
can
no, you don't have to. The police can't refuse. When you are making a medical legal thing, all you need to do is just call on police control room, right?
I know what you are talking about. Your information you are saying when you are verbally communicating, you have informed. That's not information. You have to document it and has to be sent. That document has to be sent to the police chowki of your hospital or the police station, nearby police station, where they'll receive a copy and they'll give you an acknowledgement in writing.
Talking about the integrated this thing.
Next time call forensic people from your department. We'll handle it. RML we do have, this call us, we'll handle that. Let's start integration from them.
Thank you for the session and intriguing speech.
Yeah.
Okay, sir. Thank you, ma'am. Now I will request the chairpersons to felicitate Dr. Amandeep Kaur.
Before you say that we don't have money, you say I am now inviting the president of ICFMT, Dr. to announce the next conference.
Dr. S.K. Verma, President ICFMT, to announce the next conference. I now request Dr. Dasri Harish, Professor and Head GMC at Chandigarh, to felicitate our honorable chairpersons. Dr. Pankaj Chikara, Professor, PGIMS Rohtak. Associate. Dr. Sahil Khurana, Assistant Professor, GMCA Haldwani. Dr. Rupinder Kaur, Associate Professor, Homeopathic Medical College, Chandigarh.
We now invite the president of ICFMT, Professor S.K. Verma sir, to announce the venue of the next conference.
It's my privilege that we have multiple contestants for the next year's annual meeting of ICFMT 25. We have one from Dr. Chavli from Raipur, Dr. Sanjay Gupta from Rajkot, and Dr. Ashok Srivastava from Lucknow. But after the due deliberations in the executives, it was decided that we should move towards the central part of the country, and Raipur will be an appropriate venue for that. So we announce that next meeting of the ICFMT will be held at AIIMS Raipur, and now I invite Dr. Chavli to say few words about his commitment for the next year.
Thank you, sir, for accepting our offer for hosting the next ICFMT conference. We would be hosting this conference. We have experience of hosting quite a few events in the department. So I think our department would be comfortable hosting this event as well. The place is centrally located in the country and accessible by air, by train, by road from all places. So it will not be very difficult to come down to Raipur. We would like to host this somewhere in October, November next year. That will be a time which would be a comfortable weather for all of us. So it won't be too hot or too humid. We have good rains, we have good heat in the summer, so I don't want you people to suffer during those times. So November, maybe October or November, I'll just get back to my place, talk with my faculty colleagues, and then we'll come out with a date and then make an announcement. Otherwise, we have good facilities at AIIMS Raipur. AIIMS Raipur is a new institute, just around 12 years old. So I think we have good facilities in terms of space, in terms of audiovisual facilities. Our Director, Lieutenant General is very supportive of all the activity that we do in the department, and I'm sure I have not talked to him before putting across my request. So I'm sure when I go back and then talk to him, he would be very supportive in this endeavor as well.
Give a big round of applause to Dr. Chawli.
Thank you so much, sir. Thank you. As far as the registration is concerned, because we know that forensic medicine events are less likely to be sponsored by anyone, we would try to maintain as close to this registration amount as possible. We may have to go up a little bit depending upon the costs, but then we'll try to maintain it as close to this this particular conference, whatever is the registration, will be as close as possible. That's all from my side. Thank you so much, sir.
Thank you very much. Thank you.
Sir? We have multiple places of hotels just across the road from AIIMS, so you don't have much of a problem, and they're all affordable. So it's not very far. You don't even have to use transport. You can just walk down to AIIMS from there.
Thank you, sir. That's very good.
Thank you.
Thank you, sir. This brings end to the pre-lunch scientific session. Now we invite you all to join us for the lunch. And after lunch, the competitive PG paper presentation will start at 2:45 p.m. in the auditorium. And e-poster session will be done in the demonstration room of our department level 2. Thank you. All those who are presenting the paper, please submit your PPTs now.
Thank you, sirs. Now let's begin with the presentations. The first presentation is by Dr. Abhishek Garg, PGJR, GMCH, Chandigarh.
Good afternoon, professors, judges, professors, and delegates. This is Dr. Abhishek Garg, PGJR, third year, Department of Forensic Medicine and Toxicology, GMCH, Chandigarh. The topic of my today's presentation is Alcohol in Blood, Breath Analyzer May Not Stand Test of Time. Road traffic accidents have become an undeniable reality, claiming the lives of approximately 12 lakhs people annually and injuring 5 crore worldwide. Alcohol plays a significant role in these incidents. According to the Ministry of Road Transport and Highways, 4.61 lakhs accidents occur in India in 2022, leading to 1.61 lakhs deaths. Section 185 of the Motor Vehicle Act prescribes the maximum permissible limit of alcohol for driving as 30 mg/%. Analysis of alcohol in blood and breath are two different quantitative methods to determine an individual degree of intoxication. Blood alcohol analysis has traditionally been regarded as the gold standard method. Breath alcohol testing devices are frequently used to screen drivers for drunken driving by the traffic police for the evidence purposes and when the results are put forward in civil and criminal trials. The present study was conducted to check the discrepancy between the blood alcohol concentration and the breath alcohol concentration. The aim of my study is to compare the breath alcohol levels with the venous blood venous blood alcohol levels in suspected drunk drivers or accused brought by police for medical legal examination. In the present study, 178 patients brought to the emergency of Government Medical College and Hospital, Chandigarh, with an alleged history of alcohol intake were examined. Written informed consent was taken from those patients who were not apparently under the influence for medical legal examination. For those who were considered as being under the influence, Section 53 CRPC was invoked. Breath alcohol concentration was checked by using 8818 green worn breath analyzer machine, and at the same time 2 ml of venous blood sample was collected in a vacuum with sodium fluoride as an anticoagulant. This is a digital breath alcohol tester used to check the breath alcohol concentration. In the first photograph showing the warm-up time before blowing in the breath analyzer, and in the second photograph showing method of taking breath sample by blowing air in the breath analyzer. The following chemical process serves as a foundation for the measurement principle. When reddish orange potassium dichromate comes in contact with ethyl alcohol, it shows green chromium sulfate. Venous blood sample was taken to the CFSL Chandigarh for estimating the level of alcohol in blood using a head space gas chromatography flame ionization detector under the guidance of the senior toxicologist. Head space, it is a sampling technique applied to determine the volatiles in the gaseous phase in equilibrium when the matrix to be sampled. Gas chromatography, it is a process of separating compounds in a mixture by injecting a gaseous or liquid sample into a mobile phase, typically called the gaseous gas, and passing the gas through the stationary phase. Flame ionization detector, it is a scientific instrument that measures analytes in a gas stream. It is frequently used as a detector in gas chromatography. The operation of flame ionization detector is based on the detection of ions formed during the combustion of organic compounds in a hydrogen flame. This is the head space gas chromatography flame ionization detector machine which we use to evaluate the blood alcohol concentration, and this is the HSGC, head space gas chromatography vial. This is the results of the blood alcohol concentration shown in the chromatogram. The peak concentration of ethyl alcohol in blood was found to occur between 8.7 to 8.8 minutes in gas chromatography. The regression formula to predict breath alcohol from blood alcohol was derived as y is equals to mx plus c. Majority of the subjects were below 30 years, followed by those aged 31 to 40 years. The subjects were predominantly males. Most subjects, that is 70.8%, reported to the emergency within 2 hours of the last drink. Most of the patients reported to the emergency with alleged history of vehicular accident, that is almost 50% of the cases, followed by physical assault, that is almost 23.6% of the cases. Whiskey is the most common alcoholic beverages consumed, that is 69%. Majority allegedly consumed 101 to 200 ml of alcohol, that is 50.6% of the total persons, and the mean quantity was 337.70 ml. The mean breath alcohol concentration was 141.39 mg per dl, with most cases having breath alcohol concentration between 151 to 200 mg%. The mean blood alcohol concentration was 118.14 mg%, with the highest frequency in the 51 to 100 mg%. In our study, there was 37.2% correlation between the blood alcohol and the breath alcohol concentration. The peak concentration of ethyl alcohol in blood was found to occur between 8.7 minutes to 8.8 minutes in gas chromatography. The study found that breath alcohol concentration was higher than the blood alcohol concentration within 1 to 2 hours of the alcohol intake, but blood alcohol concentration tended to be higher when more than 3 hours had elapsed. Keeping everything into consideration, it is imperative that the proper clinical examination of the person is to be done in the emergency and at the time of medical examination, as we can opine any regarding being under influence only by this. Within the first hour after drinking, the breath alcohol concentration was generally higher than the blood alcohol concentration. Between 1 to 3 hours post drinking, there was a significant correlation between the breath alcohol concentration and the blood alcohol concentration. As more time passes, beyond 3 hours, blood alcohol concentration tended to be higher than the breath alcohol concentration. Our study findings are only comparable when testing the blood alcohol concentration and the breath alcohol concentration is done between 1 to 3 hours after alcohol consumption. Breath alcohol concentration alone is not reliable for alcohol examination in hospitals without testing the blood alcohol concentration, despite blood alcohol concentration being an invasive, time-consuming and expensive method. This is the article which was published on 12th August 2024 in Times of India, Indian edition. Thank you.
Any questions from the audience?
So the blood alcohol and blood alcohol samples were taken immediately at the same time?
Yes, sir. Without any time lapse.
Thank you, Dr. Abhishek.
Thank you, sir.
The next presenter is Dr. Abhishek Kumar, GMC Haldwani.
Thank you. Good Sir. Good afternoon, Judge. Myself, Dr. Abhishek, from PG Resident from GMC Aldwani, Department of Forensic Medicine. First of all, introductions. Attempt of conflict in homicide incident of two the accidental or suicidal ones, not a new phenomena. Neither sense nor when the law were completely successful in either curbing and unearthing such attempts. One decayed one body inside a car found in unconscious condition at a cliff of a hill between Almora to Khairana, Lwani Road in Uttarakhand. He was recovered by local people and shifted to near CSC Government Hospital, from where victim referred to Higher Center Social Authority Hospital, Aldwani. Admitted to unknown to Social Authority Hospital, Aldwani, with alleged history of road traffic accident, treated as a intracranial hemorrhage. Expired 1 day after the admissions. Dead body sent to mortuary of GMC Aldwani for the postmortem examination. As per police regulation, received police paper for conducting the post-mortem examination with alleged history of road traffic accident. As per police Panchnama, deceased died due to injury sustained to head as a result of road traffic accident. On external examination, we found laceration with reddish brown margin 3 cm into 1.2 cm scalp deep, present over middle of the forehead. Second one, an area of abrasion contusion, superficial abrasion, underlying contusions, measuring 2.5 cm into 1.5 cm, present over left side of neck, bluish in color, into that is 1 cm lateral to midline and 2.5 cm above mid end of the clavicle. And third one, the contusion measuring 2 cm 1 cm, present in just below the left angle of mandible, in bluish in color. In internal examination, diffuse subdural and subarachnoid hemorrhage noted over both lobes of the brain. On bloodless dissection of neck, extravasation of blood noted around the layer of muscles present below the angle of mandible over both sides. Second, diffuse extravasation of blood noted over right side of the sternocleidomastoid muscles. And fourth, an area extravasation of blood noted over right side of the sternocleidomastoid muscles. On further dissection, fracture of greater horn of thyroid cartilage noted, and a sixth and fracture of greater cone of hyoid bone noted. And further exploration, diffuse area of extravasation of blood noted over posterior surface of esophagus. An area of extravasation of blood noted just below the epiglottis. Finally, cause of death, injury sustained to the head as a result of blunt impact force associated with findings suggestive of compression of neck. And discussing circumstantially, evidence plays a major role in drawing conclusion about homicidal death. In hilly region and in some regions, road traffic accidents are very common. For criminals, it is very easiest way to stimulate the crime in form of the road traffic accident. And in last in conclusion, that due to compression of neck are one of the most important age investigations unnatural death encountered during the day by day medical works. Therefore, careful and meticulous study of every case is mandatory to bring out comprehensive wide varieties of observation in death due to compression of neck, and also to differentiate the manner of the death. The case like these should be eye-opener only, not only the law enforcing agency but also to the forensic team, including an autopsy surgeons. My reference is this. Thank you, sir.
Any questions from the audience?
आपने अपना जो presentation है, इसमें एक जगह पे उत्तराखंड पुलिस का आपने लोगो लगाया हुआ है.
हाँ सर.
Right?
Yes, sir.
Did you seek permission for that?
No, sir.
You can't do that. ठीक है ना?
Okay, sir.
जो आपने लोगो लगाना है, they are the official. This one, when you put a logo of Uttarakhand Police in your presentation, it implies that Uttarakhand Police is officially it is with you. ठीक है? तो until and unless you have the permission, किसी और institute की आप लोगो नहीं लगा सकते. So please keep that in mind for your future. जब भी आप presentations करोगे, आप अपने institute की लगाओ, but not of any other thing. Okay?
Thank you, sir.
In the
You just written compression of neck.
Yes, sir.
Why don't you write the strangulation?
सर देयर इज नो एनी वायर मार्क या फिर कोई वो ऐसे को नहीं था उसमें कि किसी से उसको कंप्रेस करा हो नेक को.
So what was the other method you could have thought about other than the strangulation?
थ्रोटलिंग सर.
So throttling is strangulation, yeah.
यस सर.
Fair. What is the purpose of writing just the compression of neck? Whether it could be hanging?
यस सर.
It could be hanging. Sure, it could be hanging. You got the head injury also.
सस्टेंड हेड इंजरी के साथ में ही सर स्ट्रैंगुलेशन दोनों से साथ में.
So suppose if you are thinking about the head injury, it goes to suicidal. Even it doesn't go to the accidental case also.
Yes sir.
Then what was the purpose of doing the postmortem and giving the cause of death?
सर एक्चुअली ये पुलिस इन्वेस्टिगेशन तो बाद में हुआ तो उन्होंने दो ये कार में थे.
No, from your findings, what could be the cause of death other than the strangulation?
Head injury.
The strangulation and hand injury both are there.
Yes sir.
Then, so whether it was a road accident or strangulation? Both.
Both sir.
Huh?
Is there any signs or suggestive findings other than this trauma over the neck?
No sir.
So it might be the trauma over the neck, that injuries. I think I am audible. Belt key. It can't be this injuries. It's not a compression of neck basically.
Yes sir.
It might be trauma over the neck.
सर फर्दर इन्वेस्टिगेशंस में उन्होंने एक्सेप्ट करा चीज़ों को कि हमने करा है जो कल्प्रिट वैक्यूम उसमें थे.
So let's move to the next presenter. Thank you.
Thank you sir.
Next presentation is by Dr. Ankita Dhul, GMC at Chandigarh. Good afternoon, respected judges, faculty and my co-delegates. My name is Dr. Ankita Dhul and I am PGJR first year from Department of Forensic Medicine and Toxicology, GMCA, Chandigarh. And I'll be talking about analysis of cases done by Board of Doctors, a 2-year study. So there is no provision in the law which mentions about the cases where a Board of Doctors needs to be constituted for post-mortem examination. NHRC directs conduction of post-mortem examination of custodial death by a Board of Doctors. There are such cases in which a board is required, such as murder, death within 7 years of marriage, sexual assault, custodial death. A board is essential in sensitive cases where public interest or harmony is at stake and is considered to be pivotal in legal and investigative proceedings. Although the exact number of members required to constitute a board is not explicitly specified anywhere except for the NHRC guidelines, the composition of the board generally includes experts from relevant medical specialties such as forensic medicine and toxicology, gynae-obs, path, general surgery, etc., depending upon the requirement of the case and the type of sensitivity of the situation of the case. This lack of formal guideline places significant responsibility on the investigating officer and the legal system to ensure that the appropriate measures are taken to uphold justice in such cases. So the objectives for my study were to identify the epidemiological patterns associated with the cases. Next was to evaluate the underlying reasons and criteria for which a board of doctors needs to be constituted, and to assess the role of various medical specialties involved to make a board. So this was a 2-year retrospective study that was held at 2 major medical institutions. One was our college and the other one was GMS at Sector 16, Chandigarh. And the study period was 1st July 2022 to 30th June of this year. So the results of my study were, we conducted 2,235 cases post-mortem in this 2 years, out of which 88 cases were board. talking about age-wise distribution, so the maximum deceased were among the age group of 21 to 30 years with 28 cases, followed by 11 to 20 years of age group. The most common region to which the deceased belonged was Chandigarh with 69 cases, followed by Punjab with 13 cases. The highest rank of the investigating officer was found to be an ASI with 46 cases, followed by a senior head constable with 20 cases. The most common reason for which a board was requested was found to be dowry cases in 44 cases, followed by hanging in 23 cases. The most common alleged history was a fight, be with any neighbor or a shop vendor, followed by marital dispute in 21 cases, and brought in dead were 11 in number. The different type of samples that have been asked to preserve during the post-mortem examination were of blood and clothes in 18 cases, followed by ligature material in 8 cases. The board consisted members from different specialties, as I mentioned earlier, were maximum from forensic medicine and toxicology in 67 cases, followed by emergency medical officer in 20 cases. The section under which the cases were conducted was CRPC 174 with maximum cases, followed by 176 CRPC in 22 cases. So what we concluded in our study was that since there are no such written guidelines for a board of doctors to be constituted, and no specific reasons why they were done so, and the most common rank of IO who had brought the case was an ASI in almost 53% cases, which is in accordance with the rank of the IO, but we found that even in 6 cases the investigating officer was an inspector. The maximum members of board were found to be 2 in number, and out of which 76% of the board members were from our department. So my question is, if a single investigating officer can hold the investigation of such cases, why can't a single doctor conduct the post-mortem examination instead of making a board of doctors, especially in cases of brought-in dead where we don't know what happened? So, thank you. हाँ जी सर. So minimum 2. Sir, it is stated only in the NHRC guideline that minimum 2 members should be there. One should be forensic expert and the other one could be from any specialty.
Do you have the document of that, the number of board members?
No sir.
No, you are telling the NHRC guidelines are there.
Sir, I've read about it that the NHRC guidelines, they say that only a minimum of 2 members should be there to constitute a board, but they have not mentioned the reasons in which.
In your place, who has the authority to constitute the board?
Sir, head of the department of.
No, the request comes from the IO.
Yes,
constitute
sir.
the board.
Yes, sir. So that is why.
Does he give the guidelines? What are the guidelines? Why the board has to be constituted in
No sir, that is what my question is, how do they decide in what case or which case the board should be constituted? Because it is constituted even in a case of doubt.
The same question can be put to the IO whether he can define this. If the same question, why the board has to be constituted? So you just give in writing. That is the thing. He should give in writing that it is a public case, suspicious case, and constitute the layer. तो फिर फायदा क्या ना हमें सारे केसेस में एक्चुअली
वो ये लिखता है कि मैंने आपसे कहा है बोर्ड बना दो, आप नहीं बना रहे हो तो लिख कर दे दो कि नहीं बना रहे हो.
Actually, in Delhi, there is a set rules of constitution of boards.
Yes,
That
sir.
is,
होना
the
चाहिए.
application by the IO is put by the DCP to the secretariat, and from the secretariat, health secretariat, the application, if they consider that board has to be constituted, then they give the guidelines and give the authority to the HOD to constitute the board in that case.
Yes, sir.
But not in all cases. They are the set guidelines in which cases the board has to be constituted. So it is good if you can start this practice in your चलाओ ना। हर मर्डर केस में, डाउरी केस में तुम बोर्ड बना रहे हो। Thank you.
Dr. Ankita, what I understood, it was a 2-year study. So it was your college and GMSS Chandigarh. So there were 2 to 3, 5 cases, out of which 86 cases comprised of boards. Now, just for my understanding, I just want to know what is the practice in different places. So that is what I want to know. So do you maintain a register? I mean, you and your college, and if the register, obviously it is maintained. Is it in hard copy form it is maintained, or it is in the form of online, or what is it like?
Hard copy, sir. In the form of hard copy, we have 2 different registered.
Yeah.
One is for GMSS 16 and one is for our college.
Yeah, fine. Yeah, it's.
GMS at 16 is supposed to be a secondary healthcare hospital, and we are the tertiary healthcare hospital for the Chandigarh administration. So we are the medical legal experts for Chandigarh administration. So जितने भी board cases होते हैं, उसमें हमारे hospital के हमारे department के लोग they become the chairpersons. So and second thing is because we have 5 PGs per year. And we get, I mean, we do around 800 cases or so. तो हम GMS at 16 में भी 21 दिन करते हैं out of 1 month. 21 days we do postmortem examination in both the places because we want to have maximum exposure of our students. So that is why we have record of both the hospitals with us.
Yes.
Yes, sir. We post our doctors there. एंड वो कुछ पीजीस वहाँ पे करते हैं, कुछ पीजीस यहाँ पे करते हैं, वो रोस्टर हम ही बना कर देते हैं सर.
Thank you for the clarification, sir. Secondly, so what I understood, it is maintained in the form of hard copy.
Yes.
So obviously it is entered manually. And secondly, do you have a clear-cut definition of which cases goes as a board of EA, or is it mentioned in that register that this was done as a board case?
So we have
Or do you have a
separate.
clear-cut definition that these are the type of cases which should be done by a board of doctors?
No, sir. Not like that.
Then how
Only date-wise.
did you then get those data, 88 cases, when you were searching for when you were going through the last 2 year cases?
Yes, sir.
So how did you get it like?
So we have a list of cases,
Okay.
out of which we like mention board case. Like this was a board
that's
case.
that's what I
Yes.
asked you.
Yeah. Yes, sir. Yes,
Do
sir.
you have a list of cases, or is it mentioned in the register that these cases were done as board of cases?
Yes, sir. Mention, like we mention separately that this was a board case done by this and this doctor.
That is
on this
mentioned in the
date.
register?
Yes, sir. In the
Okay.
register only.
Right,
Yes, sir.
right. Thank you. Because that's what happens whenever we are going for retrospective collection of data, some of the informations will be missing. So we end up losing many cases which, if it is not entered properly or correctly in the register.
Yes, sir.
All right, that's what I wanted to know. Right. Thank you.
Thank you, sir.
Thank you, Dr. Thank you, Dr. Ankita.
Thank you, sir. So our next presenter is Dr. Arsh Agarwal, SIMS Bareilly.
This one only. Good afternoon to one and all. The topic of my paper presentation is profiling of autopsy cases at postmortem house Bareilly. It's a retrospective study. Worldwide, 6.6 deaths per 1,000 population occurs per year. In our study, road traffic accidents remain the most common cause of death. A total number of greater than 4,50,000 road traffic accidents have been reported by the Police Department of States and Union Territories in the country during the calendar year 2022, claiming more than 1,50,000 lives and causing injuries to greater than 4,40,000 persons. The aim of the study is to set up a profile of death due to unnatural causes so that the study can direct rigorous efforts to limit their incidence. With the outbursting population, more than 50 lakhs in the district, increased level of substance abuse, meager infrastructure facilities, various types of morbidities, increased vehicular traffic density, the number of medical legal cases is on the increase in number. To observe the overall pattern of autopsy cases at postmortem house is the main aim of my study. Data reported over a period of 1 year from 1 July 2023 to 31st of June 2024. This retrospective study covered all cases of death brought for autopsy at postmortem house. The death variables that are analyzed includes sex, age, area, causative agent, and cause of death at autopsy. The data were collected and tabulated to determine the frequency and proportion of these fatalities, and the results were expressed in percentages. Study location is Postmortem House, Bareilly, as well as Department of Forensic Medicine and Toxicology, SRMS-IMS, Bareilly. As told earlier, it's 1 year retrospective study. Study was commenced after getting approval from Institutional Ethical Committee. All the medical legal cases autopsied at Postmortem House, Bareilly are included, whereas cases with unknown identity as well as cases in which cause of death could not be ascertained, whereas cases in which decomposed bodies are found are excluded. Coming to sample size estimation, during the study period, a total of 2500 cases of medical legal autopsies were performed. By consulting with a statistician, he used a formula, that is Sloven's formula, for which we took approximately 345 cases that represents the whole sample size. So the formula is number of sample equal to n divided by 1 upon ne whole square, whereas ne whole square is margin of error, that's taken to be 5%. So the samples that we have to take is approximately 345 cases. Coming to results, 75.9% were males as well as 24.1% were females. 30.5% males and 30.1% females were from age group 21 to 30 years, and it's the maximum number amongst the category of all age groups. 31.3% from age group 21 to 30 years were from rural areas, whereas 31.4% from the age group 31 to 40 years were from urban areas. 67 females and 208 males were from rural areas, whereas 16 females and 54 males were from urban areas. 52.2% died due to road traffic accidents, amongst which maximum, that is 47.6%, that is 50 cases, were from the age group that belongs to third decade of life only. 30.4%, that is 105 subjects, died from the age group 21 to 30 years of age. Maximum number of deaths are from rural areas, that is 79.7% to 75 subjects. Out of all the cases autopsied, maximum number of cases were in age group third decade of life, that are basically the most productive years in one life. Finding of our study are consistent with finding of study of other authors such as Anand sir, Khaja sir, Pramod sir, as well as Manish sir. In our study, majority of the victims were males, that is 75.9%, as told earlier. Similar findings are seen in studies of other authors also, that I have told earlier. Males are found more vulnerable to unnatural deaths due to accidents, violence and stress because of their nature of work. That's why male predominance is more. We can say that rural residents are the most amongst the autopsied cases. Findings are similar or consistent with the findings of other authors. Deaths due to road traffic accident and its complication constituted the majority, that is 52.2%, followed by hanging and then by train accidents, that is 9%. Findings of our study of maximum RTA cases are consistent with findings of other authors, that is listed following. In a present study, majority of cases were male from third decade of life residing in rural areas. Maximum number of deaths were due to road traffic accidents, followed by hanging and train accidents. The study might help to interpret different types of medical legal autopsy cases, thereby providing an insight to the policymakers, law custodians and community to look into the specific aspect of the cases and then to take proper measures accordingly for the benefit of the community at large. These are my references. Thank you so much.
Okay, let me understand what you did.
Yes, sir.
What you did was you said that your department performed 2500 cases in 1 year.
Yes, sir.
And you said you are going to do a demographic profile.
Yes, sir.
Right?
Yes, sir.
When you do a demographic profile, why did you choose a sample size?
Sir, because the population is large, approximately 2500.
2500 is a large sample. It's a 1 year study here.
Yes, sir.
How is it a large sample? आपने जब डेमोग्राफिक प्रोफाइल लेना है तो उसमें आप सैंपल साइज कैसे ले रहे?
सर स्टैटिस्टिशियन से कंसल्ट किया था तो ही
तो आपने जो सैंपल साइज लिया 349, 345 जो भी लिया आपने सैंपल साइज, दीज वर 1 to 345 और 346?
No sir, daily one cases, daily one case.
Whatever.
Yes sir. No.
So how did you select? What was the, how did you select your cases?
First case.
ये सारे केसेस तुम्हारे फर्स्ट केस एक्सीडेंट के होंगे तो तुम्हारे पूरे साल में सारे एक्सीडेंट के केस ही होंगे. मे बी यदि आप सेकंड केस लेते तो हो सकता है बर्न्स के केसेस ज्यादा होते.
सर सारे फर्स्ट केस एक्सीडेंट के नहीं थे, मतलब देयर वर वेरिएशन.
नहीं, योर सिलेक्शन, व्हाट वाज द बेसिस ऑफ योर सिलेक्शन?
We took it as opportunity. We consulted the statistician. He said we can take the stratified random sampling. So every month the 10th case was taking, 10th case onward उन्होंने लिया. तो after this study is not complete. What we said कि इसके बाद we will do the whole profiling of 2500 cases and we'll find out कि statistician के जो सैम्पलिंग है और उसके जो होल हम प्रोफाइलिंग जो सर आप कह रहे हो कि होल प्रोफाइलिंग, उसमें क्या डिफरेंस आता है, राइट? एंड वी विल फाइंड द ऑथेंटिसिटी ऑफ स्टैटिस्टिशियन जो मैं कहता है कि पूरा सैंपल ना लेके यू कैन टेक द रिप्रेजेंटेटिव सैंपल. सो इट इज ओनली द पार्ट ऑफ द स्टडी ही इज प्रेजेंटिंग. In the next, we are going to do the whole profiling of this study. Yeah. Thank you.
Doctor, did you take into account poisoning cases?
No sir.
No. Why?
Only medical autopsies.
Poisoning deaths. Poisoning deaths. Because you have not mentioned poisoning deaths, I think.
Sir, only 15 cases I found.
नहीं 0 to 10 year. So you got reports of chemical analysis for all the cases?
No sir, it's just a profiling. So
आपके पास जो पॉइजनिंग के केसेस आए 2500 केसेस में से डिड यू गेट रिपोर्ट्स फ्रॉम फॉर ऑल द केसेस?
यस सर.
सबकी आ चुकी हैं. व्हाट वाज दिस
2500 जो हमने डाटा लिया.
तो यूजुअली व्हाट टाइम पीरियड, व्हाट इज द टाइम लैग बिटवीन सेंडिंग द सैंपल, विसरा सैंपल, एंड बाय द टाइम यू गेट द रिपोर्ट? कितना टाइम लगेगा? हमने भी की है रेट्रोस्पेक्टिव स्टडीज. 2 साल हो गए, रिपोर्ट नहीं होती हमारे पास कई बार.
रिपोर्ट तो इनके पास भी नहीं होगी.
तो फिर वो पॉइजनिंग केसेस फिर दिस इज तो
they are labeled as a
मतलब लेबलिंग हो गया सर ऐसा पॉइजनिंग.
So they may not be a natural death. They may not be a natural death. So thank you, doctor.
Thank you so much.
Next presentation is by Dr. Divya Kumari, UCMS Delhi.
Good afternoon, everyone. My presentation is Trauma and Hanging, an unusual case of complicated suicide. Suicides are very frequently encountered by forensic pathologists in our day-to-day work. There are some peculiar forms of suicide where the primary method chosen by the victim fails and the death occurs due to a secondary, accidental and unpredictable complication. These are called complicated suicides, and these are different from complex suicides where the victim employs more than one method to ensure his death. So I am presenting a case of complicated suicide. A 65-year-old man was found stuck in an elevator shaft. As you can see that from the diagram, he was found stuck between the lift and the wall. He had a ligature around his neck, and the other part of the ligature material was found tied to the balcony railing up above. It was concluded that the ligature broke during a failed attempt at hanging. A diary was found in his pocket, which chronicled the whole circumstance of the suicide, including detailed suicide notes, thus eliminating any suspicion for homicide. On examination, we found bright blood stains in both nostrils and subconjunctival hemorrhage in the left eye.
The upper part of the body was congested with a clear line of demarcation, as you can see, and fingernails were cyanosed. 2 faint ligature marks were present on his neck in form of pressure abrasion, parchmentized and places, and there was a pressure abrasion on the left side of the chin, suggestive of the knot. We also found a swelling with underlying hematoma on the right side of the neck, and there were lots of abrasions and bruises present over the body. On internal examination, we found fractures and extravasation of blood in the head, as you can see. In brain, we found subdural hemorrhage, subarachnoid hemorrhage, contusions, and pontine hemorrhages. On layer dissection of the neck, the tissues underneath the ligature mark were dry, whitish and glistening. Extravasation of blood was present over the strap muscles and over bilateral carotid sheaths. Osteocartilaginous structures were intact. We found multiple petechial hemorrhages on lungs and heart, including the base of aorta. All organs were congested. Cause of death was determined to be a combined effect of asphyxia and craniocerebral damage. So, complicated suicides are rare events that pose a significant challenge in the field of forensic medicine. The manner of death can remain unclear and ambiguous even after a thorough crime scene investigation and autopsy. This case, the case I presented, was ruled as suicide only because of the presence of a detailed suicide note. Opinion about the cause of death also could not be definitive in this case, considering we found findings of both traumatic asphyxia, that is wedging, and head trauma. Gwendolina Gentile et al. Published a similar case in Milan, Italy, where an elderly man killed his wife and then he tried to hang himself by tying a rope to the heater and jumping out of the window. So the rope broke and he fell to the ground. Careful investigation of crime scene showed that the rope had not been tampered with, so the possibility of homicide was ruled out. The autopsy examination confirmed multiple blunt traumatic injuries, especially on the head. He also had injuries on chest, abdomen, and pelvis. All the injuries were antemortem because there were hemorrhagic infiltration of blood. So the death was attributed to fall from height and not due to asphyxia. Similar studies are done in Budapest and Genoa, Italy, where they did a series of suicides and found similar cases where failed attempts at hanging resulted in death due to trauma. In one case, the balcony where the victim was hanging collapsed. In another case, the victim had tied the rope to a tree branch and the tree branch broke. And obviously, couple of cases, ropes broke and the victim fell down. So in all the above cases, the cause of death was determined to be trauma and not asphyxia. But in our case, we couldn't definitively rule out wedging or traumatic asphyxia because our body was found wedged in a confined space, unlike these cases where these hangings were done in open spaces. This is not the only way complicated suicides occur. Tora and Pollock reported multiple cases of complicated suicides. In one case, the victim tried to climb an electric pole to electrocute himself and suffered blunt injuries when he fell to the ground. In another case, one person tried to hang himself on an electric pole and was electrocuted. One man jumped into an elevator shaft but did not die from the fall but died due to drowning in a pool of water at the bottom. Another victim who had taken an overdose of drugs, he fell to the ground and sustained fatal head injuries. So the gist of my presentation is, as evident from all the above examples, complicated suicides pose a challenge to the forensic investigator, especially regarding the manner of death. So these cases require thorough investigation of the crime scene as well as careful autopsy, including all the ancillary investigations to reach a satisfactory conclusion and reconstruct the chain of events. These are my references. Thank you.
Any questions from the audience? Thank you, Dr. Divya.
Thank you, sir.
Next presentation is by Dr. M.Y. Sai Vipul, GMCH Chandigarh.
Good afternoon to the respected judges, delegates and my dear fellow residents. Myself, I am Dr. M.Y. Sai Vipul, PGGR first year from the Department of Forensic Medicine and Toxicology, GMCH Chandigarh. Today I am going to discuss about autopsy, challenges and feasibility at ground level of our country. An autopsy is an integral part of the criminal investigation of death of the humans and was in practice from many years. And many a times it becomes a very important piece of evidence in the court of law for settling different issues related to death of an individual. We all can safely state that the radiological knowledge, especially that of X-rays, has been used in forensic medicine from many years, and it is an integral part of our curriculum too. In the recent past, the advancement of technology in the investigative medical field was rapid. Using this technology in the conduct of autopsy led us to a new procedure, namely autopsy. So the term autopsy was coined by Professor Richard Dönhoff from the University of Bern, Switzerland, and it is a combination of two words, the ritual and this autopsy. This technique is non-invasive and blends the advanced radiological knowledge with the traditional forensic knowledge. And it uses many modern and sophisticated imaging techniques like multi-slice and multi-detector CT, MRI, MR spectroscopy, MR microscopy, CT angiography, image-guided percutaneous biopsy, body surface scanner, 3D reconstructive software and many more. So certainly it has more advantages than conventional autopsy. So some of its advantages are, it is definitely observer independent and non-invasive, less time consuming, and it provides ability to examine the bodies that are contaminated by infection or other biohazards. And it is accepted in cultures where the autopsy was not tolerated, and it provides easy and secure storage of reports. 3D images that are generated by this technique are more precise in regards to some injuries like stab wounds or firearm injuries. Air or fluid accumulation in cavities or hematoma can be better demonstrated. And with the help of CT angio, we can even assess the vessels more precisely, and there are many more advantages. But the big question is, how far is it feasible in our country at ground level? So as I mentioned earlier, autopsy requires highly sophisticated and costly equipment like CT, MRI, etc. So setting up these facilities requires somewhere around 10 to 15 crores. And in addition to this, it further requires around 1 to 2 crores as a running cost per annum. So sparing the central government funded institutes, almost all other institutes are under budgeted and many are in cash crunch state. And sad to mention that many other government hospitals do not even own a MRI machine. Even if they have one, the average waiting time for getting scans done in the Department of Radiology in many of these renowned institutes is in the range of 3 days or to even over a week. If this is the situation for the live patients, then we can understand the facilities for the dead. And these are the newspaper clippings in renowned newspapers suggesting the condition of our mortuaries. We can see that the mortuaries in Noida, which is close to Delhi, and even in Delhi, we can see that there are no defreezers or cold room for the storage of the bodies. There is a shortage of bandages to mortuary bags, and in UP, certain mortuaries there is no dignity in the dead. And coming to the in Mumbai deadly mortuaries, the bodies are stacked atop each other. And coming to the east, the Rims Ranchi, the mortuary is on deathbed. 4 places were actually defunct and bodies getting rot. And near Kurukshetra and Kaital, the rats found nibbling at dead bodies. Seeing the photographs of stained and rusted instruments that are in use at Sabji Mandi Mortuary, Delhi, on September 16, 2015, the Honorable Delhi High Court, it remarked, what the people have to endure is disgusting. The apathy and the situation makes one want to resign and run away. You think mortuary belongs to dead people, so everything there should be dead? These tools should be in museum. If this is the condition of mortuaries in India's capital and other premier cities, certainly we can understand the situation of mortuaries at other places. We have to question ourselves, how many of our mortuaries even have a functional X-ray lobby? Moreover, how many of us have the radiological knowledge to interpret the sophisticated scan reports? So advancing with time and taking our speciality to new heights with the new innovation is must, and we need to encourage it. With the due respect to autopsy, we are not against it. Moreover, we are in awe of its merits and hoping that in the near future, it can be used as a supplement to our conventional autopsy, further on improving the accuracy of our reports. But considering our present situation and conditions, is it even reasonable to speak about this new technologies replacing our conventional autopsy and chanting its merits? Instead, it makes more sense to raise awareness about the poor working conditions of our mortuaries and trying to improve them to reach the standard treatment levels. Thank you.
Any questions? Thank you, Dr.
Thank you, sir.
Next presenter is Dr. Manika Bhatia, GMC Amritsar.
Good afternoon, respected judges and my fellow colleagues. I, Dr. Manika Bhatia, junior resident from Government Medical College, Amritsar, is going to present a case report on gruesome murder of a pregnant woman under the able guidance of Dr. Kuldeep Kumar, Professor and Head, Department of Forensic Medicine and Toxicology, GMC Amritsar. Before starting, let's shed some light on National Family Health Survey done in 2019-2021 that stated that 29.3% of married Indian women ages between 18 and 49 have experienced domestic and sexual violence. 3.1% of pregnant women aged 18 to 49 have suffered physical violence during their pregnancy. And this is the only number of cases reported by the women. There are frequently many more that never make it to the police. To begin with the case, an application was moved by police official dated 20th April 2024 to conduct a postmortem examination of a burnt and charred body of a female. As per the preliminary investigation, the woman was 6 months pregnant. She was beaten by her estranged husband, tied to the bed and burnt alive. As per police, her husband is a chronic alcoholic, drug addict and involved in antisocial activities. This was believed to be the major cause of conflict between the couple. On external examination, heat stiffening of the body was seen and charred and burnt at places. Most of the scalp hair was spared. Face was blackish in color with swollen tongue clenched between the teeth. Left forearm and right and left lower limbs were missing with no infiltration at the exposed ends. Postmortem fractures were found in the left humerus with deep burns and complete charring of the left limb. On further examination, right upper limb was found to have deep to epidermal postmortem burns. Protrusion of the intestines was seen from the left lateral side of the postmortem abdominal defect. Left upper and lower limb was completely charred with multiple postmortem fractures in the left femur. On internal examination of the skull, a lacerated wound of size 4.3 into 2.2 cm was present on the left side of the head, placed 4.1 cm from the left mastoid and 2.8 cm above the occipital protuberance. The wound is surrounded by diffuse swelling extending to the front and back of the head involving frontoparietal region. On dissection, subgaleal hematoma was present on the left frontoparietal and occipital region. Fissured fracture of left frontal and left parietal bone were present. Infiltration of blood was present at the fractured site of the skull bones along the coronal suture line of the left side. On internal examination of the brain, extradural hematoma with dark colored clotted blood on occipital region was seen. Membranes were intact. Subdural hematoma was seen on left temporal lobe extending to the base of the brain. On internal examination of the neck, yellowish discoloration of underlying soft tissue was present on places. Two dark reddish colored hematoma of dimension 2.1 cm into 1.5 cm and 1.9 cm into 1.6 cm respectively were present on the either side of the neck, 2.3 cm above the level of the thyroid cartilage. Infiltration was present on the underlying strap muscles. The trachea was congested. Thyroid cartilage, cricoid cartilage and hyoid bone were intact. On abdominal dissection, a uterus was found at the level of umbilicus. The uterus was enlarged and of the size 18.5 into 15.5 cm. On dissection, a bag of membranes were found. It contained one dead fetus along with intact umbilical cord and placenta. Fetal length was 33 cm, head circumference 25.5, chest 21, foot length 6.8 and abdomen 18 cm in circumference. Fetal weight was 830 grams, eyebrows and eyelashes were developed.
Ossification center was present in the manubrium and one center present on the upper part of the body. Probable age of the fetus was 6 to 7 months and the gender was female. To conclude, domestic violence in India is a systemic strategy of creating fear and subservience in an individual in a domestic environment such as home. The motivation for this aggression might range from a desire to retain a person's power over another to instilling or coercing another individual for self-gratification. The Protection of Women under Domestic Violence Act of 2005 defines domestic violence. Before this act, matters regarding domestic violence in India were controlled by Section 498A of IPC, but it had two flaws. The first is the lack of any provision offering relief or compensation to the victim under this section. Second, Section 490A exclusively applied to the married women. To address these flaws, the Centre adopted Domestic Violence Act of 2005. To conclude, the Domestic Violence Act provides redress such as refuge, medical facilities, a protective order, a compensation order, and so on. And now this has been replaced by Section 85 and 86 of PNS. Women who have lower household income, illiterate, are belonging to the lower caste and have a partner who drinks or bets are found to be an important risk factors and place women in India at a greater risk of experiencing domestic violence. Therefore, action must be taken to fight domestic abuse against all victims regardless of age, gender, and not only women. Thank you. These are my references.
What was the cause of death?
Sir, head trauma.
Head trauma. And what about the that defect in the abdomen from which the intestines were protruding out? You haven't told us, was it antemortem or postmortem?
Sir, it was postmortem. I have mentioned it. On the left side, there was a postmortem abdominal defect.
Okay, ठीक है. Thank you.
Your presentation was a case report.
Right, sir.
Okay, it was a case report of approval order of this one. So my only one question was, what is, I mean, we do encounter these cases. Is there something special about this case?
Sir, police, they told us that she has been burnt alive.
But you couldn't find out because this was a 100% charred body. Were you able to find out that whether the burns were antemortem or postmortem?
So the infiltration was not present at the broken ends of the bone. Moreover, there was extradural hemorrhage, and we've also sent the blood clot for the carboxyhemoglobin levels, so we can find out from there.
Were you able to distinguish whether this was extradural hemorrhage or heat hematoma?
Yes, sir, we were. So the heat.
What were the different? I mean, why do you say that this is EDH and not this one, heat hematoma?
So the clot made from a heat trauma is usually friable and it has honeycomb appearance. The extradural clot formed by the extradural hemorrhage is, it has no honeycombing appearances because there is no air collected. No, sir. From the gross, it was not friable. It was fixed. It was, we could take it out from the dissection. So subdural hemorrhage was also present. Also, heat hematoma is mostly present at the parieto-temporal region. This was frontal.
So, heat hematoma is not present at the parieto-temporal area. Heat hematoma is present where the head or the skull faces the maximum amount of heat. So it can be anywhere. Okay. So my question is, why do you say that this is antemortem?
So there was infiltration at the fractured ends of the head, and the blood clot, even though we have sent it for the examination, the blood clot was of the extradural hemorrhage. It was not friable. It was dense.
Thank you.
Can I just one question? With the permission of, yeah, just one. What was the cause of SDH? Was there any history of trauma?
Yes, sir. She was first beaten. She
Over
was
the head region?
Yes, she was
Did you
first
find any
beaten.
fractures of the skull? Anything
Yes,
like
sir. We found the fractures at the skull. There was a fissured fracture at the skull.
that? Or maybe I missed out on the photos.
Sir, the photo is not clear, but yes, there is like I have
Because
mentioned.
many findings you had written down, but there was no evidence of photos. So nowadays, it's the age of evidentiary medicine, evidence-based medicine.
Right.
So if you're not giving the photos and just writing down, it doesn't give a very, good impact on your presentation.
Right, sir.
Yeah, right. Thank you. I can see. Right. Maybe I had missed out on this one. Thank you.
Thank you, sir.
Next presentation is by Dr. Monica Sharma, GMCH Chandigarh. Good afternoon, respected judges and dear delegates. I am Dr. Monica Sharma, third year PG resident in the Department of Forensic Medicine and Toxicology, GMCS 32 Chandigarh. Today my topic of talk is the protection of privacy and dignity of sexual assault survivor, victim, ethical and social consideration in the present day context. How the privacy is compromised and what does it impact on the survivor? As technical surveillance and dissemination of news just a click away, the individual's privacy is at risk. In offences like sexual assault, protecting the privacy and dignity of the survivor is of paramount importance, but it is infringed by the viral spread of photos and videos, maybe just for the fun, or it's by the so-called well-wishers. Thus, it escalates the trauma which is experienced by the survivors. It leads to the loss of confidentiality, privacy and anonymity. Victims endure public humiliation, stigmatization and threat to their safety. Disrupts their personal and professional lives. It becomes a barrier to recovery and process of healing. These violations constitute a breach of trust in the legal system and are punishable offences under the law. Furthermore, they hinder the other victims for seeking help. What the law says about this? Under Section 72 of BNS, the identity of victim allegedly involved in offences which are under Section 64 to 71 should not be disclosed or made public. Further, they are punishable as 2-year imprisonment and fine. What are the law regarding the minors? In India, there are two acts. One is the Protection of Children from Sexual Offences and second the Juvenile Justice Act 2015. According to POCSO, under Section 23 of Section 2, confidentiality of identity, it prohibits disclosure of the identity of a child survivor, name, address, photograph, family details, school, neighborhood or any other particular leading to disclosure of identity prohibits from being made known. Section 24, subsection 5, it requires police official to ensure that identity of child is protected from media unless directed by special court. Section 33, special court shall ensure that identity of child is not disclosed at any time during course of investigation or trial, provided that for reason to be recorded in writing, the special court may permit such disclosure if in its opinion such disclosure in the interest of the child. The Juvenile Justice Act 2015 states, Section 72 protects the privacy and confidentiality of children involved in any proceeding, maintains the confidentiality of identity of child whether as a victim, witness or in conflict with the law. It prohibits the disclosure of identity in any media, magazine, publication or social media. The exception for it is when it is for the best interest of the child and permitted by the Juvenile Justice Board or Children Court. What does the Honorable Supreme Court puts the view? The Honorable Supreme Court has repeatedly stressed the need to safeguard the privacy and dignity of rape victims. The core points led by the Supreme Court are the anonymity of the victim, which is under Section 72 of the BNS, the media reporting guidelines, in-camera trials for certain offences, use of pseudonyms except for the main name of the victim, guidance in specific cases. As in case of Nipun Saxena versus Union of India, it stated that identity must be protected of all sexual assault victims or survivors. The exception for these are if adult victim has no objection to her name being published, identity being disclosed. It can authorize any person in writing to disclose her name. It has to be voluntarily and conscious act of the victim. Some victims are strong enough and willing to face the society even after names disclosed. It helps other victims of rape and becomes a source of inspiration to others rape victims. If dead body of an unknown victim is found and it is established that she was subjected to rape and that is not possible to identify her, her photographs need to be published in the media. But for this, in these cases, the fact that she was subjected to sexual offense not be disclosed. Whenever identity of victim need to be revealed, an application is to be made to session judge or special magistrate. Why I am discussing this case, as in the recent case in RGKR Medical College, the recent incident was the alleged brutal rape and murder of a resident doctor in Calcutta. Here the name, her photograph, all identification data including the disturbing photographs of the incident, personal details and detailed PMR report were circulated on all social media platforms. The law was breached and the impunity of there was a complete violation of right to life and right to privacy. Now the police has sent notice of arrest to several people, including senior doctor of the institute and elsewhere for this violation. The conclusion of this is measures that should be taken to protect the privacy and dignity of the sexual assault survivor by every individual. To enforce the law regarding confidentiality, privacy should be followed stringently. Ethical and safe reporting standard to be encouraged. Public awareness regarding the dissemination of sensitive information in the social media and confidential counseling and protected digital data. Thank you.
In Calcutta case, it has been disclosed the name of identity.
Yes, sir.
Identity is disclosed.
Yes, sir.
Calcutta case, identity has been disclosed.
Yes, sir.
I have not.
The photographs and names and everything was on social media actually. Yes, sir.
PMR रिपोर्ट ही है. नहीं रिपोर्ट तो मे बी सर, लेकिन उसकी आइडेंटिटी नेम और
The name has also been disclosed and it is a warning. The persons who are getting such messages in WhatsApp media, they should not circulate it.
Yes,
Better
sir.
it is delete. They should just delete it and not confidentially
Circulate,
also
yes, sir.
circulate it. You know?
Yes, sir.
Otherwise they will be charged with this action also. So that is advice to all the people who are getting such messages in WhatsApp media, at least don't forward it.
So forensic के students ही कर रहे हैं. Can the parents reveal the identity of the victim, of a dead victim?
So parents know, so Supreme Court does not give the permission for this also. It is not permissible. Thank you, sir.
Thank you.
Our next presenter is Dr. Padmaja, GMCH Chandigarh. Good afternoon, respected judges, faculties, and my dear colleagues. I am Dr. Padmaja, PGJR third year from the Department of Forensic Medicine and Toxicology, GMC Chandigarh. And today I will be presenting the comparison of the completeness of IC written coding of medical record dates before and after the implementation of history-taking proforma. So ICD is a vital epidemiological tool that enables the storage and retrieval of health data for the core national and international mortality and morbidity related statistics. It is an alphanumerical code of 3 character levels that enables to code the intent, the mechanism of injury, and the object or substance involved. There is also an additional code to denote the place of occurrence. An optional code is put for the activity of a person at the time of incident. So ICD-10 has 3 volumes. The external causes are mentioned in the chapter 20 of ICD-10, and the rules and guidelines for selecting the underlying cause is mentioned in the 2nd volume. The other 2 volumes being the alphabetic index and tabular list, which are used in combination to locate the correct code for a selected cause. The causes of death are tabulated according to both chapter 19 and 20. So the aim of my study was to compare the completeness of ICD-10 coding of medical legal deaths before and after the use of history-taking proforma. The primary objective was to improve the quality of history-taking before commencing the postmortem examination. And the secondary objective was the ICD coding of medical legal postmortem cases conducted by the department. So the study design of my study was a retrospective and prospective cross-sectional study, and the duration was 2 years. The retrospective study commenced on January 1st of 2022 and ended by December 31st of 2022. The prospective study was from May 22, 2023 to May 22, 2024. That is cases after the implementation of a new history-taking proforma. So the sample size was 1035 cases, of which 526 cases were in retrospective study set and 509 cases were in the prospective study set. The inclusion criteria was the medical legal postmortem cases with an apparent external cause of death. These were the exclusion criteria: unidentified and unclaimed bodies, cases with no available history, and deaths due to natural causes. So the methodology was retrospective cases were coded and their completeness were noted. Then an ICD-based history-taking proforma was introduced in the department and the prospective cases were coded as per this. The completeness of codes in the prospective study were analyzed and the differences, improvements and shortcomings were analyzed. So we will discuss in brief the steps in coding of history in postmortem cases. First we have to identify the external cause. And for example, the pedestrian hit by a car. Here the code will be V03.1. The traffic accidents will come under the alphabet V, and point 1 in the code indicates that it is a traffic accident, and 0 indicates that the victim was a pedestrian, and 3 indicates that the opposite vehicle was a car. Next we have to identify the intent, whether the injury was accidental, intentional or undetermined. Like in case of intentional self-harm by hanging, the code will be X70. If the intent is unspecified, the code will automatically go under the letter Y. The place of occurrence codes such as X70.0, where point 0 indicates that the incident occurred at home. The mechanism is also noted, like whether it was a fall, accident or assault. Also, in case of RTAs, the type of vehicles are also included. Then we have to know the purpose and role of deceased, like in vehicular accidents, the purpose of travel and whether the deceased was a driver or passenger. Example, motor vehicle accident between motorbike and a car while commuting to work. So the code here will be V23.52, indicating that the accident involved the driver of a motorbike and car, with 2 suggesting the individual was working for income. So the observations were 80% of the study sample were males and mean age was 37.18 years. The most common cause of mortality was road traffic accident, which accounted for 49% of the cases, and the other major causes being poisoning, hanging, fall from height, burns, etc. The retrospective study analysis there were 526 cases, and of which 60% of the cases were incompletely coded. Of this, 57% of the incomplete codes were RTA cases, 27% were poisoning, and hanging constituted 7.6% of the total cases. So the major missing parts in the history were purpose of stepping out in case of RTAs, which was missing in 70% of the cases, then role of deceased, whether he was a driver, passenger, alighting or boarding the vehicle, then the unspecified vehicle, the intent of person was also missing in majority of the cases, and the type of person and place of occurrence was also missing from majority of the cases. The intent in case of hanging was missing in 92% of the cases, and also in case of falls and falls from height. All the cases of drowning, electrocution and snake bites could be completely coded. So coming to the prospective study, we were able to code 88% of the cases, and of the incompletely coded cases, majority belong to RTA and comprised among almost 44%. So the most common missing element was information about the vehicles, which was missing only in 15 cases, and the role of deceased was missing only in 12 cases. The falls and fall from height accounted for 12.5% of the incompletely coded cases, and hanging accounted for 9.8% of the cases. Most of the cases of hanging were fully coded, and 56% of the cases of poisoning were incompletely coded, and the reason being the relatives unsure about the history. So this table shows a comparative analysis of my study. So these were the shortcomings. Like in case of RTAs, details about the vehicles were often unknown due to reasons like hit and run incidents, deceased being the sole person involved, and absence of eyewitness. And these circumstances make it challenging to achieve a data set with 100% complete or specific codes, impacting the overall data quality and completeness. So why this study? It is necessary for an accurate ICD term coding and also for legal and medical documentation and also for statistical analysis. So in conclusion, there was a notable reduction in the use of undetermined event codes and non-specific event codes. There was an improvement in the quality and specificity of history taking, but the inability to achieve 100% completeness does not indicate a failure to elicit a proper history, but rather a lack of available information. Thank you.
Thank you, Dr. Padma.
Next presentation is by Dr. Rajat Mandal, MAMC, New Delhi.
Good afternoon, respected chairpersons, faculties, and my dear colleagues. Today, myself, Dr. Rajat Mandal, today I am going to present about the postmortem analysis of heat stroke deaths in Delhi NCR region case series. Heat stroke can be defined as most serious heat disorder characterized by the complete breakdown of the thermoregulatory system and complete loss of sweating and temperature raised by more than equals to 105 degree Fahrenheit. In recent days, we, especially in the North India and also Eastern India, have faced the notable increase in the frequency and intensity of the heat waves, and which ultimately leads to the, especially in the Delhi, death toll due to the heat wave in the Delhi this summer rose to the at least 58 cases. So here I have combined all 5 cases into one case history because the findings are almost same. All 5 diseases, which includes 4 male and 1 female, were being found near the Daryaganj and Jama Masjid area of Delhi. Upon arrival to the Loknaik hospital, 3 persons were declared broad dead and other 2 persons died during the course of treatment after 2 to 3 days of hospital admission. The clinical findings of the two survivors, that is the temperature was 105 degree Fahrenheit and 160 degree Fahrenheit respectively, and also on ABG it was found that hypernatremia, hyperchloremia and metabolic acidosis along with serum creatinine have been increased and positive D-dimer. On postmortem examination, external general appearance, it was almost similar. The build, because all of them out of 5, all of them 4 are unknown. The build was almost average and moderately nourished, face was congested, especially in case of the broad dead cases, and along with the bilateral conjunctiva, which is also congested in broad dead cases. No antemortem external injury noted over whole body of the all 5 deceased. Let's talk about the internal examination, that is CNS, congested and edematous, and pedicle hemorrhages seen in the over the brain, white matter. And in 3 cases subarachnoid hemorrhages have been found. In heart, fibrinosis of muscle have been observed, and epicardial and subendocardial petechial hemorrhage have been found. On respiratory system, trachea and bronchi was congested in broad dead cases and contains frothy hemorrhagic fluid in 2 cases. Lungs, congested, edema and hemorrhages, petechial hemorrhages found especially in the interlobar fissures. Liver was found, liver and along with all other visceral organs are found congested. Now histopathology report. Histopathology shows the acute tubular necrosis along with the tubule lumens filled with the hyaline and fibrin cast, and also it also shows the acute exudative phase of the diffuse alveolar hemorrhage with prominent hyaline membranes. And also I'd like to mention that viscera we have sent and viscera report came negative. So cause of death, all the findings of the medical history and medical records, gross finding and histopathology report and histopathology and viscera report with the circumstantial evidence including eyewitness are consistent with death due to heat stroke. Discussion, there are two main categories of the heat stroke, that is high environmental temperature, as in my case series it is referred to as classical or non-exertional heat stroke, and also another form is second variant is from the strenuous exercise. The pathophysiology of the heat stroke, renal and splanchnic vasoconstriction with concomitant peripheral vasodilation which occurs, which causes the shunting of the blood flow to the periphery to dissipate heat. But if exposure to the heat continues, the vasoconstriction needed to keep the blood in the periphery fails, and which ultimately causes the peritoneous blood flow decreases, less heat dissipation, and which causes ultimately the hypothermia. And due to hypothermia, the cerebral edema will be there, and also ICP will be increased, intracranial pressure, then cerebral blood flow decreases, and there will be CNS dysfunction and ultimately coma and death. I would like to mention another, that is heat index, that is we often see in the weather app, that is what it feels like. As of now I have checked, that is it is 35 degrees Celsius, but here we can see that is, and also humidity here it is around 70 degrees. So we can note at 35 degrees Celsius the with the relative humidity the temperature, that is the heat index, will be like 51 degrees Celsius. So here they have categorized, WHO categorized the three categories, that is red zone, which is serious health, which is serious risk to the health, that is the heat stroke is imminent, and second yellow category is prolonged exposure and activity could lead to the heat stroke, and also prolonged exposure and green activity may lead to the fatigue, that is mentioned in the green zone. Now what is the pathophysiology of the visceral hemorrhage? That is, it is increased in the temperature and which causes the hepatic damage, and ultimately the increase in the prothrombin depletion and thrombocytopenia, and which causes the plasma fibrinogen level decreases and increased capillary fragility due to the anoxia, and which ultimately leads to the disseminated intravascular coagulation. My finding also are consistent with the my finding, that is the pedicle hemorrhage, brain and pulmonary edema, visceral congestion, and also the microscopic examination are very much consistent with the finding of the cervicatal and alumni et al. So Minister of Family Welfare, Health and Family Welfare have recently published guidelines regarding the cause of death due to the heat stroke. That is, one clinical diagnosis have been available, that is the body temperature at the time of collapse, it is the 105 degrees Celsius, and also temperature cannot be established, but the environmental temperature of the at the time of collapse was high in case of the clinical diagnosis available. But where clinical diagnosis is not available, that is a continuous exposure to the hot environment and fails to identify an independent cause of the death. And in some pre-existing disease known to exacerbate by the heat, this death can also be certified as heat related death. So in conclusion, we the forensic pathologists should keep in mind that a heat stroke remains a diagnostic made by the elimination. There is no specific sign of the heat stroke at the autopsy. The diagnosis heavily relies on the exclusion of the other possible causes of the death. And also I would like to mention that diagnosis can only made possible through the integration of the other departments with the forensic medicine to deliver the better medical legal services. These are my references. Thank you.
Kindly go to the cause of death slide.
Yes, sir.
So, are eyewitness circumstantial evidence?
Sorry. No, so sir, I mean.
Thank you.
Welcome, sir.
Our next presenter is Dr. Riha Mahajan, PGIMER, Chandigarh.
Yes. A very good afternoon to the esteemed judges, seniors and my fellow colleagues. I am Dr. Riha Mahajan, Junior Resident, PGI Chandigarh. I am here to present my study on the topic multispectral imaging in forensic medicine. It is arguably true that visibility of human eyes is limited. It is because of the fact that human beings can perceive only a limited amount of wavelength of light. But with the advancement in technology, there are many technologies available like photogrammetry, multispectral imaging system, 3D scanners, etc., which can aid and overcome the limited vision of our human eyes. Let us see what is multispectral imaging. Just like fingerprints are unique to every human being, spectral signatures are unique to every material. That depends on the fact that every material absorbs, reflects and transmits some amount of light. Let us see how the working principle works of the multispectral imaging. A lamp provides a light source that falls on the refraction gradient, which works as a prism that separates the components of light into multiple components of light which falls on the object, and the reflected light is then captured by the detector and the image is displayed on the screen. In our department, a thorough study was conducted using this multispectral imaging system, and displayed are the cases that I have studied, which include traumatic bruises on autopsy, clinical case and evidence collection on a fabric. Although there are multiple devices available in the market which include torches, goggles, dark rooms and detectors to perform the study, but in our department, since a specific device was available that comes with the brand name Forenscope, we use that. It is a handheld mobile multispectral device which comes with various light sources and filters. It also has a attachment that is a darkroom cylinder which can help me to control the mobility of light during examination. In my study, I used various permutations and combinations of these light sources and filters to get the best possible outcome in the image. In the first case, are you able to appropriately distinguish a bruise in the white light on DSLR or Forenscope white light photography? In the image, it might be difficult, but if I change the filter and light using a combination of violet light with a yellow filter, I'm sure everyone would be able to distinguishedly appreciate the surfaced bruise. Other permutations and combinations have also been used which showed some enhancement, but the best results were found in the first image as discussed. The second case was a suspected strangulation case. In this again, bruise was not evident on white light photography on either DSLR or Forenscope, but with violet light and cyan filter, violet light and yellow filter and cyan light and red filter, both these cases bruise was evident. The third case was a suspected seminal stain. In first four images which are clicked through DSLR and Forenscope's white light without any filter, we were not able to distinguish a seminal stain. However, using ultraviolet light with either full spectrum or orange colored filter, it was very evident that the seminal stain was present. Although the method of investigation has multiple uses of great importance, I did come across many challenges, which included refractive surfaces, background fluorescence, and surface contamination, which in this case was water. And because of these problems, I could not capture a very good image. Other than bruise examination and trace evidence collection, for multispectral imaging finds its application in many other things like human body fluids and pattern analysis, document examination, trace evidence collection, fingerprint analysis, all through non-destructive analysis, because no chemical is used in this process. To sum up the entire study so far, multispectral imaging has application only for screening purposes without any rating of bruise, and holds much flexibility as it is reproducible and quantifiable. Despite the challenges, the area of study holds immense future prospects, one of which is its integration with artificial intelligence to aid in evidence detection. For example, the cameras can be equipped with artificial intelligence that can calculate the best combination among all the possible permutations of light source and filters for maximum enhancement. And on a larger scale, a whole body examination, full body scanners can entirely automate the process. Thank you and have a great evening ahead. Yes, sir. This totally, sir, I am conducting a thesis study, but I am only detecting bruises on postmortem cases.
Bruises in those cases where they are not evident, or bruises that are evident to naked eye?
Sir, I am taking both the cases. First is first I am looking for any bruise, and if there is any enhancement seen using the combination of alternate light source with the filter. And secondly, if I'm already scanning the bodies entirely to check if there is any obscure bruise and if my device can pick up those obscure bruises.
How is your device different from a Woods lamp?
Sir, it has a software that comes by its own name only, Forenscope. Now, every light, although it has a narrow wavelength spectrum, for example, white light comes between 400 to 700 nanometer, but that doesn't mean that blue light is only 400 nanometers. It might range from 415 to 450 also. So if there's a range available for the light, my software in the device calculates the best image with the appropriate filter and gives me the best outcome for the body fluid specifically.
Does this take a photograph also? Or
No, sir. I have to click the photos. Wherever I find any bruise or object of my interest, there I place the Forenscope with the cylindrical attachment, and then I click the photograph.
So the filter is provided by your Forenscope?
Yes, sir.
Okay. Thank you.
Thank you, sir.
The next presenter is Dr. Rupeshwar, UCMS and GTB Hospital, Delhi.
Good morning everyone. Myself Rupeshwar from UCMS and GTB Hospital and first year PG resident. I am presenting examining the unseen rare homicide at unusual spot with unusual injury. Homicide is the gravest violation of social and moral norms. According to NCRB in 2022, there were around 28,000 reported homicide cases, 2.1 per 1 lakh individuals, 78 murders per day and 3 murders every hour. In India, in Delhi, 500 reported homicide cases were reported in 2022. As you can see, in 2019, India was ranked 4th in the world for total gun deaths. Lot of casualties, including homicide and suicides, were there. Depending on the direction of travel of the projectile, there are entry and exit wounds. Entry wounds are smaller, more regular, surrounded by an abrasion collar and may exhibit a grease collar, along with tattooing, soiling or flame burn. While exit wounds generally larger, more irregular and characterized by outward beveling of tissue. Homicides can transpire in diverse array of locations. Most frequent locations are isolated areas including houses, followed by highways, petrol pumps, etc. In the usually serene and controlled environment of a hospital, where the primary goal is to offer care and healing, the emergence of a homicide is both shocking and deeply unsettling. I am presenting a case of 35-year-old male, a follow-up case of X-slap 2 months back. During the course of his treatment, he again underwent X-slap with peritoneal lavage with adhesiolysis. On post-op day 8, he had burst abdomen. An open lap with Begota bag in situ was done after 2 days. And on the fateful day, the deceased was on his bed in the ward. Doctors on duty were doing surgical dressing. Then one of those doctors heard multiple gunshot sounds and bullets being fired in the deceased by an unknown assailant. As you can see, this is a picture of the same ward. The unknown assailant came from that door and shot the deceased from the left side. This case gathered lot of media attention also, as it was a case of gunshot as a mistaken identity. On autopsy, apart from general condition of the body, as per disease, abdomen was open with exposed loops of intestines. No firearm entry wound was present externally. The dead body was sent to radio department where X-ray was done, which showed one radiopaque foreign body present over the right side of the back of the abdominal region. A firearm entry wound of size 1 cm into 0.8 cm, oval in shape, present on the surface of the small intestine loop, which was surgically exposed, situated on the left side of the peritoneal cavity, 105 cm above the left heel. The track of the wound was directed upwards, backwards and medially towards the right side, piercing and lacerating multiple loops of intestines, mesentery and corresponding blood vessels and muscles of the right side of the back. The track of the wound ends in the subcutaneous plane where a copper jacketed, non-deformed metallic bullet measuring 1.3 cm in length and 0.7 cm of base was found. The skin overlying the bullet was intact and showed reddish bruise. So the cause of the death was hemorrhagic shock as a result of antemortem injury to the internal abdominal organs produced by projectile of firearm. Documenting and interpreting firearm injuries are routine tasks, not only for disease victims during autopsies but for living victims also. Macromorphological examinations are conducted alongside imaging techniques. Initially, a correct diagnosis was elusive due to the absence of a conventional entry wound. The missing entry wound over skin, along with lack of an abrasion collar, grease collar, tattooing, complicated the diagnosis. Without knowledge of the gunshot history, accurate diagnosis would have been nearly impossible. Routine radio examinations might not have been conducted. It was only through X-ray imaging that the bullet was detected. In our country, majority of autopsies are done by medical officers working in rural areas. Hence, MBBS students need to be sensitized about these findings in the undergraduate teaching. The case of this man who was fatally injured by gunshot while receiving medical care in a hospital, despite being one of the most crowded hospitals in Delhi with 1700 bed capacity, 6,000 OPDs per day, 250 daily admissions and 104% bed occupancy rate, such a violent incident occurred in broad daylight. Brings to light significant concerns regarding violence within healthcare settings which manifest physical abuse, verbal abuse, intimidation, causing psychological stress and PTSDs, direct threat to physical safety, not only patient but also endangers healthcare professional safety. Recently, rape and murder case of doctor in Kolkata underscores the urgent need for comprehensive measures to address violence against the healthcare professionals and broader issues of the gender-based violence. To conclude, I say this indicates that these unusual findings are present in significant number of cases which can lead to misinterpretation of findings if autopsy surgeon is not aware about these findings. Urgency and commitment in addressing the issues of violence will not only improve safety but also contribute to a more supportive and effective healthcare system, ensuring that those dedicated to caring for others can do so without fear of violence. These are my references. Thank you.
Any questions?
So, examining the unseen, rare homicide with unusual injury at unusual spot.
I mean, इसमें unusual क्या है? आपका hospital में there was an incident of gunshot. Everyone heard it. The patient died, and you did an autopsy, and you found the person, the missile that was there. So unusual. I mean, why did you classify this as an unusual case?
So I classify this as unusual because of two reasons. First, spot was the unusual. Usually homicides are at isolated places. It was a homicide at hospital, which no one can expect. And second unusual thing was that no external entry wound was present over the skin. It was over the loops of intestines.
Because there was a burst abdomen.
Yes, sir.
So are you definite about the track of the wound?
Sir, the track of the wound, which was very difficult to direct the track of the wound, but bullet was impacted in the subcutaneous plane and extravasation of blood was also present, so we somehow find the track.
मिसआइडेंटिटी का केस था, किसी को मारने आए थे।
The wound in the intestine, you told some 105 centimeters from the heel of the leg. Man, is it how you measure the wound of the intestine? Is there a better way of measuring? Wound of the intestine, wound in the intestine, it was mentioned as 105 centimeters from the heel. Heel of the left leg or right leg, whatever it was. So do you mention it like that, or is that a better way of giving a reference, considering that it was an internal injury? It was not a surface injury.
Delhi में norm है सर, सारे hospitals में ना, we measure from the axillary but
No, but it was an internal injury.
But for fixed parts, heel is good. But for mobile parts, like
mobile part is a difficult.
And it is an internal injury.
See, once you have the fixation of the organs, then it might
No, sir. No, my question was, it is not a surface injury. It was not an external injury. It was an internal injury. So I personally believe there is a better way of writing the landmark in this particular case, considering that it is an internal injury. It is not an external injury.
Right, sir.
can you define this?
Sir, as it is internal injury and the organs were mobile, so
This was not an internal injury, this was an external injury because the intestine came out.
yes, sir.
No, even if the intestine came out, you could have given. Sir, if the intestine has come out, then it is totally flexible, na? Then how she is telling that 105 centimeters from the EA?
And also,
So you should have given an internal reference.
Okay, sir. Yes, sir.
Okay.
Yes, sir.
Just one passing remark. If you remove the word antemortem in your cause of death, will it make any difference? Just show that slide. What was the opinion regarding cause of death?
Yes, sir.
I think that's not required. And number two, you said this what was that thing you said? Rare type of injury seen in significant number of cases. Unusual finding in significant number of cases. So you are contradicting yourself in that statement.
So I'm saying we have seen one case. Throughout the India we can see many cases. So but students must be aware of this.
It's okay.
thank you, Dr. Rupeshwar.
The next presentation is by Dr. Sarjana Singh, GMCH Chandigarh.
Good afternoon, everyone. I'm Dr. Sarjana Singh, demonstrator, GMCH Chandigarh. Today, I'm going to present on the topic, Understanding Pathophysiology of Diseases, Risk Assessment, Screening and Counseling of Family Members through a case report of suspected Marfan syndrome. Patients with connective tissue diseases may be more susceptible than the general population to cerebrovascular events, including intracranial aneurysm, dissections, and strokes. Marfan syndrome is a heritable disorder of connective tissue caused by deficiency of glycoprotein fibrillin. Incidence of intracranial aneurysm in Marfan syndrome varies between 4% to 29%, and prevalence of hemorrhagic strokes is between 3% to 4%. Cardiac pathologies associated are mitral valve prolapse, aortic root dilation leading to aortic regurgitation, aneurysm dilation, and dissection. Why this case report for presentation? The importance of history, particularly the family history of any disease before conducting autopsy and physical examination, is being highlighted. It could provide a clue and guide towards the underlying etiology if any similar heritable disease is running in the family, leading to preventing further deaths by taking timely action by treating the cause if possible. Case presentation. As per history given by IU and family members, a 14-year-old boy informed that he felt headache and blood started coming out of his nose while playing basketball, and after that he fell on the ground. The school CCTV footage recovered showed the same, that while playing basketball, he suddenly held his head and blood started coming out of his nostrils, and after that he fell on the ground and became unconscious. The family members then brought him to our hospital, where he was declared brain dead. The father further mentioned that their son used to complain of headaches of increased intensity from last 1 month, and on some days he used to describe them as severe and unbearable. But as they used to subside by themselves, they did not seek any medical consultation. He further mentioned that another young male in the family, 25 years, died due to hemorrhagic stroke 5 years ago. Also, the 14-year-old child was myopic and the power of lens changed twice in the same year. Findings during autopsy: height 198 cm, there was pectus deformity, reduced upper segment to lower segment body ratio, arm span exceeding the height, abnormally long thin fingers, and thumb sign was positive when the fist was made passively, and the thumb tips extended from the palm of hand. Eyes pupils were dilated and fixed. All other organs were unremarkable. Brain subarachnoid hemorrhage was present and was more prominent over the base of the brain. On further exploration, a ruptured aneurysm was found at the junction of bifurcation of middle cerebral artery and internal carotid artery. Heart was enlarged and dilation of aortic root present with diameter 5.2 cm. Cause of death in this case was cerebral damage as a result of rupture of aneurysm of cerebral vasculature leading to subarachnoid hemorrhage. So what findings during autopsy supported suspected Marfan syndrome? First is the history. Headaches of increased intensity from last 1 month, and on some days he used to describe them as severe and unbearable headaches. Myopic and power of lens changed twice in the same year, clue to suspected ectopia lentis. Family history: death in a young male aged 25 years due to hemorrhagic stroke 5 years ago, clue to some suspected neurovascular manifestation of heritable family disease. Gross physical examination: pectus deformity, reduced upper segment to lower segment body ratio, arm span exceeding the height, and positive thumb sign. Brain ruptured aneurysm was found at the junction of bifurcation of middle cerebral artery and internal carotid artery, leading to subarachnoid hemorrhage. Heart dilation of aortic root present with diameter 5.2 cm. As Marfan syndrome is a connective tissue disorder that can weaken the blood vessels, it can eventually lead to aneurysm and dilation with subsequent rupture or dissection, leading to hemorrhage as evident in the present case. So these are some of the representative images showing positive thumb sign, Steenberg sign, and showing pectus deformity. Subarachnoid hemorrhage more prominent over the base of brain due to rupture of aneurysm, and the picture with the arrow mark show ruptured aneurysm of right middle cerebral artery. So why this case report for presentation? The patient, 14 years, died due to rupture of cerebral aneurysm. If Marfan's syndrome diagnosis was established by genetic testing, pedigree analysis, further screening, counseling of family members, followed by CT or MRI and DSA can be done. If any aneurysm is found in any of the family members, surgical coiling and clipping can prevent its rupture and save the particular member. Screening of family members by doing ECG and 2D echocardiography of heart, and if any aortic root dilation, aneurysm or mitral valve prolapse is detected, any surgical intervention can be helpful. Hindrances: sometimes proper history is not available, missing out the findings during gross physical examination during autopsy, resources of genetic testing are not available in all government hospital settings, the cost of genetic testing, loss of follow-up, the family members don't consent for genetic testing, and the family is in denial stage of grief after the death of their member. Summary and conclusion: at autopsy, history taking gross physical examination, internal findings and the correlation is important. If any death occurred in the previous family member due to same cause, for example hemorrhagic stroke in the 25-year-old male in a specific age group, could be a clue to some heritable family disease. Counseling of family members for genetic testing, pedigree analysis, further screening, radiological scans and tests with the help of other departments become important. And if the radiological findings and other tests are indicative of any pathology, for example aneurysm, timely intervention can save the life of particular member of the family. So this example with same set of steps as discussed above can be applied for such type of diseases if they are encountered in the future. These are my references. Thank you everyone.
Thank you.
Okay, sir.
Next presenter is Dr. Saurav Vishal of GMC Haldwani.
जूम नहीं हो रहा। Good afternoon, chairpersons, respected chairpersons, all the faculty members. Myself, Dr. Saurav Vishal from GMC Haldwani, Nainital, Uttarakhand, and my topic for paper presentation is the love, riots and murder, a homicide disguised as a death during riots, a case report. Haldwani riots, 4 deaths, over 200 injured, internet suspended, school shuts. On 8 February, as you all heard about the dangas that took place in Haldwani, and here's the video.
शहर के बनभूलपुरा इलाके में अतिक्रमण विरोधी कार्रवाई के खिलाफ लोग हिंसा पर उतारू थे। देखते ही देखते पूरा इलाका गोलीबारी, पत्थरबाजी, चीख पुकार और सायरन की आवाज से बेचैन होने लगा।
Dozens of vehicles, both government and private, were burned, and around 100
Your
police
6 minutes will be over by the time it ends.
मगर जब हिंसा थमी तो इलाके से एक-एक कर कई लाशें बरामद हुई। वहीं कई
और इसी माहौल में पुलिस को एक और लाश मिलती है। लगता है कि ये भी दंगाइयों का शिकार हुआ है, लेकिन जब लाश की तफ्तीश होती है तब फिर एक ऐसी कहानी सामने आती है जिसे सुनकर खुद पुलिस भी हैरान हो जाती है।
इसी बीच पोस्टमार्टम रिपोर्ट से पुलिस को कुछ ऐसी बातें पता चली जिसने मामले को बिल्कुल ही एक नया मोड़ दे दिया।
A case history. A dead body of an unmarried 25-year-old man, resident of Bihar, found in that same place where the riots took place on the very next day. So naturally, he was presumed to be a victim of that riots. As per the information given by the relatives, the disease had arrived Haldwani, place of riot, just before 2 days. Medical legal autopsy was done to determine the manner and the cause of death. According to the history given by the investigation officer, the family of deceased were alleging assault, and there is no history of diabetes, hypertension and any other chronic illness. An autopsy finding a Mangal Sutra beaded thread was found in his jacket pockets. 3 deformed bullets were found lodged inside the cranial cavity with the entry wounds present over the part of right occipital region and posterior aspect of the neck. Bullets and skin around the entry wound were preserved. Multiple abrasion and laceration was present all over the body, suggestive of physical assault of the victims, and the age of abrasion and contusion were not in the consistency with the history provided by the police. And on examination of the external injuries, here is the 2 entry wounds and the abrasion and the contusion over the nose. Investigation findings. Many unanswered questions arose following the autopsy, such as what was the resident of Bihar doing in Haldwani and what was his reason for visiting? Why was he carrying a Mangal Sutra locket with him since he was unmarried? The bullet recovered from the body were different from those used by the police force, and all of them were lodged in the head, as police authorized to shoot only at the legs in their defense. The profile of the victim did not match with the profiles of other victims, that's religion and demography. So the police started investigation further into the cases, following which they found that the victim had an affair with one of the constable wife in Haldwani. The victim had visited Haldwani for the same woman who, along with her husband and two other, conspired to kill the victim, then disposed of his body in the same place as that of the riots, so as to mask the homicide into the riots' later death. And this is the X-ray of the skull, and the bullet recovered from the cranial cavity are deformed and that are not matching with the officials. And conclusion is that this shows the importance of even the smallest of details which are revealed during the autopsy, and the doctor's role in the properly using his skill and knowledge so as to catch these small hints and use them in bringing justice to the disease. Forensic science play a vital role in justice system by providing objective scientific analysis of evidence from crime scene. Forensic evidence is crucial in the court, offering reliable information and ensuring that investigations are thorough and unbiased, ultimately aiding in the pursuit of justice. Thank you. Yes, sir. Yeah, I presented here the poster, sir. Yes, sir. Yes.
But what is special of?
What was the range of fire to do it? What was the range of fire?
Sir, it's approx 6 to 10 meters around.
It was a routine autopsy with good investigation by the police, right?
Sorry, sir.
It was a routine autopsy case of a firearm injury.
Yes, sir.
In which the police conducted a good investigation. So what is special about?
But sir, they wanted that they supposed to think that the bodies are the case of riots, na. They actually hiding the.
That suspicion, वो suspicion भी पुलिस को थी?
नहीं सर.
हाँ, आपको थी?
सर जो वहाँ पे ऐसी सिचुएशन क्रिएट की जा रही थी, ऐसी सिचुएशन क्रिएट की जा रही थी कि लोगों को पता नहीं. Yes, sir. No, sir.
No, so you are trying to say that this is in any other case, it is not related to the riot. What I am telling that even if the person would have died because of this riot thing, the person would have killed him because of riot, he would have used the gun also.
But sir, body placed there, na, at that situation, at the place of the riots where took place.
You are not getting my question.
Yes, sir. Yes, sir.
You presented the case that it was not due to riot death. The body was placed there to say that this person riot death.
Yes, sir.
What I am telling is that suppose let's say the person would have been a victim of riot death, the person who killed him, he used the rioter, he used firearm.
Yes, sir. But the guns are and the bullets recovered from that body, na, sir, not matching with the officials. All the guns provided to the police. Yes, sir.
Police investigation, that is what Dr. Ravindra is saying.
Yes, sir.
That investigation by the police was good. हमने क्या किया हमारी तरफ से ये पूछ रहे हैं वो.
सर पहले तो इस केस को दबाया जा रहा था कि पता ही ना चल पाए, फिर हमारी पोस्टमार्टम रिपोर्ट्स के बाद ही बहुत चीज खुलासा हो पाया.
आपने कहा पहले पुलिस को सस्पिशन मीडिया में उछाला जा रहा था कि ऐसा कैसा हो गया, तो दबाया कहाँ जा रहा था? वो तो उछाला जा रहा था
इनिशियल डेज में, स्टार्टिंग में.
So what was the time period between finding this body?
Yes, sir.
And the postmortem examination? जब बॉडी कब मिली और आपने पोस्टमार्टम कब किया, उसमें क्या टाइम डिफरेंस था?
सर 8 से 9 तारीख को दंगे वहाँ पे हो गए थे, मगर वहाँ पे इंटरनेट और ये सारी फैसिलिटी बंद हो गई थी. बॉडीज हमारी मॉर्चरी में पड़ी हुई थी, जिसमें कि 2 तो एडमिट थे हॉस्पिटल्स में. तो धीरे धीरे डिक्लेयर होता, किसी को पता नहीं चल पाया था कितनी बॉडीज आई हैं. तो पहले तो पता चला कि 3 बॉडीज हैं, फिर चौथी बॉडी हुई, फिर धीरे धीरे खुलासा हुआ.
आपने पोस्टमार्टम कब किया, बॉडी कब मिली, पोस्टमार्टम कब किया?
10 तारीख को.
9 को बॉडी मिली, 10 को आपने पोस्टमार्टम किया.
यस सर.
तो क्योंकि उसमें तो दबाया कब जा रहा था और उछाला कब जा रहा था?
सर स्टार्टिंग डेज में.
दबाने के साथ
थैंक यू.
Next presenter is Dr. Sonakshi Sharma of PGIMER, Chandigarh.
Good evening, respected judges, all the senior faculties and delegates. Myself Dr. Sonakshi Sharma, junior resident, second year, Department of Forensic Medicine, PGI Chandigarh. Today I am presenting the case titled Workplace Prank-Led Medical Emergency, the Unforeseen Consequence of Misusing the High Pressure Compressed Air. Let me give the brief introduction. Barotrauma is an injury caused by the pressure effect, and colon barotrauma remains the most common cause of the elevated intraluminal pressure. And iatrogenic injury to the colon during colonoscopy remains the most common cause, and non-iatrogenic pneumatic injury to the colon is less frequently encountered in the industrial setting. This case report presents an unusual case of the fatal non-iatrogenic colon barotrauma. Now this is the details of the case. 20 years old male worker working in the pesticide industry. As per the information given by the police, the patient presented with the alleged history of blunt trauma abdomen when the deceased was unloading the guinea bag from the factory vehicle, and guinea bag fell over his abdomen and chemicals followed by which chemical contents spilled over his body. On arrival in the hospital, the patient presented in drowsy state and with alarming symptoms, salivation, sweating, abdominal distension and bleeding per NS. And the vitals indicated pulse 120 beats per minute, BP 100/70 on noradrenaline, and respiratory rate 22 breaths per minute. Patient was in gasping state, SpO2 80% and pinpoint pupils, abdomen is tympanic on percussion. And provisional diagnosis of gut perforation, peritonitis and suspected compartment syndrome with OP poisoning was made. And in view of hyperkalemia, they are doing the hemodialysis and they are treating the patient on the OP as a OP poisoning case. And after that, they have planned the exploratory laparotomy, but the patient condition getting deteriorated and patient dies on 7 July 2024 at 6 a.m. in the morning. On autopsy finding, there are no suspected obvious findings except the reddish pattern abraded contusion in an area of 16 to 14 centimeter present in the chest and upper abdomen, bleeding per NS. Internal findings are about 700 ml of blood mixed with the fluid and fecal content present in the peritoneal cavity. There are multiple contusions in the sigmoid colon and the mesentery, multiple longitudinal serosal tears over the wall of the sigmoid colon, and 2 perforations of 1x1 and 2x1 centimeter present in the sigmoid colon, 6 centimeter, 8 centimeter distal to the rectum. In view of the different history given by the police personnel and the attendants, we have a doubt the history is not correlating with the internal findings, so we planned the crime scene visit. The crime scene visit conducted and CCTV footage revealed the prank done by the co-worker in the industrial setting. This is the video showing the prank. This one is in the yellow shirt is doing the prank with the red shirt co-worker. He is directing the air hose pipe towards the anus. And in the first attempt he was not successful, and in second attempt the patient collapsed. These are the technical details of the compressor. Airflow rate is 41 CFM and pressure at 8 bar. Now come to the discussion. The first case of barotrauma was reported in the literature in 1904. And in the literature, various cases are reported of rectosigmoid and the cecum perforation, but sigmoid colon perforation is an unusual case of the non-iatrogenic colon barotrauma. They are treating on the line of the OP poisoning, so there is a delay in the diagnosis as misleading history was given, and it leads to the delay in the appropriate treatment, allowing the underlying condition of the patient to worsen, and rapid progression from initial symptom to death within 24 hours highlight the critical nature of the timely intervention in cases of the perforation peritonitis. External pneumatic insufflation through anus involves various factors as air pressure, airflow velocity and resting anal pressure and distance from the source and anus. So understanding these type of injuries are important for the accurate diagnosis and the treatment. Now come to the conclusion. Pranking is not the joke. This case demonstrates that how the air hose pipe can turn fatal, which was meant for cleaning the fabrics and tools. And in the factory, the professionals have to educate the workers regarding the equipments, and they have to display the clear warnings on the machines which are used by the workers. Clear flag signs are on the equipments, and posters with proper illustration with do's and don'ts are also in the industrial settings. At the end, the prevention is better than cure. Thank you.
Why was the patient being treated for OPC poisoning?
Because sir, because when the guinea bag fell over his abdomen, the chemicals content spilled over his body, and he is in the industry, and the police is giving the information, and the police is giving the misleading history that he fell down and chemical contents of the guinea bag fell over his abdomen. And there are
the history of police was not misleading. You are suggesting कि पुलिस गलत बता रही थी, पुलिस को गलत मालूम था पहले।
यस सर, मालूम था।
और फिर ओपीसी के लिए गनी बैग तो गिरा ही नहीं।
नहीं नहीं सर।
ओपीसी स्पिल भी नहीं हुआ, पिन पॉइंट प्यूपिल कैसे आए और चेस्ट पे क्रेपिटेशंस कैसे आई चेस्ट में?
Sir, pinpoint pupils and chest cramp. Sir, there are parasympathetic symptoms also. When the air hose pipe is directed towards an anus, and parasympathetic.
Did you
supplies-
send Visra for chemical analysis?
Yes, sir.
And what is the report of that?
Sir, report is pending. We have sent the Visra
So
for.
you are not sure कि police was misleading or not?
Sir,
अपन चलो वीडियो आ गई, ठीक है, thank you.
Sir,
वीडियो सर बाद में आई होगी ना, वीडियो बाद में आई होगी.
I have also visited the field. Seen a fan, then I.
Thank you.
Okay, thank you.
Thank you. Next presenter is Dr. Vaibhav Agarwal of UCMS and GTB Hospital, Delhi.
Good morning, judges. Good morning, teachers. Good morning, judges. Good morning, teachers. Today I am presenting a case report on multiple canine bites, a social negligence. So this was a case which came to our on the medical college, which was alleged history of multiple dog bites of a 4-year-old girl, which family belonged to a butcher shop and used to daily feed the dogs, but by that day they didn't fed the dogs, maybe according to the history, and the dogs attacked the girl which was playing outside. So this was the case. So on autopsy at antemortem external injuries, we saw multiple bite wounds present over different areas like chest, abdomen and over the back, and bite marks were present over the arms, axillary regions with varying shapes, that is V-shaped, punctured wounds and multiple curvilinear lacerated wounds. These were present like this, V-shaped wounds, and on the back also. So on there were multiple reddish abrasions of varying size and shape present. The abrasions are of irregular shape and the abrasions are grazed over posterior aspect of body mainly over trunk, buttocks and upper portion of the thighs. And on internal findings, we saw hemorrhage over the chest, and abdominal cavity showed 500 grams of blood. On internal findings in rib cage, on the 7th rib, we found that there was extravasation of blood present and lacerated, as you can see in the image. In the neck and vertebra, on layer dissection of muscles and neck, trachea was also lacerated and rings were around the tracheal rings, and extravasation of blood was also present. Here the trachea is lacerated in the second photo. On opening the intestine and the liver, both the intestine had shown the tear of mesenteries, and liver also showed laceration with parenchymal deep lacerations. So by doing this case, the cause of death came out to be hemorrhagic shock. So by this case report, I want to present that key discussion. The children are at greater risk of being bitten by dogs, as dog bites are very common in Delhi. As in Delhi, it has been reported about 29,000 dog bites, stray dogs bites have been reported in September 2023 only. So what was the reason behind children getting attacked? First is the children are at lower stature. Second, children are more likely to lean and hold faces close to the dogs, and which is perceived as threatening to the dogs. And third, adults have a better sense of defense against the attack. So mostly in dog bites, we see penetrating neck wounds, bites to head, neck in less than 6 years old child, and to the lower limbs for more than 6-year-old childs, basically because of their height. And autopsy of victims helps to identify the pattern of attack, dog's teeth and particular wounds for multiple canines also. Like this is a specific wound present over the neck, because that is the first place most canines attack, to the neck. injuries represented by the particular puntiform V-shaped holes, lesions presenting irregular and furrowed borders. So this typical type of puncture is present, which is known as hole and tear puncture wound, which is produced by canine tooth or either maxilla or mandible on one side. So it is present as shown in the image. So what we can do, what government has done for this? Government has made, according to Municipal Corporation of Delhi, it has made animal birth control rules for stray dogs. That is, it includes capture, identification, records and release. So according to MCD, as I told, MCD data September 2023, more than 29,000 stray dogs were sterilized. Government guidelines on feeding, vaccination and sterilization of stray dogs, they have made some rules. Like first is section 11 of Prevention of Cruelty to Animals Act 1960, the Animal Birth Control Dog Rules 2001, Under Stray Dog Management Rules 2001, the IPC section 428, 429, which is now BNS 321, the Environment Protection Act, Wildlife Protection Act, and Supreme Court order which in 2009, which also was against the vaccination and sterilization of stray dogs. So my conclusion is dog bite analysis should be consistent with multidisciplinary plan of action involving different forensic experts such as pathologists, odontologists, veterinarians, biologists and crime investigators. A scientific inclusion and exclusion of the dog involved is possible and also recommended because of the possible serious criminal, legal or financial consequences for the owner of the animal. Prevention of dog bites. For 39.5% of dog bites were by stray dogs. Prevention strategies to dog owners and people who do not own the drug should be told. NGOs like Motorpaws make reflective collars for the dogs which can be identified at night. Common places to feed the stray animals. Vaccination of pets. Rabies awareness campaign should be launched. Licensing and vaccination should be made compulsory. And in some steps by NGOs like Federation of Indian Animal Protection Organization, it does animal birth control, dedicated anti-rabies vaccination program, dog bite prevention education, post-bite counseling, on-site first aid, community engagement. This is a graph showing animal health, human health component. These are my references. Thank you.
Next presentation is by Dr. Vivek Rawat of GMC Haldwani.
Good evening, everyone. I'm Dr. Vivek Rawat, final year PG resident from the Department of GMC Haldwani, Nainital. And my topic for today is an unusual case of diabetic death, a case report. Starting from the introduction, a diabetic death is a rare but tragic form of premeditated violence that involves the death of two people at the same time, homicide followed by a suicide, or suicide pact. I would like to emphasize on this thing that there is a specific suicidal pact. For example, if there are two lovers who are trying to commit suicide, if it is to be called a diabetic death, one would kill the other person and then commit a suicide. So normally in usual cases there is a suicidal pact. So the circumstances that provoke may vary from person to person, the most common being family and marital disputes. Coming on to the case report, on 15th of June 24, at around 9 to 10 p.m., alleged history of a property dispute between two distant relatives, which led to the perpetrator stabbing the victim as well as his own mother, who tried to stop the perpetrator during the act, followed by shooting himself with a .315 bore pistol. All of them were brought to the nearby health center and further referred to a tertiary care center where they succumbed to death. The perpetrator and the victim died within 1 day of hospital admission, and the mother of the perpetrator died 3 weeks later. All the bodies were examined and the following findings were observed in them respectively. So this is the exact history which got revealed later on after the police investigation. First of all, when the victim came to us, as in the perpetrator, the relatives of the patient, relatives of the perpetrator were trying to mask the truth, as in they did not give any such history of a gunshot. They were trying to tell us that it was a stab wound or he would have fallen somewhere. And looking at the wound also, it is not a typical entry wound, and so when the patient came to the hospital, he was treated as a injury itself, laceration, and which also lead to the we can see Kennedy phenomena also here, that they stitched the wound, and so during the autopsy it was difficult for us to see if it is an entry wound or not. So when the body came to us, we suspected foul play. How? First of all, in the second picture we can see there is smudging of tattooing and burning, and we also saw some soot particles over palm of his right hand. So we suspected foul play. Starting from the external examination, there was a therapeutic stitch wound with 13 intact stitches of length 13 cm noted over right mandibular, submandibular, and extending up to right neck region. So mainly the injuries were right submandibular gland was perforated, body and angle of right mandibular bone was fractured, and the gun was passing, the bullet had passed through the right anterior cranial fossa, fracturing it, perforating the right frontal dura mater, and one deformed disheveled bullet fragment and was enlarged in the frontal lobe parenchyma, and it exited the cranial cavity through right frontal bone. So when we suspected foul play, we sent the body for postmortem X-ray. So when we did the X-ray of the whole body, we could see some two small fragments over the head. So these are what we concluded is the broken fragments of the bullet, which they could not figure out before. Internal examination. Over the skull, we could see a comminuted fracture of size 5 cm and 3 cm noted over right frontal bone, with a clean punch-in hole appearance over the inner table and beveling over the outer table, as in it is entering the it is exiting from the skull, and it had entered from the base of skull. So we could see a clean punch-in hole and over outer table and beveling over the inner table. The first picture, we could see there's a small fragment which is enlarged, which I have encircled, and in the second picture we can see beveling of the outer table. Findings of the victim. There was an alleged history of a stab wound, so he was treated in the emergency itself, and so we had to write. We had to mention the injury as it was a surgically made stage inside wound, and there were two perforations inside of size 0.5 centimeter into 0.5 centimeter and 3 centimeter to 2 centimeter noted. So this is how it was surgically repaired, and also there was a ileostomy bone created over the right side. Going on to the mother of the perpetrator, there was a surgically made stage inside bone vertically placed. This is also operative in nature, and on the left we can see, which I have encircled, that is the alleged stab wound. So these are the causes of deaths. The perpetrator died of head injury, and the victim and the mother died of perforation penetrandis. So why did I do this topic? First of all, it is an unusual case. Why it is an unusual case? Because there is no specific pact in this. For example, if a mother kills his infant baby, there's no specific pact between them. The mother kills the baby and does suicide. So it is also considered as a dyadic death. Second, as Amandeep ma'am said, there needs to be a proper integration of different clinical clinical departments and forensic department, so as we cannot lose many proper evidences and this. And obviously this needs a multidisciplinary approach and creating awareness in the population. And finally, we should not be doing postmortems based on the history given by the patient's relatives. We should not be biased by the history given by the patient's relatives, and we should obviously thoroughly investigate the body and look for the findings.
Thank you.
Next presenter is Dr. Sahul Kumari of GMC at Chandigarh.
Good evening, respected judges, professors, senior, junior, colleagues and co-delegates. I am Dr. Sahul Kumari, PGJR from GMC Chandigarh. I will be presenting on topic guidelines for the use of biomedical waste or leftover samples for commercial purposes. Human biological samples are samples of specimens that are generated from a diagnostic, therapeutic or surgical procedure on patients. Include organs, parts of organs, cells, tissues, subcellular structures, cell products such as blood products, urine, saliva, DNA, RNA, nail clippings or any other cell and body fluid. The source of these specimens may be patients, autopsy specimen, abandoned waste, tissue banks, IVF clinic, organ donation centers, etc. Leftover samples are those samples which have undergone the required clinical and laboratory testing for the patient. Large quantities of leftover samples may remain available in the hospitals. These samples may be referred to as a biomedical waste, sometimes may be a biohazard and require appropriate methods for disposal. Such samples are usually discarded as hospital waste. De-identified samples are those in which all clinical, personal, identifying information has been removed and therefore there is no way to relink with the source. The leftover samples, if de-identified, can serve as a precious resource for research and development activities to develop diagnostics, advance innovations, or for the development of kits, identify specific disease markers, or determine relevant health parameters and other such purposes that may have huge value. Commercial use includes, there has been a keen interest from the commercial companies in procuring and using these leftover de-identified samples for the development of commercial kits, products or technologies that have the potential to improve future patient outcomes, provide diagnostic accuracy or offer therapeutic advancement, ultimately benefiting the society. The guidelines presently only addresses the ethical use of de-identified samples that are non-identifiable and collected for clinical care only and for development of future products, technology or commercial purposes. They are not applicable for the use of leftover research samples since their secondary use must be aligned with the original informed consent given by the research participant. Ethical consideration while using the leftover samples in commercial use, the hospital must ensure that the samples are completely anonymous or de-identified irreversibly and are going to be discarded after clinical diagnostic care. Robust data security measures must be in place to protect any residual information associated with the samples. Companies should maintain transparent and open communication with the relevant institution and hospitals. Commercial kits and technologies that are prepared should be affordable, ensuring broader accessibility for patient and healthcare provider in the country. The rights of the donor, autonomy and about the informed consent guideline says patients own the biological samples and data collected and the institutions are the custodians acting on their behalf as per ICMR National Ethical Guidance 2017. Informed consent is required from the patients or from any secondary use of samples for research. However, if the clinical samples are anonymous or left over, they lose identity and there is no way for the institutions to go back to the patient to obtain informed consent for any secondary use. Therefore, the use of de-identified anonymous or leftover samples, use may be permitted with a waiver of informed consent. There would be no loss of patient's right or autonomy in such cases, as the leftover samples are de-identified and cannot be traced to the patient. The limitations, which includes, it may be noted that de-identified samples that contain clinical information could still become identifiable and therefore could lead to a breach in the confidentiality of the patient. If the samples are identified coded, can be reversible to identify the patient, and samples are not leftover, sample contain clinical personal information, or they are research sample, these guidelines will not be applicable. The role of the hospital in commercial use includes the de-identified and the leftover samples going to be discarded by the hospital can be provided by the hospital to commercial companies or for future commercial activity. Robust data protection and security measures should be in place to safeguard against de-identification. The hospital must sign appropriate MOUs or MTAs with the commercial company stating the plan, type of samples, defined duration and proposed outcomes, the quantity duration for which the sample will be stored, and any limitation on their use should be specified. Ethics role in commercial use. The ethics committee may determine if the proposed leftover samples were collected for clinical care and not for research, and the samples will be discarded by the hospital. Exists that the benefits of using leftover samples would outweigh the risk and privacy concern and would serve the public interest. The role of commercial company must adhere to their local, national and international regulations governing the collection, storage and secondary use of the biological samples. This includes obtaining necessary approvals such as ethical clearance, as well as establishing formal agreements such as MOUs, MOAs or MTAs. The company should contribute to scientific knowledge and medical advancements useful for mankind. The company must engage in good ethical practice, regular audits and handling procedures to maintain regulatory compliance. The companies must provide information on the intended use of the samples, declare the nature of product development and display transparent policies that indicate the source, handling purpose, financial interest and robust scientific methods, safety and destruction of samples when they complete the intended purpose. The companies must make the products, kits, others be easily accessible to the people in the country at affordable cost. Once all the guidelines are followed by the stakeholders, these de-identified samples can be used commercially by all for the benefit of humankind. Thank you, everyone.
Our next and the last presenter of the day is Dr. Ravi Singhal of GMC at Chandigarh.
Good evening, respected judges, seniors, and my dear friends. I, Dr. Ravi Singhal, PGJR, GMCS, Chandigarh. My topic is an unexpected gift on Doctor's Day from government. According to Section 106 of the Bharatiya Nyaya Sanhita, harsher penalties than its predecessor PC Section 304A have been introduced for causing death by negligence on recklessness not amounting to culpable homicide. For doctors, the increased penalties and explicit inclusion of medical negligence have raised concern about the potential impact on their practice and willingness to treat seriously ill patients. The aim of this article is to explain this section in detail and discuss the controversies surrounding both of its subsections. IPC Section 304A, causing death by negligence. Whoever causes the death of any person by doing any rash or negligent act not amounting to culpable homicide shall be punished with imprisonment of either description for a term which may extend to 2 years or with fine or with both. BNS Section 106, causing death by negligence. Whoever caused death of any person by doing any rash or negligent act not amounting to culpable homicide shall be punished
with imprisonment of either description for a term which may extend to 5 years and shall also be liable to fine. And if such act is done by a registered medical practitioner while performing medical procedure, he shall be punished with imprisonment of either description for a term which may extend to 2 years and shall also be liable to fine. 106 का subsection 2, however, cause death of any person by rush and negligent driving of vehicle not amounting to culpable homicide and without reporting it to be a police officer or a magistrate soon after a incident shall be punished with imprisonment of either description of a term which may extend to 10 years and shall also be liable to fine. For the purpose of the subsection, registered medical practitioner means a medical practitioner who possesses any medical qualification recognized under the National Medical Commission Act 2019 and whose name has been entered in the National Medical Register or a state medical register under that act. Difference: now there is a clear mention in a registered medical practitioner in section 106 BNS. Medical negligence as a rush and negligent act has been introduced for the first time for both RMPs, as that general offenders fine is in addition and to the punishment, whereas previously it was either fine or punishment. The previous provision under section 304A of the IPC was generic and did not specifically target medical professionals. The new law explicitly includes them, making a person substance mandatory in cases of medical negligence. The medical community is appreciative. The argue that involving physicians in a such strength laws could have a long-term impact on the medical profession, especially in terms of handling high-risk patients. Thank you.
Now I request Prof. S.K. Verma, President ICFMT, to felicitate the judges of the session. First, the judges for the e-poster presentation. Dr. Varun Modgil. Dr. Janesh Saini. Now the judges for the paper presentations, Dr. Preetinder Singh. Dr. Harvinder Singh Chabra. Thank you, sir. This comes, with this we come to an end of the scientific session for today. And now I hand over the mic to Dr. Ankita Dhul and Dr. Harshita for the valedictory. Thank you.
तुम अकेले कर लो या
ये दोनों से
करो
Good afternoon, one and all. We have now entered the final stage of 2 days extravaganza ICFMT 2024. I now request Director Professor S.K. Verma Sir, President ICFMT, Professor Jaswinder Singh Sir, General Secretary ICFMT, Professor Dasari Hari Sir, Organizing Chairperson, and Professor Amandeep Singh Sir, Organizing Secretary of this conference, to come on to the stage and please occupy their seats. Thank you, sir. I now welcome anyone from the audience who would like to comment or give inputs regarding the conference, including the academic activities, arrangements, food, etc. Sir, please.
यही बोल रहे सर दो ज़्यादा बोलना नहीं. So 2 days and lots of academic activities, unlike the usual conferences where we see strength of delegates coming down. Of course, yes, people have their own travel plans, but still I'm happy that till the last presentation there have been people who have presented enthusiastically, and the arrangements were wonderful. I'm sure everyone must be going back home a contented person, having received things as they expected from the conference. Thank you, sir, for the wonderful conference.
Thank you, sir.
Congratulations to Dr. Dasari Haris sir and his entire team, Dr. Amandeep sir and all the entire team for conducting a wonderful conference. The best part of the conference was this, the academic part, since it was all organized in this room only. So it was possible for every one of us to go through all the, unlike the other conferences where the number of presentations are really high, and the parallel sessions went on, they go on, and where it is obviously not possible for one to sit in and view all the presentations. Regarding ICFMT, I'm sure it will gain more popularity in the coming years, and more people will be coming and joining this ICFMT as life members. And with those words, I would like to conclude here. Thanks once again to the entire team of GMC Chandigarh, and all the best to the next organizers. Thank you all.
दो दिन बहुत अच्छे गुजरे, सेहत से भी और पेट से भी. सर के पास जब भी आओ हमेशा हंसते खसते पेट भर के जाओ वापस, दिल भर कर भी जाओ वापस. और आई थैंक यू सर फॉर सच अ हॉस्पिटैलिटी एंड अ नाइस प्रेजेंटेशन. नाइस our PGs, they present very good, and I wish for the conference. Sir, thank you.
Anyone from the junior faculty, junior residents, anyone who would like to say something?
The budding forensic experts.
Someone from PGI? Anyone from PGI? आ जाओ सर, आप ही आ जाओ. आप बड़े हो, छोटे को चाहिए हमें. आप छोटे चाहिए हमें.
I sincerely thank you, sir, for organizing such a wonderful 2-day fiesta for us. As young budding forensic medicine experts, getting everything at a single spot is very difficult, and when we have a lot of legends with us, they share their knowledge, we get something, even if we are not listening, to be very frank, sometimes we are not listening here and there, but we get something on the back of mind, we know that this is there, and after these 2 days fiesta of academic activities, as well as sir has mentioned that lots of foods and arrangement were also there. So I think this was a very good, very well organized 2-day conference, and we are very happy and we are very privileged to have such legends at the same platform, and in this age we are getting all these knowledge from the knowledgeable experts like yourself. So we really thank you for organizing such conferences for us. Thank you, sir.
GMC Haldwani, there were a number of people from GMC Haldwani. Anyone? आ जाओ यार, आ जाओ.
It was a nice conference overall. The food was good. Everything was good actually. The only thing which we thought could be better was the stay, if stays were provided. Everything else was very good. Thank you.
Thank you. I now invite the organizing chairperson, Professor Dasari Hari sir, to say a few words.
Good evening to everyone. At the outset, I would like to thank Professor S.K. Verma sir for giving us the opportunity. I did not know that we had this opportunity till Aman came back and told me that we are going to organize this. But this was, we organized and it went well thanks to my team of enthusiastic residents, demonstrators, EMOs, my faculty, and of course Dr. Amandeep Singh. Without Dr. Amandeep's help, this could not have happened, because he is the one who coordinates. Actually, he is the one who also runs my department. Whatever happens in the department, I have to ask him, because I am stuck up with a number of other administrative jobs, and usually the department updates I get from Dr. Amandeep Singh ki sir ye hua tha, ye aaya tha, ye ho raha hai. And some letters I get for myself as the HOD, and then we discuss and they are implemented again by Dr. Amandeep Singh mostly. So without his help, this one would not have happened, and the groundwork as usual has been done by my whole team of doctors, ministerial staff and attendants, and we have sort of got tuned to it. I mean, if you give us a conference and give us 1 week, we can do it. That is how much we have been tuned to these conferences, and my team of residents, they are also now completely tuned. So I hope this went well. If there are some inadvertent mistakes, then I take the responsibility for that. And like he said about accommodation, accommodation cannot be provided at this cost anywhere. 4,000 for junior residents and 6,000 for the faculty, and in that if you have to have one banquet, 2 lunches, 2 breakfasts, 2 teas, and this, I don't think we can, because we don't have any sponsors. Forensic medicine is one subject which doesn't have any sponsors, because we don't ask for much equipment, and there are no running costs for our equipment. The maximum you have is a CAMC which runs for 5 years and that too you don't get the proper thing. So the manufacturers, once they supply something to us, they are done with us, and they are not any more interested in this until and unless you buy something else new from them. So you don't have sponsors. What we do is the money that we get as registration amount, and that's it. So providing an accommodation, I don't think any conference nowadays provides accommodation. They just give a list of hotels and this. But we did try, because in Chandigarh we have 2 good bhavans. One is Gulati Bhavan and another is Sood Bhavan, which give us good air conditioned accommodation at 1,000 rupees per day per room. And that is why you are lucky. Otherwise you would also have had to shell out more money for that. Anyway, we have come to the conclusion of this, and we will meet again at AIIMS Raipur. Thank you one and all.
Thank you, sir. Now it is time to announce prize winners of all the presentations. I now request the dignitaries on the dais to give away the prizes for the winners.
So I'm starting with the offline presentations. So starting with the senior faculty prizes. Second prize goes to Dr. Arvind Kumar, UCMS, Delhi. First prize goes to Dr. Siddhartha Das, Jipmer. Now junior faculty paper presentation. Third prize goes to Dr. Nikhil Mehta, JMCA, Chandigarh. Second prize goes to Dr. Ankit Sharma, PGI. And first prize goes to Dr. Harvinder Singh, HIMS, Dehradun. Now junior faculty e-poster presentation prizes. Third prize goes to Dr. Sandeep Raju and Dr. Arpan Kumar Pan. Second prize goes to Dr. Rahul, GMCH Chandigarh. And first prize goes to Dr. Gagandeep Kalsi, GMCH Chandigarh. Now PG paper presentation prizes. Third prize goes to Dr. Abhishek Garg, GMCH Chandigarh. Third prize goes to again Dr. Padmaja, GMCH Chandigarh. One more third prize goes to Dr. Riya Mahajan. Second prize goes to Dr. Monica Sharma, GMCH Chandigarh. And second prize for Dr. Rajat Mandal. Mamsi Delhi. First prize goes to Dr. Ankita Dhul of GMCH Chandigarh. Coming to the e-poster presentation for the junior residents, the third prize goes to Dr. Arun Prasanna of GMCH Chandigarh. And also Dr. Riya Verma of KS Hegde Medical Academy, Mangalore. She's not here. The second prize goes to Dr. Manogana from Agra, SN Medical College, Agra. And second prize also goes to Dr. Sanchit Narang of GMCH Chandigarh. The first prize goes to Dr. Harshita of GMCH Chandigarh. Done. Thank you, sir. Congratulations to all the winners and the participants who've made the presentations really competitive. Without your enthusiastic participation, we would not have been able to organize these competitions. I now request Director Professor S.K. Verma, President ICFMT, to say a few words.
Dr. D. Harish, Professor and HOD of GMCH, Dr. Jaswinder, Professor and Head SRMS Bareilly and General Secretary of ICFMT, Dr. Amandeep, मेरे प्यारे मित्रों, भाइयों और बहनों, और नए जो साथी हमारे साथ जुड़ रहे हैं, उन सबको मेरा प्रणाम, नमन। जैसे कि मैंने कल भी बोला था कि ICFMT is conferences are known for the academic feast. Now I am confident and I can vouch on your behalf also that you must have felt that commitment of the ICFMT conferences for the academic extravaganza. I congratulate Dr. D. Harish, Amandeep, Dr. Nikhil, other members of the department, and the people standing behind me, the young faces of the department who has worked tirelessly. I know how the conferences are being managed because of my personal experience. It is not an easy task, it is a Herculean task. Because even if one guest comes to our house for a dinner, all family becomes a little bit apprehensive. And this is a 2 days activity where you have to have lot of logistics applied. You have to arrange starting from the chief guest to the last person who is serving you the good food, or the caterer, the lecture theatre staff, the decorations, and each and everything. It requires a lot of meticulous planning and implementation. The day we entered yesterday morning, when we have come to this premises, we have started having good vibes about the institution. The infrastructure in the institutions are excellent, I'll say. The academic environment was, everybody is feeling very happy. You see, it is very unlikely that on the second day at about 5 or 5:30, 6, still we have plenty of delegates, because in most of the conferences, valedictory, usually hardly 5 to 10 people you will find at the venue. But I'm glad that we have, especially the young people. I'm very, very fascinated by the young lot, because you are now the torch bearers of this particular fraternity of ours. We people, we had our innings now almost culminating or coming to an end. So we are feeling proud that the young people, the way you all has presented, you might not have got the prizes, that is irrelevant. Winning and losing is nothing. Participation is more important, and you people have participated in the activity. So you are all winners. See, whosoever has come over here everybody is a winner. Everybody deserves a big round of applause. Please you boost yourself so that you will come with better prepared next time, and I'm definite. उसी मंजिलें उसी को मिलती हैं जो अपनी कोशिशों में कभी कमी नहीं छोड़ते. किसी की कहावत है, एक पत्थर तो उछालो यारो, कौन कहता आकाश में छेद नहीं हो सकता. तो अगर आपने कोशिश करी तो जरूरी है. देखिए, डिफिकल्टी और प्रॉब्लम्स तो जीवन में सबके साथ चलती रहती हैं, और पतंग वही सबसे ऊपर जाती है जो हवा के अगेंस्ट चलती है. जो हवा के साथ बहती है वो पतंग कभी उड़ नहीं सकती. सो इफ यू आर वर्किंग अगेंस्ट द ऑड्स, आई नो आवर स्पेशलिटी इज नॉट एन इजी केक. We have to work lot of hardships. The working environment in most of the mortuaries across the country is not the optimum, I will say, but the things are improving, and I am definite. The days, I know 4 decades earlier when I started my career in 84, the things were much different, I will say, and now the things have. Now our fraternity has grown close to around 2,000 people, I suppose. And at that time we were hardly 200. So from 200 to 2000, it's a big jump, and the things are improving. Yesterday itself we have a good news that our the subject has been given the due. I will not say it is something that has been given to us as a donation. We deserve that. Our marks should have been equivalent to all other subjects, otherwise it diminishes the importance of this specialty. So with these words, hoping to see you soon next year at Raipur. Thank you very much.
Thank you, sir. I now request Professor Jaswinder Singh, General Secretary ICFMT, to say a few words.
Thank you. I have this feeling, why so early? इतना अच्छा शो चल रहा था, इतना मज़ा आ रहा था, और कल शुरू किया और आज जल्दी ख़त्म हो गया, है ना. तो all good things come to an end. So first of all, I would like to congratulate the organizers for such a big show, and on all parameters it is a successful program, and I congratulate the entire department. कल भी मैंने बोला कि हरीश सर, अमन सर फेसेस हैं इस कॉन्फ्रेंस के, बाद बहुत से लोग हैं, आप उनसे मिल भी चुके हो, उनको देखा भी आपने, तो सबको मैं बहुत बहुत बधाई देता हूँ इस कॉन्फ्रेंस की सक्सेस के लिए. एंड यू सी द स्माइलिंग फेस, बट यू डू नॉट नो, वो आपसे पहले उठ के पहुँच जाते हैं यहाँ पे, एंड दे टेक केयर ऑफ ऑल द थिंग्स. लॉजिस्टिक्स सही है या नहीं, खाने वाला टाइम पे है या नहीं, सर्टिफिकेट बन गए नहीं बन गए, एंड इट इज़ अ हरक्यूलियन टास्क. अगर इतना आसान होता तो एवरी ईयर यू वुड बी कॉम्पिटिंग कि नहीं मुझे करना है कॉन्फ्रेंस, एंड इसके उलट लोग भागते हैं कि नहीं, दे नो इट्स अ हरक्यूलियन टास्क. बहुत सारी, जैसे वर्मा सर ने भी स्ट्रेस दिया, इट्स अ ह्यूज टास्क. तो जो हमारा यंग लॉट है, जब आप आ जाओगे हमारे वाले लेवल पे, देन यू विल रियलाइज, एंड वी एनकरेज यू. हमारे ब्रांच की सबसे अच्छी बात ये है कि यू आर ग्रूम्ड 1-to-1. जितनी ग्रूमिंग हम यहाँ आपको देते हैं एज अ टीचर, मुझे नहीं लगता और किसी सब्जेक्ट में इतना क्लोजली आपको हम ग्रूम करते हैं. एंड वी विश यू ऑल द बेस्ट इन योर फ्यूचर कि आप एक अच्छे फॉरेंसिक एक्सपर्ट बनो, एंड यू टेक द टॉर्च फर्दर, राइट. बहुत से प्रेजेंटेशन थे, दे आर फ्यूचरिस्टिक इन देयर अप्रोच, फैकल्टी के भी एंड पीजीज के भी, एंड दैट वाज अ गुड थिंग, दैट इज वर्थ अप्रिशिएटिंग, है ना. तो योर टीचर्स आर वेरी इनकरेजिंग. यू मे बी गेटिंग सम ड्यूरिंग द प्रेजेंटेशन, थोड़ा सा आपको लगता होगा कि टीचर्स ने बोला इस चीज़ के लिए टोका, लेकिन दैट इज ऑलवेज फ्रॉम द एनकरेजिंग पॉइंट ऑफ व्यू टू टेक यू फर्दर, राइट. टू as a teacher, it is our effort to take you to the level of excellence, always pushing you, right. So with that intent, जो grooming forensic में आपकी हो रही है, मुझे नहीं लगता और किसी सब्जेक्ट में होती हो, and I encourage that you
attend the conferences regularly. Not only ICFMD, IFM, we have many bodies, wearing street bodies are there. वहाँ भी जाओ, attend करो, papers present करो, and you learn, right? So thank you all, and thank you team GMCH, and उनके साथ associate होके I would like to say कि उन्होंने लेवल को ऊंचा किया है, एंड एम्स रायपुर के लिए भी उन्होंने एक बार सेट किया है कि इतना अच्छा इन्होंने किया, तो दे हैव नाउ दे माइट बी फीलिंग द प्रेशर, बट एम्स इज अ बिग इंस्टीट्यूट, एंड आई विश ऑल द बेस्ट टू चवाली सर फॉर द एम्स रायपुर. थैंक यू.
Thank you, sir. I now request Prof. Dasari Harish sir and Prof. Amandeep Singh sir to felicitate the organizing committee members. So first, starting with the demonstrators of our department, Dr. Sarjana Singh. Dr. Arvind Kaur. Dr. Himanshu. Now the EMOs of our department, Dr. Vikas. And Dr. Snedeep Kaur. Now with the first years of our department, Dr. M.Y. Saivipul. Dr. Harshita. Dr. Ravi Singhal. Dr. Arun. Dr. Ankita Dul. Now second year residents, Dr. Ravi and Dr. Sahul Kumari. Dr. Sahul. Now third year residents, Dr. Padmaja. Dr. Monica Sharma. Dr. Sanchit Narang. Dr. Abhishek Garg. Now the post-PG demonstrator.
Now, of the post-PG demonstrators, we would like to honor Dr. Gagandeep Kalsi because she left our institute just 10 days back? 10 days back. And she is now ex-post-PG demonstrator. And she has been coming almost daily since 22nd to be with us and make this conference a success. So we would like to felicitate Dr. Gagandeep Kalsi first, and then we will felicitate Rahul.
Dr. Rahul.
Next, Dr. Nikhil Mehta, sir, Assistant Professor of our department and Treasurer of this conference. Next, Dr. Shikha Gupta, ma'am, Assistant Professor of our department and Head of Scientific Committee of this conference. Thank you, sirs. With this, we come to an end of the ICFM.
तुम्हें तो दिया था मैंने अपना यहाँ खड़े खड़े कैसे फोन कर सकते हो? अरे ये वही बोल रही
Now I request Professor Amandeep Singh sir to propose the vote of thanks.
President ICFMT, Director Professor S.K. Verma sir, Secretary ICFMT Professor Jaswinder sir, seniors, delegates, my friends, students, thank you for being with us, bearing with all the shortcomings, and I hope you enjoyed and you will wish to again visit our institute, be with us in next conference we organize. Thank you very much for this. Thank you to organizing committee. Thank you to all the helping persons here. Thank you to Mr. Gupteshwar for covering this in late evenings. Thank you very much. Thank you.
Now, if you could all come onto the dais, we will have a group photograph, please.